All right, good morning, everyone. Welcome to our Thursday, March 14th public hearing. We have a good amount of folks here with us today, so we want to get right in. But first, I'll turn over to my good ranking member, Senator Seminara. Do you have any opening remarks?
Not too many this morning. Good morning, everybody. Looking forward to hearing everyone's testimony. Thank you so much.
Great. And without further ado, Commissioner Barton Reeves and your DSS team, please come on forward.
We are going to soon refer to you as the squad.
My goodness. Well, good morning. Good morning, Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services Committee. My name is Andrea Barton Reeves, and I am the Commissioner of the Department of Social Services. I'm pleased to appear before you today to offer remarks on several bills on today's agenda. The first is Senate Bill 313, an act concerning continuous Medicaid eligibility for children under the age of 6. This bill would require the department to provide continuous eligibility for the Medicaid program to any child under the age of 6 who has been determined eligible for the program until the child reaches the age of 6, starting on July 1, 2024. In general, federal laws require Medicaid eligibility review every 12 months, and effective January 1 of 2024, all states, including Connecticut, have been required to provide 12 months of continuous eligibility to children under the age of 19, and we have implemented that federal requirement. There are other states, however, notably Oregon, Washington, and New Mexico, who have obtained federal approval for demonstration waivers under Section 1115 of the Social Security Act that would allow for multi-year continuous eligibility. We do appreciate the positive aspects of this proposal, including including providing stability and assurance of coverage for families participating in the program. Our only concern here is the cost. So the costs are projected to be at $13.1 million, which is 6.5 state share in the first year, but over $111.8 million, which is about 55 or 56 million state share when fully annualized. This funding is not included in the governor's budget. We would also need to pursue an 1115 waiver, and that does require some time and resources that are not currently available within the department's current resources. And due to the federally required steps in the waiver, it would take a minimum of about a year for approval to occur for us to be able to offer that, in addition to resources that we would need in terms of staff and money. So for the reasons right now, we cannot support the bill, but if we are certainly open to more discussion as to how we might pursue this. Continuing with Senate Bill 364, an act concerning supplemental nutrition assistance. This bill would require the Department of Social Services to stagger the distribution of SNAP benefits so that benefits are distributed in 4 intervals a month beginning in January of 2025. Federal law does allow states to stagger instances throughout the month, and they do not allow for more than 40 days to elapse between the issuance of any 2 allotments. Nationally, the issuance schedule of SNAP benefits varies from state to state. Were DSS to implement such a change, we anticipate that it would require significant systems changes to implement a newly developed distribution schedule. And that cost we estimate to be about $500,000. That's very different, which is currently unbudgeted. We also think it's important to engage in stakeholder engagement. We would have to let all of our SNAP families know that there would be a change. Our families that we support are often budgeting their benefits based on a specific schedule as to when those benefits come due, and we would need some resources in order to have a fully implemented campaign to let them know of the change. And we do estimate that that would be an additional $500,000. For a total cost of $1 million for the successful implementation of the staggered benefit. Section 2 would require DSS to develop and implement a plan to participate in the federal restaurant meal program. This is in fact a state option that allows households where members are homeless, older adults age 60 and over, or the disabled to use their SNAP benefits to purchase prepared meals with their SNAP card. Restaurants have to agree to this program, and they have to agree to offer low-cost or discount meals for breakfast, lunch, and dinner during their regular business hours. In addition, these restaurants cannot charge a service gratuity or sales tax. There are 9 states right now that do operate what we call the RMP on an extremely limited basis. Rhode Island is the closest, and that has an RMP that it has since 2011, but only 9 Subway restaurants in 2 counties have chosen to participate. Arizona has a much more expansive program, one of the largest, where there are approximately 730 participating restaurants, 586 of which would be considered fast food restaurants. So in order to operate the program in our state, we would have to have something that is known as an EBT-based solution, the cards that we usually use now for SNAP. The restaurant would have to agree to participate. The recipients who are permitted to redeem the benefits at the restaurants must be identified within our EBT system in order to limit the participation to eligible SNAP benefits. In addition to that, we do have some federal oversight rules that we must follow, and that includes following the rigorously federally required oversight, monitoring, and reporting requirements, which right now we don't have the resources within our agency to fill because we're using all the resources we have to administer SNAP as it is. And I will stop for a moment. I have my testimony here, as you can tell, but we recently received a report from FNS, which is the federal agency that oversees our SNAP program. We're happy to share this letter. We received an outstanding report in the manner in which we administer SNAP, but there was also an acknowledgement in that letter that we are doing so with significant understaffing in SNAP. But we did manage to get excellent results even so. So if we were to add, we would need more resources to do this. So in addition to what I had just noted, the state would incur significant costs that are associated with modifying the program, our impact eligibility system that would allow us to identify eligible participants, modifying the EBT vendor contract and the system, developing a system to monitor the transactions and a system to monitor restaurant compliance. In addition, as I just mentioned, are having dedicated DSS full-time staff, but that's what it would require to administer the program. Altogether, we think this would cost about $1.2 million. These funds are not currently in the budget, in the governor's recommended budget. House Bill 5426, an act concerning fuel vendor reimbursement under the Low Income Home Energy Assistance Program, LIHEAP. This program proposes to make changes to the way in which deliverable fuel vendors are paid and program benefits are established under SEEP, which is the Connecticut Energy Assistance Program, and study the benefits and drawbacks of bulk purchases of deliverable fuel, and finally to convene a working group to study best practices in other states to fairly compensate deliverable fuel vendors in energy assistance programs, and finally to develop a common application and benefits portable for LIHEAP and Operation Fuel. The first proposed change in this bill would require DSS to ensure adequate supplies of vendors for the program by establishing new pricing standards for deliverable fuel that fairly compensates vendors for costs incurred in the fuel purchase and delivery in the LIHEAP program. We do appreciate the importance of our deliverable fuel vendors in administering a very successful program. The department notes that there are 249 vendors who are currently participating in LIHEAP, and there have been no major variations in vendor participation levels over the last 3 years. Of note, a large majority of our vendors have also expressed an interest in enrolling new customers. So we do believe that that we are already ensuring an adequate supply of vendors in LIHEAP in accordance with existing statutory requirements. What's most important to note here is that the department, under its federal grant, receives a fixed amount of funding annually to administer the program and to administer those benefits to residents. Any change in the pricing standard for deliverable fuel, increasing the compensation to fuel vendors, would directly reduce the benefit levels for recipients of the program. With regards to the proposal to study the benefits and drawbacks of bulk state purchases of fuel, the department observes that in the 1990s, this had already been considered, and it was considered to not be a highly viable program. In addition, a review by the federal LIHEAP program administering agency in 1997 drew a similar conclusion, in part reading, none of the states operate a bulk purchase program. Several oil industry analysts have suggested the bulk fuel programs would not have produced significant savings beyond the 15 cent per gallon savings at that time. found in margin over programs and would create major management problems for traditionally thin-staffed LIHEAP offices. So while the criticism here might be that this is a study from 1997, unfortunately, this has not changed. The LIHEAP program in our office is still very thinly staffed, and there are states that are not, most states are not operating a bulk purchase program. And in our written testimony, we do have a link to the study that we cite. So with regards to the directive to design a common application for the LIHEAP benefits and Operation Fuel, we respectfully note that we have just concluded the implementation of an online application for LIHEAP that was incorporated for extensive client and stakeholder participation during its development, and it was expressly designed for ease of use. So while, of course, we are open to redirecting applicants who are ineligible for LIHEAP benefits to Operation Fuel, we do have concerns about requiring a private entity to be bound to a state-developed system, which would require their consent and ongoing participation. So at a minimum, it would require a substantially longer time period to implement this program and the proposal in this bill other than beyond the October 1, 2024 date. And it would require resources and funding not currently contemplated in the governor's budget. Moving on to Senate Bill 397, an act expanding Medicaid coverage for school-based healthcare. We do support the broad intent behind this bill to maximize federal Medicaid funding to support school districts in providing necessary health services to their students. But we cannot support the bill because of its significant unbudgeted costs, its administrative complexities, and its revenue loss to the state. We do welcome ongoing analysis and conversation with the State Department of Education and school districts and other stakeholders to explore ways to increase federal Medicaid claiming for health services provided by students who are eligible for Medicaid. There's quite a bit regarding that particular bill that is in our written testimony, but I will spare you my reading all of that. And I will move on to Senate Bill 365. An act concerning safety in the healthcare workforce. This bill aims to improve safety in the healthcare workforce by promoting the implementation of workplace violence prevention standards in hospitals and health and safety training for home health and other healthcare settings. We are currently engaging and working with our healthcare providers in our role as a state agency charged with administering the Medicaid program and Children's Health Insurance Programs, which is known as CHIP. But DPH is the agency that is primarily responsible for regulating healthcare providers, especially in the categories of healthcare providers referenced in this bill. As such, we respectfully suggest that DPH is in a better position to impose these requirements. The fiscal projections for FY 2025 at a 1% increase in fees paid to home health agencies would result in an overall cost of over $2 million annually. And because these costs are not included in the governor's budget proposal as it stands, we are unable to support the bill because of its fiscal impact. In Senate Bill 396, an act implementing a task force recommendations for the elderly nutrition program. This specifically Section 4B requires DSS in consultation with the Commissioner of Aging and Disability Services to develop a plan to maximize SNAP benefits to support the elder nutrition program. We do very much support this interest, and we appreciate the committee's interest in maximizing the use of SNAP to support the elder nutrition program. We do, however, respectfully suggest that the Department of Aging and Disability Services is better positioned to be the lead agency on this initiative. And as we are literally in the same building, we are positioned to continue to be in partnership and support with ADS as the lead agency should you decide to move in that direction. Next is Senate Bill 395, an act concerning Medicaid budgeting methods and the reporting of medical debt. This bill, Section 3 specifically, would allow DSS to reduce or withhold Medicaid funding for any healthcare provider enrolled in Medicaid that violates Sections 1 and 2, which restricts certain healthcare providers from reporting medical debt to credit rating agencies. We do appreciate the overall goal and intent of this bill to help protect healthcare consumers from facing financial challenges related to negative credit reports as a result of medical debt. But it is inappropriate for us as an agency to be the agency in the position of enforcing these new proposed requirements. So in lieu of the current language in 3, if the bill goes forward, we would recommend a proposal that does not include Medicaid payments and have any relation to our relationship, our role as a payer, as probably more appropriate for consideration. And so for those reasons, at this time, we are asking for a respectful reconsideration of the bill as drafted. Moving on to House Bill 5454, an act concerning mental health services for young children and their caregivers. So this bill would require in consultation with the Office of Early Childhood and the Department of Children and Families and DMIS of the Department of Mental Health and Addiction Services to prepare a strategic plan and report on maximizing federal and state resources for mental health for services for children under 6, their caregivers, and pregnant persons. We, again, as related to our earlier bill, the early bill that was proposed, we do appreciate the intent of this bill to implement upstream behavioral health services for children and their caregivers. We also support the bill's approach to analyze the options available. We are unable, however, to expand because of our fiscal and administrative constraints. We are unable to expand the services using new state funds for services at this time, but we do welcome collaboration with OEC, DCF, and DMIS, and particularly DCF as the state's lead agency for behavioral health to develop a plan that considers the mental health needs of children under 6. We do ask respectfully if you would move the delivery of this plan from October 1, 2024 to March 1, 2025. There are a number of task force reports and studies that are actually due on October 1. So we have actually plotted them out, and we're asking for a little more grace in some of these so that we can get them to you on time and with the quality that we know you deserve from us. Speaking now to House Bill 5458, an act concerning homelessness. Should the bill move forward, we would ask for several technical changes. First, with respect to Section 1A, to define CHESS in a manner that does not, I'm sorry, let me read it a different way. Section 1A currently as drafted defines CHESS in a manner that does not completely align with the federal approval. What we would recommend here is that the language be streamlined to replace language in subdivisions 1, 2, and 3 so that it does align with the federal definition of CHESS, and we can offer some specific wording with respect to that. Again, here we are also asking if we can have the date for the report moved from October 1 to March 1 of 2025 to give us sufficient time to carefully consider the topic, considering the other reports that we have not. Of course, we always mention our rate study, which is quite an endeavor in and of itself. Finally, I will speak to House Bill 5457, which is an act concerning nursing homes implementing a nursing home waitlist. And this is very short. We support the bill as it would require waitlists to be in electronic form, nursing homes to provide access to the department and the state ombudsman for investigative purposes, and to modernize communications with families and applicants in the form of email or letter regarding the placement of a person's name on a wait list. We believe this supports more transparency and accountability, and we are in support of that, and we urge passage of the bill. And with that, I thank you for your time, and I, with our team, are here to answer any questions you might have. Thank you.
We might have a couple.
I imagine so.
Thank you so much, Commissioner. It is good to see you once again. This is our last scheduled regular public hearing. I think we're going to have a joint hearing on Tuesday with appropriations, but this is our last regular hearing of the Human Services Committee. So we've put you through the ringer this year and want to thank you for spending a lot of time with us. And of course, we'll be having further conversations after today as well. But thank you for that. And thank you for ending on a high note, a positive note, testifying in support rarely of one of our bills. So thank you for that.
We heard you. We reordered things. We thought it would be better. Yes.
Leaves us with a smile on our face.
Yes,
yeah.
Exactly.
Just going through just in the order that you went through, that would be helpful.
Certainly.
Senate Bill 313, the continuous Medicaid eligibility for children under the age of 6.
Yeah.
That's a big fiscal note. It sounds like good policy. Other states have found a way to do this. But I guess my thought was, one, this hasn't, it's something that as you pointed out, Washington and New Mexico and Oregon have already done, and other states have pending requests to do. So do you know how they've been able to afford it? And, why is the fiscal note so high? I thought that the major barrier was churn.
Mm-hmm.
And if the main issue we're dealing with is churn, how could that possibly be? How did you arrive at a number that's so prohibitive?
Yeah, so our Medicaid director is not here today, so I will be doing my best to answer the questions that you
Okay.
have. We actually had been exploring this option before to continue to expand Medicaid because we believe that when children get the best care, they actually grow up and to be healthy and productive citizens. So I can bring back for you, Senator Lesser, some of the really detailed work that we've done to come to this number. It has to do with the number of children that we believe are under the age of 6 right now. We've looked at some population data. We've actually done quite a bit of digging around this because we were really interested to see how other states have done it. I know that our Medicaid director, Guy Woolston, has spoken to the other states. I'm not privy right now to the information that he's gathered from them as to how he's done it. I think that some states have done some private and public partnership to at least get started until the state could figure out how we could fit that money into its state budget over the biennium. Some of them have done some really creative work with their 1115 waivers to figure out ways in which they can afford it. Some of them have bundled it with other kinds of waiver supports under housing and food and nutrition. So it was sort of a bigger social determinants of health waiver. There have been lots of different ways that other states have done this. We really have tried to hone in specifically on children because specifically, we're seeing that there is a trend, and we believe this, that children really need more support, and we can see it in some of the bills that you've proposed around mental health services. We see it with the urgent care centers that children, we see that are now open, that DCF is primarily in charge of oversight. And we are seeing, particularly with our partners at CCMC, a rise in the need for children, especially with behavioral health needs, to just needs more support. So we're trying to respond to that from a policy perspective, but I can get you more details as to where we are and how we came to the number.
And you know, my sense though was that our children's uninsured rate should be very low, right? We have CHIP program, we have a number of programs designed to ensure universal or close to universal insurance coverage for kids in the state.
Right.
So when I see a annualized $55.9 million cost for providing continuous enrollment, the only folks I could imagine who are not covered are, you know, are kids caught up in churn where their parent moves and forgets to update the form or something along those lines.
Yeah.
So it's like that's why I'm struggling to understand how
Hmm.
you could get a number remotely that large, or maybe I'm misunderstanding what
Mhm.
we're trying to do here. Is that,
Okay.
is that,
All right. And here comes DC Hadler. Yes.
Oh, great.
I'm gonna.
hey,
I was
came
going
in
to
at
start
just the
by
right
saying
time.
that yes, we'll
so-
go ahead, DC,
yeah, so
because
could,
it's really the number of children between 3 and 6, but go ahead, DC.
Thank you, Commissioner, and thank you, Senator Lesser. It's a great point. I think one of the things is that it would simply expand enrollment. I think that's what other states have found as well. Someone could have a change in income, for example, that now would make them ineligible during this period, but under the continuous eligibility, they would continue to maintain coverage. I just was looking last night at Oregon's waiver. They were estimating about $80 million a year in state share for their program. So I think that they have actually, they have identified that as a priority and put money into it, but the dollars at stake for doing these expansions can be fairly significant.
Okay. So the major, so is the major population are folks who have lost eligibility due to income changes?
That's highly likely. Again, as you point out, churn normally is a process where somebody who is eligible and continues to be eligible closes for one reason or another and then comes back into the program. That would certainly be alleviated by continuous eligibility. But there are other reasons why a person might no longer be eligible for Medicaid, but under continuous eligibility, they would stay on. The exceptions to that are folks who move out of state, or if a child passes away, or if they request closure. Then those are sort of the exceptions to continuous eligibility. But other changes during that time period would not affect their eligibility, including increases in income.
So I know Director Wilson's not here to defend himself, and he's a smart fellow, and I think we're normally we are very deferential to the department on understanding fiscal notes, but
Sure.
My source of skepticism is that we've just done so much to expand coverage for this population, at least in theory. I just don't understand how what I see as like a pretty small administrative tweak could
Mhm.
lead to fiscal note anywhere near that high, but I'm sure there's something I'm not seeing.
Okay.
I'm just not sure how we could get there. So any supporting documentation would be helpful because, this should be an administrative thing, not a coverage expansion, if that's, at least in my mind. Maybe, I mean, I understand it's a coverage expansion,
It
but not,
is.
but I would think it would not be a major coverage expansion, but it seems like it might be here based on the fiscal.
Yes, it might be. I think it might be surprising, Senator, the number of children that it covers. So we will bring that to you.
Okay,
Yes.
great, thank you.
Okay.
Moving on to the SNAP bill. Appreciate the testimony. Thank you, DC Hadler. We may call you back in a
He
second.
may be back in just a moment.
Don't go too far away.
Yeah.
Just with regard to the restaurant meals option, I would just ask the department, take a look. I know that Rhode Island has a limited version of it, but what came to our attention that got our interest was actually Massachusetts's implementation. I think they were particularly looking at food deserts,
Yes.
and culturally appropriate meals for immigrant populations and some others. So they have some interesting non-fast food based options that exist in Massachusetts. And I know that some states have implemented it in other ways that may not be superly well. I'm trying to be charitable, but may not be the best result in the best policy outcomes.
Understood.
But maybe Massachusetts could be a good example. And can you just sort of elaborate on what you would need to implement, or at least not implement, to design a
Yes.
program along the lines of
Yes.
that?
Yeah, so as we outlined, just to make sure that I have all the bullet points, we would need to modify our impact system, which is the system that we use to determine eligibility. So there would be an IT cost associated with that. We would also have to modify our contract with what we call our EBT vendor, which is essentially the vendor that issues the cards that people use to access their SNAP benefits. So the contract would have to be modified, and then systems changes would have to be made in order to make sure that people who are qualified and eligible have the ability to use the card. We would be required by the federal government to track and monitor that use, not just by those that are eligible, but also the restaurants, and we would have to have a system to monitor restaurant compliance. So essentially, these are the four primary things we would have to do. We don't, as I mentioned, our SNAP team is already understaffed. We really wouldn't have the ability to implement this within our current resources, but those are the four primary things we need to do to make this possible.
And I'd say read the bill. It's more of us asking you to study it and sort of design what that program
That's
is rather
right.
than implement it.
That's
I
right.
understand that would definitely have additional resources.
Yes,
And congratulations to your SNAP team on winning that award.
thank you. Dan, national expert in SNAP
Fantastic.
here in Connecticut. Yes.
And then with regards to the heating assistance bill, the part that sort of encourages coordination, the common application and better coordination between the Connecticut Energy Assistance Program and Operation Fuel. We think we understand that Operation Fuel is a private entity. I think they're in the room and we'll be hearing from them in a little bit. One, I want to commend DSS for its work on improving the application process. I've heard nothing but positive news from residents, from community action agencies about how much smoother things are working now than they were before, just in terms of the application process. But one of the things that I continuously hear from constituents is just confusion between the two programs. And that's why sort of better integrating them, perhaps on a voluntary basis with Operation Fuel, I think could only help constituents access the benefits that they're entitled to. So in terms of the contract, I don't know what's involved on your side to make further tweaks to the application, because I know you just went through this. Is this something, what are the obstacles to that? Are there ways that going forward, as you make improvements to your application system, is that something that you could do to integrate an Operation Fuel application in the process?
Well, Senator, if I could respectfully disagree on just the premise of the integration, I think we still feel very strongly about the testimony that we presented, that the that integrating Operation Fuel or any private entity for that matter, we don't do this for our community action agencies either, right? They have an opportunity to work on the system that we built for them, really might not be the solution that we're looking for here. What could probably be more effective is really raising up the difference publicly between Operation Fuel and LIHEAP. So it might be worth it to have a more robust campaign so that people can really understand what the differences are. We can do that on our website. We can do that on Operation Fuel's website. We can do it through mailings. There are lots of different ways that we can continuously educate people on the differences between them. The integration isn't necessarily going to get to this idea of people being confused about where to go. And I did have an opportunity to read Operation Fuel's testimony, and apparently they feel the same way, that integration is not necessarily the approach that we would use to help address what we think is the fundamental issue, is that there is a state option to be able to get fuel assistance. Obviously, I'm stating the obvious, and then there's the private option with Operation Fuel. We don't even have, with respect, let me just say it a little bit differently. With the exception of the latest round of LIHEAP funding, there is no contractual relationship between the state and Operation Fuel. We believe that and it says in their testimony, they would prefer to operate very independently. We think actually that's better for them. We do think it could cause more confusion if there is some kind of integration, because families will still think that Operation Fuel is the state is Operation Fuel, if it's all one application, and it doesn't necessarily get to the heart of what the challenge is. So perhaps if we had some resources where we could do some sort of education and then see what the outcome of that is, and then we could revisit some other kind of solution.
With respect, Commissioner, I don't agree.
I understand.
And for one thing, the state is intimately involved in Operation Fuel. We have for years, not in addition to providing occasional appropriations, we have supported them by directing fines assessed by PURA to fund their operations. There are members of the Low Income Energy Advisory Board. We have, they are a nonprofit, but they are, along the lines of many of the other nonprofits the state supports, they are, fulfilling, they have their own board and they set their own eligibility, but they have certainly been integrated in many ways with this as part of the state's support for low-income residents looking for assistance with heating and and other functions. And I get that they are not funded in the same mechanism, and there is a separate program than LIHEAP, and I'm not proposing that we merge them into a common program, but at a time when we are experiencing decreased federal support at a time of increased demand, it seems to me that coordinating the scarce dollars that we have available better could only benefit the residents. And I know that previously Operation Fuel had a process, had a system in place to require residents to first apply for and exhaust any CEAP benefits before applying for Operation Fuel. I don't think they do that anymore, and I'll let them opine about whether or not that's a good policy or bad. Like that, I trust their judgment on that. But making sure that we can better stretch scarce resources by at least having the two programs talk to one another seems like it would be a net benefit. I would also say I think public education is great, but I have heard countless examples of constituents who are just confused by the two programs. I've also heard from legislators who are confused about the two programs. When Operation Fuel announced this fall that they were halting new applications, as they are again, I think tomorrow, that got a lot of press, a lot of coverage. And I think I heard from people firsthand, including members of this body, who were under the impression that LIHEAP had stopped taking applications. And we can educate people, but I also think we can probably do more to make sure that residents aren't experiencing we can implement a no wrong door policy where you can access both programs potentially even if they are administratively separate. So that's why I'm sort of pushing on this issue. I suspect we'll hear from the action agencies and Operation Fuel as well to talk about it. But I guess what I would be really interested from you is just on the administrative question about potential barriers to this, given that you just upgraded the website. Is that something, you have the one front end, but in terms of opening up the back end to other players, are there obstacles to that, or is that something that we could potentially address with appropriation?
Well, there's definitely a significant administrative list because it would mean that we would have to allow access to lots of data that we have from people who are applying to LIHEAP to Operation Fuel. So we do have some concerns about that because when people apply for the state benefit, I think there is an expectation of privacy with respect to how we use that data. So they would absolutely have to either opt in or opt out with respect to that, and that's challenging across the board for us just generally at DSS. We're often asked for our data on the people that we serve for other purposes, but and you can describe it as, depending who sits in the seat, as maternalistic or paternalistic, but we really are very protective of the data that we have because it's very private and personal. So that is the one. And I think, Senator, the other piece is that we were just a little confused about how it would help with the issue of the confusion. So now if people are coming into our website and they see that they can apply to Operation Fuel or to LIHEAP, I think it would still have people confused as to whether or not the programs are the same or they're different. I know you're asking with the administrative, and I'm actually going to ask DC Hadler to come back up, but that's part of the challenge we have now as well.
Well, while DC Hadler is sitting down, I'll just quickly respond. I would say, if you could find out, hey, I'm entitled sort of quickly to X dollars of support from Community Action Agency under the LIHEAP program, and I'm at, Y dollars of support under Operation Fuel, or I'm not entitled to any under this program, but I am under the other program because they have different, they serve different purposes. They have different, it could only, I just think having the side by side would be really helpful, so you could actually find out where you're eligible for support and where you're not, if that's a way to do it. I don't know if that's a way to.
We certainly could do it that way, Senator. Again, we could upgrade our website so that we could have a more prominent display of what we do and what Operation Fuel does, how we partner, what the standards are, how you can determine your putative eligibility for LIHEAP and your putative eligibility for Operation Fuel. We're happy to have more information so that people can make decisions. I think it's the actual integration of the application that I think would cause an enormous amount of confusion and maybe have the opposite effect of what we're trying to solve for. But please go ahead.
Yeah, thank you, Commissioner. I think we do foresee potential contractual operational challenges. If funding changes or, Operation Fuel can only handle a certain, timeline of applications, whereas we'll be open longer, and that could create confusion and about, where you can go. I think we'd be happy to continue to work on informing people about, alternative options. I will say there already is a lot of work that happens sort of behind the scenes. So when people are going through the energy assistance application, referrals are being made to Operation Fuel if they're not eligible for energy assistance or if they've exhausted benefits and Operation Fuel is still open. So I think, our community action agency partners work very closely with Operation Fuel. They're, everyone is fully aware of what they can offer, and they are able to help guide people in that sense. We do have quite a bit of information up right now on the Heating Help website that does also identify Operation Fuel, but there are probably opportunities for us to draw a clearer line as to when you might want to go through one door versus the other. I think the reality is we also overlap a lot, right? I mean, people who are eligible for SEEP will often be eligible for Operation Fuel. And I think we would encourage that we go through the SEEP process as the first line, often because has more benefits that can be offered, especially for deliverable fuel households. You can get a much higher benefit than what is traditionally offered from Operation Fuel. And just also, the sense is that the challenges of scale, right? It's about 20 times the funding and enrollment in SEEP as compared to Operation Fuel. So there's they're a very important partner, and we're happy to keep working with them. We certainly talk all the time, and are happy to continue to do that and figure out ways we can make clearer where people are and what the status is of the two different programs.
I totally agree with the last few things you said, and you know, certainly there are barriers to having that direction when they're two totally different enrollment processes. They don't talk to one another. There's no coordination. So I think I think it would make sense to encourage people or nudge people to apply to CEAP first, and then use Operation Fuel to supplement what isn't, you know, whether you have eligibility issues or you need additional funding beyond that. But there was no mechanism to do that at present. So that's, I think, I'm not saying we need to have a hard, you know, you must do CEAP first, but if the two applications if the applications were more integrated, I don't know, I'm beating a dead horse, but I do think that we could at least have that conversation, sort of figure out how best to stretch scarce resources. Can I move on? Because
Certainly.
we got a lot of more bills, and I
Certainly.
suspect that some of our members have questions as well.
Sure.
NEMT, one question that sort of not in this bill, but sort of relates to the wheelchair bill that we heard earlier, was about whether or not NEMT could be used to provide, this was a recommendation from the Wheelchair Task Force,
Yes.
whether or not NEMT could be used to provide transportation for wheelchair users to a service location. Is that something that we're allowed to do under federal law? Are there restrictions on whether or not we can do that or not?
I don't believe there are any restrictions. I believe Senator Seminara had questions about this the last time that I and my team appeared before you. There are some liability concerns that some of the providers have raised because the transportation for those that have their wheelchairs and for the member themselves are things that aren't necessarily covered under NEMT with our current contract and also, you know, the current structure of the program. So I did promise, and I will come back with some suggestions as to how we can support those that need their wheelchairs, just not for repair, but obviously for transportation. So we've committed to that, and we will come back with some options, including speaking to other states to see how they're managing it as well.
Thank you. So with regard to school-based health center, school-based healthcare, because
Yes.
that's a big enchilada.
It is.
You know, one, I think the top line is that the U.S. Secretary of Education who has a interest in Connecticut, has been concerned that we are not pulling in our fair share of federal funding for Medicaid for school-based health services, including special ed, but also non-special ed services provided by school nurses and whatnot. So looking at your testimony, because you submitted a lot of testimony with regard to the school nurse piece,
Mhm.
we did do a bill last year to allow billing by school-based health centers, but school nurses are not currently allowed to bill for Medicaid currently.
No, they are not.
Is there any reason why we shouldn't allow them to do that?
Well, I will ask Nicole Godburn
Yeah.
to come in and join us, but there's not a specific reason at this moment, right? So it's not like it's barred under federal law. We have categories of care providers, obviously, that are covered under Medicaid. School nurses have not been one of them. We've not actually explored that.
Mhm.
But we also know that every time we expand Medicaid, there's a significant fiscal cost that's associated with that. So we can, as I think we said at the end of our testimony, we're certainly willing to continue to explore it, but no, there isn't a reason right now. But it also, go ahead, Nicole. Sorry to see you.
No, thank you, Commissioner. I think the Commissioner captured it well.
I know who you are, but could you just say
Oh,
who
sure.
you
My
are?
apologies. Sorry. Nicole Godburn, Director of Reimbursement and Certificate of Need. I think we would just need to explore a little bit more the definition of school nurse, what type of services would be built in underneath that, and then what our current claiming process is for those services is typically done on the school district level. The school has to capture that through a random moment time study. That information has to get rolled up to it. We claim through a certified public expenditure. It's kind of a little bit of a complicated process. So we just need to understand those definitions a bit better so we can go through and ensure that we're capturing everything correctly, working with CMS, making sure that the federal match is captured correctly. So administratively, it's a little bit of work for us to do. So we would just need some time to explore and understand that.
And I understand, I think we've had some sidebars on this, but that there's a federal capacity grant that currently states are eligible to apply for that may have been due like this week or something. Do you know, is DSS applying for that funding or?
No, we were not applying for that funding. There was a federal capacity grant. You're absolutely correct. And we just did not have the capacity to apply for that grant and many of the other grants that we have outstanding right now.
We should have a capacity grant.
We need them. Yes, we do. It is the same people doing all of the work.
Well, boo. All right. One of the issues that I know other states are wrestling, trying to figure out why we're not bringing in as much funding. We were sort of asking this question: so what can we do to bring in more funding? And came up with a couple of different questions. So one is a requirement, I think, in the federal rules, I guess, without a waiver, that a parent has to consent before a kid can get Medicaid funding, even if the kid is in the Medicaid program. And I didn't know if so one of the parts of the bill is sort of pushing DSS to apply for a waiver to expand that, either by potentially looking at free and reduced lunch eligibility or some other capacity, just to try to make it easier to opt into the program. Is that something the department has looked at or has opinions on?
No, we have not had an opportunity. We're aware of that, but we've not had an opportunity to explore it more fully right now. But we're happy to do that and bring back more information.
And the other is sort of a bigger conversation with your agency and also the Office of Policy and Management, which is when this program was first, when billing for special education services was first contemplated or allowed by under the Malloy administration, I think in 2014, the state, I suspect, I was not focused on that at the time, but the state has directed half of the reimbursed funds to the general funds.
That's correct.
And so when I've spoken to school superintendents and other folks on the ground, the real about why they don't submit for reimbursements, the thing that I keep hearing is that because it's only a 50% Medicaid match and then 50% goes to the state, they're only getting a 25% match on eligible billing services. And so frequently it's not worth the school district's time. And so as a result, billing is surprisingly low in this area. I know a lot of it's subcontracted out, but that seems to be a barrier. So whether it's 80-20 as this bill contemplates or 50-50 as it is right now, my question that I actually posed yesterday to OPM, but I sort of want to engage you all on is, could we have a situation where we reduce the percentage that the general fund keeps in a way that's revenue positive, right? If we can encourage school districts to do more of this billing, that will help the state fiscally. But right now, one of the barriers is they're extremely low. It seems to be they're extremely low reimbursement rates. So I don't know if you have thoughts on that. I don't know how we land at a number that works for the folks who are trying to maximize revenue for the general fund. From my perspective, this is money that the school district should be entitled to. These are eligible federal reimbursable Medicaid costs. It seems a little weird that the state is profiting off of that, but I understand the sensitivity to the general fund. So I don't know if there's a way we can arrive at a place that works for everyone.
So thank you, Senator. I don't know the answer to that question. I think the structure or the process that you described is the way that those funds have always been allocated to the general fund.
Since
and the school
2014, yeah.
systems, right,
Yeah.
exactly, since 2014. And I actually would have to defer to OPM as to whether or not there is a way to restructure the percentage. So it is to the point that you made that it's more revenue neutral to the general fund, but I can't offer any more insight into that. And I do apologize for that.
Okay. I am going to skip the safety and health workplace bill, although I
Okay.
appreciate your testimony on that.
Yes.
With regard to elderly nutrition,
Mhm.
I think we can skip that and focus on ADS for that. And then I think that's it for me. A
Okay.
very, very light few questions.
course.
Thank you.
you.
And I will turn it now over to Representative Gilchrist for questions.
Great. Thank you, Senator. Good to see you, Commissioner.
Good morning.
I'm going to start with Senate Bill 365, the safety and healthcare workforce.
Okay.
We're a good team. We didn't even mean to do that. So in the conversations I've heard about the fact that Connecticut used to have an escort program through Medicaid, where Medicaid would cover an escort if requested. However, that was so I've been told, burdensome process. And so a lot of agencies weren't able or didn't use it. Could you talk us through, in your testimony, you say that DSS is exploring other ways to support home health agencies in enhancing staff safety within state and federal funds. Could
That's
you
right.
just talk us through some of that? What is that looking like?
Certainly. So after the horrific death of the nurse that worked for one of the agencies with whom we have a relationship, we were approached by several of the agencies to ask what could we do to enhance health and safety. My colleague Fatmata Williams is actually the director that's in direct communication. She isn't here today. Has direct communications with the home and healthcare agencies. They have provided us with I think a very thoughtful and comprehensive list of ways that we can provide supports, and that would include, personal alarms, ways in which apps can be downloaded onto phones that can not necessarily track people where they are for the purposes of keeping track of whether or not they're where they're supposed to be. That's not the question at all, but just as an additional point of safety. So we have taken that list at DSS. My old background is coming back to me, but at DSS, and we are continuing to work through the economic feasibility of meeting some of those needs. And we are in constant communication with that specific agency, whose worker suffered that. I can't even talk about it. It's horrific. And with other agencies, as home healthcare agencies, to come back with more of a comprehensive proposal as to what we can do within our available resources that can help enhance the safety of workers. So we are actively working on that right now.
Thank you. Looking forward to seeing,
Yes.
what comes out of that. Are part of those conversations escorts or a similar program, or?
That was part of the ask.
Okay.
But the challenge that you identified still remains a challenge.
Okay.
So we're looking at ways in which perhaps there are other ways to provide more monitoring services and safety,
Okay,
right, that might meet the need.
great. Thank you. Next, shifting gears to House Bill 5427, the NEMT. Just want to better understand. So independent drivers
Yes.
are ride sharing app entities like an Uber considered an independent driver?
They are.
And so how are they required to have the criminal history record check and the motor vehicle driving record review before providing the Medicaid member trips?
So the vendor does require that. Yes. So the vendor's MTM, and they are engaged. They do engage in extensive background checks. They do that.
With the Uber drivers or with like each individual Uber driver who would be taking these trips?
Right. So when a
Okay.
driver applies to work with the vendor, they have to undergo a background check in order to work with the vendor.
Okay.
Yes.
Okay. And then it seems, based on the testimony and what we're hearing, when it comes to this proposal, it seems as though the independent driver, so there's testimony from Uber, Uber Technologies, who sees this as requiring all, if I'm getting this right, all independent drivers to have to get this F certification,
That's right.
F endorsement.
Yes.
But then we're seeing testimony, for example, from, what's the name of this company? M7,
Mm-hmm.
who
Medical care.
is not an independent driver. They do, I'm forgetting their type of entity. Their taxi livery service, and they're raising the issue of the fact that if their drivers want to get the F endorsement, then they wouldn't be able to provide the Medicaid trips for 90 days.
Okay. I'm not aware of that barrier.
Yeah.
Yeah, I am not.
So I guess it'd be great to all work together because as we
Yes.
hear testimony throughout the day, I will put publicly in the record, I am concerned about, like, do Uber drivers really get the background check? Like, okay, we'll see.
Okay.
That is a concern of mine. But as we move forward, it'd be great to fix this piece on this 90-day, because
Mhm.
certainly we don't want to prevent, if the livery taxi drivers have the background checks and their motor vehicle record check, just because they want to get a higher endorsement shouldn't mean that they then can't provide the Medicaid. So I think it might be a technical fix, but we
Right.
might have drafted it in a way that is overly broad?
I think that's the challenge. So thank you. As you continue to speak about the bill, the challenge I think is coming back to me. So the challenge is that the the livery services and the driver services, as you described, see the bill as suspending their driver from being able to participate in service while they acquire the F endorsement. And so the concern that has been raised is, let's just say with our current vendor, that would take about 1,000 drivers, right, sort of out of circulation when people are still very desperate for the need to have drivers with NEMT. If the bill, I think we're changing a way that the drivers don't have to come out of circulation, but they were required to get the F endorsement, if that's the desire of the legislature, then I think that might be the fix that they may be looking for. But I
Okay.
think what you're getting is a response to the bill in the way that it currently is drafted.
Okay.
Okay,
All right. Thank you.
yeah.
And then my final with House Bill 5458, an act concerning homelessness.
Yes.
The department has requested a date change from October 1 to March.
We have,
Would you be open to January? Because if there are things that come out of that report for policies,
for the session.
yeah, it would
Yes,
be, okay,
yes,
wonderful.
we would. Thank you. Yes.
Thank you. All right, that is all from me.
Okay, thank you, Madam Chair. Senator Seminar.
I just have one question, and I'm gonna bring you back to Operation Fuel as much as you probably do not want to go back.
That's
to that
perfectly
one.
fine.
But, or maybe I have two questions, but
Sure.
one, it's my understanding that, that people who apply through the state do not automatically, qualify through Operation Fuel.
That's correct.
Is that vice versa as well, that people who,
Yes.
okay. So if we did as the good senator is looking to do next to me, would you anticipate that it would reduce the amount of funds available and therefore would reduce the amount of people we serve?
How can I answer this? Because Operation Fuel uses a different income standard than we do, the potential exists, but we're very much serving the same population of people. So our standard for LIHEAP eligibility has different categories that we use: vulnerable, non-vulnerable. DC Hadler can come back apparently on this side, and he can explain that again. So it is, but the Operation Fuel standards are, how can I explain it? They're different than ours, so you don't necessarily have to be within the same categories that we use in order to do that. Go ahead.
Yeah, thank you. Of course, Operation Fuel is here and they can certainly answer the questions
Exactly.
for their entity as well. But just wanted to, my understanding is that they have a higher income threshold, right? They will go up to 75% of state median income, whereas we are federally limited within the Connecticut Energy Assistance Program to 60% of state median income. So it's not a, perhaps our income fits always, SEEP always fits within Operation Fuel's income limits, but not vice versa.
Okay, I guess my concern is this: we learned this year, or we did this year, as we have done in years past, run out of money, then we have to come and allocate additional funds,
Mhm.
correct? And this year, my understanding was that there was a wait list in your department for people. No?
No.
Because
No,
okay.
Senator. So thank you so much. I really do appreciate this question so that we can clarify some of the misunderstandings there are about money. We did not run out of money in LIHEAP. What had happened is that based on the allocation plan that we had brought before the legislature, there are people that had exhausted their first round and their second round of their crisis benefit, because that was the plan that we had submitted. The fund has never run out of money. So what had happened is that our legislature obviously said, well, what are we going to do about, it was about 16,000, close to 17,000 people who had exhausted their benefit and were not eligible for any others. There were other people who are coming to the fund later in the season. We still have applications that are coming in now, and we have more than adequate resources to meet their need. But, our legislature had decided, well, we want to meet the needs of those who had exhausted their crisis assistance. And that is why we put in the additional $17 million. That the fund has never been insolvent and it has never run out of resources.
Okay, I guess that's where my issue lies.
Okay,
In that we made the decision was made that people who exhausted their benefits
that's right.
continued to get additional benefits. Whereas there were some who applied later, I got that, who didn't get any benefits at all.
No,
No?
no, that's
Okay.
no.
Just
that's-
clarify that
No,
for me.
no. There is still money for those who will come. If we have people applying tomorrow or next week, the allocation plan that we propose was based on our experience of the numbers of people who will apply and who will be eligible, and we are right on track on that allocation plan. So there is no shortage. I think the decision to help those that had exhausted their benefit is the decision that may have caused some confusion that the fund had run out of money, but it actually had not. The issue was this, and this is what we had testified on. You remember we were there for quite a while with the LIHEAP hearing that day, is that when we went back to our pre-pandemic numbers, we were no longer able to offer the third and fourth tranches of crisis assistance. So that when people exhausted them, there was nothing else that we as a state could do through the LIHEAP program. They could certainly have applied, and here's a perfect example, through Operation Fuel. If they met their criteria, there were people that could apply and receive relief through Operation Fuel. And people did do that. But with respect to any further eligibility under our program, once they ran out of their 2 cycles of their crisis assistance, there were no more resources for those individuals because they were deemed ineligible because they'd used up all of their benefit. But for those that hadn't exhausted their benefit, there is still plenty of money available for them.
Okay, I
Okay.
appreciate you making that clarity because I did receive some other information that
Understood.
led me to believe that we were, as I said, assisting
Yes.
people in round 3 and 4, let's say, and there
Yes.
were some people who got 0. So
Mm,
I'm glad you
no,
clarified
yes,
that. I
yes.
appreciate you clarifying that, and
Certainly.
thank you.
Thank you, Senator, Representative Hughes, followed by Representative David.
Thank you, Madam Chair. Sorry, I didn't know you were going first. I share our committee's frustration in trying to make the whole energy assistant much more elder friendly because they get so confused and how to apply and when to apply and then
Yes.
delivery and that they can't get retroactive payment for their delivery.
That's correct.
They can only get prospective and then there's a time limit. It is really hard for
Mm.
our elderly folks to manage the system we have now. So I'd like to get some solutions out of this bill that actually makes it much more user friendly.
So-
But what I really want to ask you about is the elderly nutrition program. So my understanding is that there's a 5.5 million per year increase in funding for our elderly nutrition program. Is that correct?
That is my understanding.
Okay,
yes.
great. And some of the recommendations are streamlining the process for grant databases, which you referred to take advantage of the funding as well as working to increase the SNAP enrollment. Is that correct?
That's correct.
Great. Okay. Because we're just like the WIC program, it's underutilized from people who are eligible. So I'm really looking forward to figuring out how we can work across agencies to, amplify, again, make it really user friendly for folks who are eligible to understand they're eligible and how they can use it, right?
Mhm.
So the Farmers Market Nutrition Program has upped the allocation for each senior from $24 per season to $50 per
Mhm.
season. Again, I don't think seniors know that. And I don't even think a lot of the farmers markets know that. So how can we can double the value of that benefit at so many farmers market, but we need to see the redemption of those benefits, right? So do you have any suggestions, language tweaks that we could support maximizing that across our state for elders?
I don't have any at the moment, but I can certainly provide them. And as I sit here, I continue to reflect on the experiences I had in the job immediately taking this one, to trying to explain to people the difference between family and medical leave and paid family and medical leave.
Exactly.
Yes, okay, very, very, very challenging messaging, but I can tell you the lessons that I learned there is that it's persistence
Yeah.
and having a very focused and planful approach around education that's still happening today. So I think there's opportunity there for us also to, let's say, for example, to partner with AARP, with my colleague from Aging, to really think very, very carefully about where the information gaps are, where people are getting their information, and then go to them where they are to provide that information. So even more recently, and I've been out of that job for about a year, paid leave is going to libraries and holding seminars there so people can just come in and ask their questions. What is the difference between family medical leave and paid leave? I don't understand. Why did I lose my job? Because you just left because you didn't get family medical leave permission, which is not the same thing. And that has been extremely helpful. But what we've also found, and the current CEO, Aaron Choquette, I think will tell you, is that it never ends. And I think that's part of the challenge that we have, whether it's with Operation Fuel and the confusion with LIHEAP or the programs that you're referencing. We, I think, often underestimate the tremendous importance and need for continuous public education around the things that are important. So I'm happy to take that back, to think about ways that we can partner, have consistent communication around what can be done, what people should know, and so that there can be better advantage taken of the programs that can really help people.
And did you ask for an extension on the DSS and ADS commissioners to develop an outreach plan by October 1st, 2024?
I'm not sure if we did. I will
Okay.
certainly take one if you're offering it.
No. Again, I
Okay.
so want to maximize
Sure.
people's, benefits before it becomes crisis. And again, the
Yes.
farmers markets all end in October, or most of them do. So then if people are eligible to maximize their benefit through the winter, I really want to make sure that they have a streamlined and seamless way to do that before next winter.
Understand.
So, I'm not really offering that, but,
Okay.
but I want to help. So I want to help make it user friendly for seniors
Yes.
and for the agencies serving them and the municipal agents and whoever might be able to provide
Mhm.
really one-stop access to all those benefits. I think that's all I have right now.
Thank you, Representative. Representative Dathan, followed by Representative Coe.
Thank you so much, Mr. Chair, and nice to see you today, Commissioner. Appreciate your testimony as always. Just wanted to let my good friend, the representative from Easton know that there is some DOAG programs that support our seniors and that are really good for local food, farmers markets and things like that. And there's quite a bit of investment going on there. Just speaking from my subcommittee experience in DECD. My question really regarding the supplemental nutrition assistance in Senate Bill 364. We talked last year about a similar issue about other benefits. And I know that there was some issue about staggering, particularly for existing folks. I was under the impression that we implemented for new folks to be able to be part of a staggered system when it comes to SNAP. Did I forget something there?
No, we have not changed the distribution schedule for SNAP. Go ahead. Yeah, no, we have not.
Oh,
That's
okay.
correct. I think it was proposed, but
Yes, yeah.
I thought it was implemented as part of the implementer, so apologies. It would be great to get that over the finish line. Maybe even use some ARPA funding to pay for these one-off costs to be able to do that. Because we see so many folks that are in food deserts that don't have access to fresh fruits and vegetables because of the timing of their payments for SNAP. So I'm pleased to hear that we're still looking at it. Also in that next section regarding the ability for folks to be able to use their benefits at Subway and other sort of fast foods. Are there limitations on the menus in some of the other states that are using this benefit so that maybe if you are able to use your SNAP benefits at Subway, for example, that you are not able to buy like chips and soda with it, but you're limited to buy sandwiches and water? Are there any limitations in any of the other states that you know?
I don't know of the limitations on the other states. We do know that SNAP itself had a number of in its previous iterations, right, had a number of limitations. And for a lot of reasons, policy reasons, and reasons around class and socioeconomic status, those have been relaxed. I don't know whether those same standards would apply to being able to buy fast food. In some instances, you would imagine that it is somewhat relaxed because now you can use your EBT benefits to buy fast food, which is something that had not been permitted in the past. But we can find out what the details are from other states. I think when the expansiveness allows for more restaurants to participate, and that's probably what some states have discovered. There supposed to be willingness on the part of the restaurants as well, and that needs to be worked on too.
Thank you. I think it's interesting to explore. I would
Mm.
just be curious. Also, do any of these fast food places offer maybe discounts to folks who are using their EBT SNAP benefits at them so that they're not having to pay $10 for a sandwich and may
Yes.
be able to get something reduced? I don't know if you could find that out as well.
That is actually an essential component of this program, that they
Okay.
do have to offer certain meals at a discounted rate and not charge tax for it either.
Yeah, because your SNAP benefits are not going to go very far if you're buying Subway sandwiches with them and
That's
other
right.
folks.
That's right.
I do think it's good that we help our communities be able to have some flexibility for the consumer there. Thank you. The next question I had was really regarding the non-emergency medical transportation. I know I was thinking about this the other day with the wheelchair issue that we were talking about, and the chair mentioned his questioning along that as well. And so I do want to kind of explore that. One of the problems we see in our state, and we talked about it in 5001, was really the ability for non-emergency medical treatment, particularly for folks in the IDD community in different parts of the state. I know the good ranking senator and I talked at length about this last year, and we did actually do a program for that, and just wanted to see where this might be useful to be able to expand these in other parts of the state based on maybe what other states are doing. So if you could talk a bit about that, I'd appreciate it.
Okay. I'll do my best. And I think I lost your question a little bit though, because I'm
It
not
was,
sure if we're
sorry, it
focusing
was
on the
more
wheelchairs.
about the ability for these sort of non-emergency medical transportation using other programs like a Lyft or a Uber or something like that,
Yeah.
or even sort of more private taxis, because this might be a way for us to improve those services, particularly in other parts of the state, which are not
Yes.
as accessible. I know there's a lot of controls. Uber offers, you have to enter a PIN if you're a woman, which I didn't realize. It was
Yes.
only that when my husband asked for the Uber, we didn't have to do a PIN, but when I would do it,
I have the same
so
experience,
I'm
yeah.
just wondering if there's any sort of things in place that maybe DSS can do based on what's other states, so we can expand these non-emergency transportation programs to make sure our recipients are safe, but still able to use these
Yes.
in other parts of the state.
Yes, so thank you for the question and for restating it. I did get a little lost, so I apologize for that. No, that's all right. Your question is one that we've actually explored with the Department of Transportation. We have said to them, look, we've got a single contract with one vendor, but we've always had a single contract with one vendor for quite some time. And that vendor is, we're in partnership with them and they really have been quite responsive to a number of the concerns that we've raised. But then we have this sense of there are parts of the state that probably aren't getting the degree of support that they need. And so what other options might there be? So one of my deputy commissioners, Chantal Vars, is in communication with the Department of Transportation to have those discussions about what we can do in concert with other transportation initiatives that DOT is engaging in. And that does include whether or not we can use Uber, Lyft, other ride shares. Could we incentivize taxi services there? So we're actively exploring that. I wish I had more to report to you other than to say that we understand that there needs to be some supplement to the services that we have in order to meet the needs of the state. So what I can do is I can ask DC Vars maybe to come back and report on that when we have more of a concrete plan and some recommendations as to how we can expand and better support others.
That would be great. I'm
Okay.
looking forward to it. I know
Sure.
it's, it is a big thing to look at, so I
Yeah.
appreciate the agency looking at it. Thank you, Mr. Chair.
Thank you, Representative Cook, followed by Representative Johnson.
Thank you, Mr. Chairman. Thank you, Commissioner, and your staff for being here. Greatly appreciate it and everything that you do. I will wait to ask questions on the elderly nutrition for Commissioner Porter, but I do want to just clarify a couple things on the transportation bill. And I know it's not necessarily called out, but more for clarification. And then if it's not something that is specifically in there, something that we can work for.
Mm.
So the bill talks about most cost-effective means of transportation. Although as we try to budget and make sure that we make ends meet, I want to ensure that the most cost-effective does not mean the most irresponsible, which we have seen significantly in years past and still today. Leaving people, not getting people to dialysis, you fill in the blank, the horror stories are immense. And so as I'm reading the bill, it requires for a licensed operator. Is that simply a driver's license? Or are we putting them through more license requirements before they can transport the folks that need that non-medical transportation?
Right.
And then we can proceed after your
Yes.
response.
So right now, according to the vendor, and I will get more information from you, you at a minimum obviously need to have a license, and then they do conduct a very thorough background check for that person. So yeah, so right now an operator does include obviously having a valid license with a clean driving record and a background check. I think what you might referring to is the statute that references the F endorsement. Is that correct? Or am I referencing?
Well, it's all connected to
Okay.
proposed bill 5427.
Mm-hmm.
So,
Okay.
so the clarification, and I understand that it's not called out specifically, but
Yes.
the bill, the statement of the purpose is to require non-emergency medical transportation to be licensed operators of a
Yes.
motor vehicle used for passengers of non-medical transport. So my
That's right.
question with that is it simply a driver's license? Or is there more training to that would certify them as a licensed operator?
There isn't additional training that I am aware of right now, but I can get more answers to that for you. I know that with the vendor that we currently have, they do require them to have regular training, and I don't know what the interval of that training is, but at a minimum, they do have to have a driver's license with a clean record and subjected to a background check. But I can get all of those criteria for you.
So then to follow up with that, then are we auditing? Are we following up with those requirements, licensures, trainings? Do those get reported back to us, or do we just entrust that this company
Hmm.
is doing what they're supposed to do?
So there is one person in our agency who is responsible for the actual auditing. And so I can get back to you, so what we do specifically for them, but we do ask regularly about the quality of the services that are provided. We do respond very vigorously with respect to the complaints. And I can tell you now that I've heard about the concerns that people have raised, and I think Representative Dathan and Hughes also mentioned these. So I am meeting weekly with the president of the vendor and their senior team to get direct reports so that we're not talking through our teams, even though our teams are quite capable, around the concerns that have been raised and what it is that they are doing to address those concerns. So those include going out to some of our major hospitals and healthcare places to actually observe what is happening, to follow up on the reports of abandonment. I can now go back and I can ask more specific questions about the auditing that we do with respect to the drivers and what kind of transparency we have into when drivers are added to the roles and and what happens. Now, I can tell you this, because I've been meeting with them regularly, because I think really our staff needed some additional support to really help to clarify with this vendor what it was that we wanted. I can say that the vendor has been extremely responsive to the concerns that we've raised. And they have been terminating drivers who have been violating the rules, and they've been terminating drivers who have been abandoning people or have been rude and disrespectful. They've been taking direct action around those drivers. And that is a direct result of our saying to them, what has been happening is unacceptable, right? That the people of the state and any state in which you operate, they deserve better. So we want to work with you. We think it's important that you're delivering valuable service, but we also have made it very clear these are taxpayer dollars that are paying for these services. So we need a higher level of accountability. And so that's what's been happening of late, very recently.
And I appreciate that and the dedication to making it better. I mean, this is years past of
That's right.
significant problems. And,
That's
you know, with each company, it was promised to be better and it's gotten worse. And so I respect that you inherited an issue. It wasn't an issue that you necessarily created. And so with that, I would offer a few suggestions if you
Certainly.
don't mind.
No, not at all.
And one of those would be, it should not be just a simple license, a driver's
Right.
license or a simple background check. There's been significant amount of folks that have called my office or stopped me in a grocery store, or you fill in the blank, where they stop you and say, you know, I was left, the person didn't pick me up. Oh, they saw that I had a wheelchair. They saw that I had a walker. The vehicle wasn't equipped for that. They didn't know how to assist me. And understanding that it still falls under the line of non-medical transport, there is still some assistance that might very well be needed to get a person from point A to point B. Oh, they didn't wait for me longer than 5 minutes and I have a walker, but I needed to get out of my house.
Yes.
They went to the wrong address and never bothered to call. So I think that when we look about licensing and then we talk about training, that we as a state and as an agency really need to set those standards and not the company. And we know what our patients and our residents need better than they. We've been doing this much longer in most cases. And nobody that is on oxygen should get in a vehicle with somebody that's been smoking.
Right.
Those should all be strict restrictions in the world of transporting our non-medical transport folks, but they are not. And I hear what you're saying about the reporting, but reporting is only as good as what you see with your own eyes and not what somebody brings back with their interpretation.
Mhm.
And so as we look at how this continues to evolve, I understand that you're understaffed and I don't envy that at all. And you know that folks sitting around this table would give you everything that you need to make this better. But given the cards that we are dealt, I do think that there's things that we can put in place to make things better for those residents of our state to get where they need to go. And I believe that it is absolutely deplorable for any company to find an excuse to leave somebody sitting outside for 4 hours in the cold, in the elements. I don't care what the temperature is. Nobody should be left outside for 4 hours. And if a doctor's office is closing, it's not, there comes this balance about who's responsible for this person because that person's an adult. I talk to our taxis in my neck of the woods often. We are very limited on Uber drivers and Lyft, especially in areas where you have no cell service. And so when you're left in an area where service is minimal, you're stranded. And that could be stranded for hours at a time. That could be stranded during a time where you need medication, where those things could be very life-threatening and critical. So I think as we move forward in the process of making things better, we really need to look at what a license means, what our requirement standards are. And as we talk about minimal standards, I believe this needs to be far beyond minimal, because folks that need assistance need to deserve that they're not being put in harm's way. And that means from the time that they're supposed to be picked up to the time that they're supposed to be dropped off. And I would hope that as you're talking to them weekly, that those things could be conveyed, because we must do better. So I appreciate you listening. I appreciate your office and then the dedication to making it better.
Thank you.
Thank you, Mr.
Thank you, Representative Johnson.
Thank you, Mr. Chair, and thank you, Commissioner, for your work. It's very much appreciated.
And I, can certainly echo all the remarks that were made by Representative Cook. I have the same issues because I'm in a more rural area as well. So we run into transportation issues. But my focus today really has to do with Senate Bill 365 and that concerning safety in the healthcare workforce.
Yes.
And I'm sure you're aware of the fact that in my district, the nurse was murdered who went to see someone in a halfway house. And it's not the first murder, by the way, from somebody in a halfway house. It's we had a young girl who was a newspaper delivery girl murdered by sex offenders in her neighborhood. She was delivering the newspaper and never came home. And then another situation where a group home was put in, a halfway house was put in a public subsidized housing facility. And a little girl on her way home was murdered in that particular area. So we have a problem in terms of how we're addressing these issues. And I know that one of the things that we did as we created the sex offender registry, but it's not being transferred. That information isn't being transferred to the home care agencies. And I think they've confused the sex offender registry with the HIPAA Act.
Mm,
It just
Okay.
says, and I've talked to some of the nurses about it. They said, oh, this stuff is confidential. I go, well, if it's somebody who's been arrested and incarcerated and now is someone who's gone to a halfway house, that's all public information. And that is public information that is all over. You can go on the website and get the address and find out who's in the area. I have the 80 of them in 4.3 square miles in Wyndham. And so I'm very, very concerned. I like to see the statute here where we're looking at doing an analysis of what's going on. But when I talk to the Department of Corrections about this, and I find out, well, when you're in a halfway house, if it's with corrections and parole, it's different than if the person goes on to probation. Then it gets put in the blanket of the local home care agency and the probation officer. So it's a different system in terms of analysis. So I'm looking into how this is working because I think that we need to understand where the intersections are of these situations. So I'm hoping that we take that into consideration because the halfway houses especially for the violent offenders are something that we really should be concerned about. They're killing the little children. They're killing the people who are coming to their homes to give them care for their mental health disorders. This particular circumstance that just recently happened in my district, this circumstance was where the person was served time for first-degree rape, also had stabbed the person numerous times, and was charged also with disfiguration, although it looks to me like it should have been attempted murder, but that's beside the point. And in any event, then served several years, about maybe 10 or so, was put into the community, was reviewed by people who had to know that they were in some type of authority situation, understanding these types of behaviors, and said, oh, this person's okay to be in the community. The person violated several laws, was still moved in and out of prison, into halfway houses, back and forth. Yet the nurses serving him didn't know what the crime was that was committed. Knew the diagnosis, and now, of course, that's confidential because that's under HIPAA, but not this actual situation. So what we have now is we have somebody who the probation officer has him, which is not as stringent as parole. Excuse me. And tried to put him into the Connecticut Valley Hospital. Connecticut Valley Hospital refused. And then 2 months later, he murders the nurse. So we need to have some way of making sure, first of all, that people are in a situation where they're serving this population. And of course, we want to make sure people who have the capacity to live in the community get that chance. But also we want to make sure people in the community are not at risk because of the way that we've decided to do this work. So the reason I'm bringing all this up is because I'm hoping that we can take a look at the safety of people who are doing this. We don't want to see any more nurses murdered.
who, when they go out into the home, we want to make sure they know where they're going and who they're seeing in terms of the criminal charges, which are public information. So I just didn't know what your take on the current circumstance. I realized that this was these proposals were made before we passed our budget last year, but I just wanted to know how you see this, how we can work with the Department of Corrections to see what the situation is with respect to the safety of the population, little kids walking back and forth, not even realizing who the neighbor is, right in front of and near subsidized housing complexes. So we are putting children at risk. We're putting the servers at risk. We're putting everybody at risk when we have people like this in the community and they're not being monitored properly. And I know that you have limitations in terms of Medicaid providing the coverage for the care that they get, but I'd like to see more in the way of being able to address this, and I wondered what your thoughts were.
Representative Johnson, I know that this was a horrific tragedy that occurred in your district, and I know that you've been a zealous champion of the safety of Hope Care workers and this issue in general. So I want to thank you for that. This is one of just a handful of bills that is going through the legislature right now. So in addition to Senate Bill 365, I know the Public Health Committee is looking at Senate Bill 1, which is a sort of a more comprehensive look at this issue of the safety of the healthcare workforce. I do want to remind you that Commissioner Barton Reeves is only the commissioner of the Department of Social Services. She can't, I think, speak for DOC and other state agencies. And I would just ask that you limit your remarks to 365 and what we could potentially include in that bill, just because we have a relatively narrow scope in this committee.
And I agree with you completely. And thank you so much for that, Senator. My point is that it's a morass of different types of laws that intersect. I do want her to just focus on the Medicaid aspect for the delivery of the healthcare services. But I think also we could have agency agreements that could address how the Department of Corrections interacts in this particular area. So in terms of the study that's proposed in this particular bill, I'm hoping to see that part of the interagency agreement and take a peek at that as we do the study. So that was my focus, but that's why I try to explain why I'm asking the question so people understand what I'm talking about.
Thank you.
Thank you.
Thank you, Representative. It's certainly, Commissioner, you can respond if you'd like.
I'll try to respond as best I can, and thank you, Senator. So Representative, thank you for your question, but to the Senator's point, I would have to have a conversation with Commissioner Quiros to better understand the circumstances that you described, probation versus parole. I'm somewhat familiar, but not enough in order to be able to answer substantively. As I mentioned earlier in our testimony today as a department, we do have a fairly comprehensive list of services and supports that we will probably propose at some point to help better assure the safety and security of those who are going out into the community and delivering services. And so that it also includes people that work at DEMIS, people, and now I'm just talking about the state as well. And what I think probably what people don't know is that birth to 3 services through the Office of Early Childhood are also delivered out into the community. So we are talking about not only our provider network, which is extremely important, but all of the people who go out into the community. I have asked, and I still have some of that information, what kinds of services and support each of our state agencies provide. They're outside of the 4 walls of their agency, and what kinds of safety protocols do they have in place so that I can match those with what our home and healthcare agencies are asking for and put together more comprehensive recommendations as to what we can do. Now, all of these recommendations will have a fiscal note associated with them, and we know that. And then, the governor's budget is fixed for what we have now. But I clearly hear you. We are deeply concerned. And I will say from a very personal note, I grew up in a family of nurses, my mom, 3 of my aunts, 2 cousins, and many of them were delivering care in the community, methadone clinics, anything you can think of. So this is actually very close to me in terms of my family. So even if that wasn't the case, we're just very committed to making sure that we have some sort of recommendation that we can make to keep very, very critical workers safe in the community. So I'll continue to work on that.
I so appreciate that your answer very much, and I'll be researching this too. And so I'd like to be part of the conversation when you do the study group, so that I could maybe help with that at analysis. So thank you so much. Thank you, Mr. Chair.
Thank you, Representative. And again, I would also encourage you to work with us, and we're in communication. The chairs are with our counterparts over at Public Health, over Senate Bill 1, and some of 365 is in there. Some of it will be in there. We're working to make sure that on a holistic level, the legislature is responsive to the the tragic murder of Joyce Grace. And I know it's something that affected your district, but affected all of us. So thank you, Representative. Other comments from members of the committee? Seeing none, you're off after only almost 2 hours, so
Thank you.
thank you. So we are way past the 1 hour mark. So we will now go to a member of the public, and of course I've misplaced my sheet. So we're going to hear from Paul Kidwell at the Connecticut Hospital Association. Is Paul here? No, Paul. Okay. Why don't we do another member of the public? Anderson Curtis, is Anderson here? I think nobody believes we'd ever be done with the commissioner. All right, we'll go to Commissioner Porter. We were trying to give you a little reprieve. I don't know. Good afternoon.
Good afternoon, Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Case, and distinguished members of the Human Services Committee. My name is Amy Porter, and I'm the Commissioner for the Department of Aging and Disability Services. As you likely recall, one of our major program areas is our State Unit on Aging, which administers our elderly nutrition program. So within that context, I'm here to provide comments on Senate Bill 396, an act implementing task force recommendations for the elderly nutrition program. We appreciate the committee convening a task force to study this critical program. It's really allowed us to continue to work closely with all of you, with our community partners, to address a variety of concerns. As a brief overview of the elderly nutrition program, actually first you may hear me refer to it as the senior nutrition program. Our federal funders are in the process of updating the terminology and the name, so you may hear me use them interchangeably. The program is open to individuals age 60 and older, their spouses, and certain younger individuals with disabilities. It's designed to reduce food insecurity and isolation through the provision of nutritionally balanced meals and socialization. It's delivered either through congregate meals in the community settings like senior centers or senior housing, or home delivered meals provided to individuals in their homes by delivery drivers. The funding is primarily federal with a partial state match. The funding is allocated to our area agencies on aging, or the AAAs, who in turn contract with local providers through a competitive procurement process. For reference, we did include a link in our testimony to the 2023 legislative report. It has a lot of extra details in there that I promise not to go over today. Things about the program, nutritional risk data, allocation methodology, provider costs, and reimbursement rates. So you'll be able to find a lot of detail there. Section 1 of the bill would require ADS to disperse additional payments to the AAAs when they've expended 50% or more of the initial round of contract funding. Until recently, we had a threshold of 75%. That was put into place after an audit finding that our contractors were holding too much cash on hand. The intent was to ensure that the AAAs and our other contractors expended 75% of the funds that they've already received before requesting more. Based on our work with the task force, we've since lowered this threshold to 50% and amended our contracts accordingly. Though the bill requires us to study the feasibility of lowering this even further, we don't believe we could do so without risking an audit finding. As such, we don't believe that the annual reporting requirement is necessary. Also in section 1 is a requirement to pay invoices for this program within 30 days. Our contracts currently require us to make payments within 45 days, which is the comptroller's requirement. But we do strive to process them more quickly. In fact, we're currently averaging 30 days for invoices that are received in good order. As these new proposed requirements pertain to accounting functions for several federally funded programs, not just our nutrition program, we would respectfully request to work with the committee to achieve these goals administratively rather than through statutory changes. The bill also requires a continuity plan to minimize any disruption when a provider leaves or there's a significant increase in service levels or demand. It's important to note that federal law and state regulations require that our providers are chosen through a competitive procurement process run by the AAAs. And when a local provider changes for a subregion, the AAA has always worked with the outgoing and incoming provider to ensure continuity of services. So that's happening already. As for increases in demand, I think one of the things that often gets confusing to people is that this program is not an entitlement program and it's not means tested. So providers should be working with their area agency on aging to reduce levels of service or to implement waiting lists when the demand exceeds available funds. We're already working to ensure that these plans are documented locally, but clarification on intent would be helpful to balance the notification requirements here with the added administrative burden, mostly for the AAAs that this will fall on. Section 2 requires ADS to develop a plan to streamline contracting, reporting, and documentation. ADS is always striving to streamline our contracting process, but we are trying to administer our contracts within state and federal contracting rules. We're 75% federally funded in ADS. For this program, we do execute multi-year contracts with our AAAs that encompass all of our federal funding, including not just the nutrition program. And we have suggested to the AAAs that they may want to consider doing that as well. We think that might help ease some of the administrative burden and delays. As to documentation, each program participant completes the intake and assessment process, which is called the Form 5, except for the service indicators section of the Form 5, which was intended to assist with prioritization in the event of a wait list and to provide additional malnutrition data. All of the other collected information is required as part of our state performance report. Some of you may recall that we added this service indicator section a couple of years ago based on discussions with this committee and with our community providers. But we recently met with the AAAs and agreed to remove this section and figure out other ways to get at that same information, making sure that we can prioritize. Sections 3 and 4 speak to leveraging the Supplemental Nutrition Assistance Program to support nutrition program consumers. As you heard our DSS commissioner talk about, we do appreciate the overall goal here. Our preliminary conversations with DSS do point to some challenges with data matching, trying to figure out what that looks like. But given that DSS is supportive of the goal and we are as well, we can work with them and with our providers to really dig into the issue to figure out what that will entail and how we can move forward. There are a couple areas in the bill where we're unclear, and I've tried to identify those in the testimony. Automatic eligibility under Section 2, template or portal in Section 2, and requirements that AAAs apply for funding through a grant database portal. These are some things that don't match with our current understanding of the program, so we've tried to outline them, and we can work with the committee to get some additional clarification. Lastly, we appreciate the intent of sections 5 and 6 to further expand the capacity of the senior nutrition program. However, as the funding to support the various initiatives is not included in the governor's recommended budget, we can't support it at this time. We want to thank you again for your consideration of the nutritional needs of Connecticut's older adults and for your support of our dedicated community providers who serve them. We look forward to continued collaboration as this session and this legislation develop, and I'm happy to answer any questions.
Thank you, Commissioner. With regard to go start in whatever order you'd like, but in the I will say that yesterday I got a call, a disturbing call from a elderly nutrition service provider that serves Hartford County, indicating that they were going to be providing a mitigation plan due to an ongoing operational deficit that would substantially reduce home delivered meals and congregate meals in this area of the state very, very soon. Why does this keep happening?
Well, I think as I mentioned in my testimony, I think there is some misunderstanding that this is an entitlement program. And so we had different infusions of cash along the way, particularly with COVID funds, being able to really increase the number of meals that were available to people during COVID. And so the service levels increased. As things started to wind down, we needed the providers to go back to where they were before. They have a contract with the area agencies on aging that calls for a certain set of meals. If that's not, if they're not able to meet that demand, they either need to reduce their service levels or put a wait list in place. And so I think it's happening because those mitigation strategies aren't happening until far too late in the process.
But don't you, I know this is pass-through funding that's administered by the AAAs, but why are we having these mid-year, $1 million deficits that cause, in this case, a reduction from 2 meals a day to 1 meal a day for the folks on Meals on Wheels, and from 5 days a week to 3 days, or 4 days to 2 days, depending on the type of site for congregate meals? That's a pretty big impact on a person who's relying on this for in many cases, their primary source of nutrition. This isn't happening in the middle of the year. It keeps on happening. What steps are we taking to make sure that we're budgeting appropriately so that we know what the program is like? So, we don't have this surprise. We need another cash infusion in the middle of the appropriations calendar.
Yeah, it's a great question. I don't think we should have surprises. We know what that allocation is at the beginning of the year. We know we may not get all the federal funds right at the same time, but we know what the state allocation is. We have a pretty good estimate of what the federal allocation is, and the area agencies on aging then contract with the elderly nutrition providers with those numbers, with that budget and those numbers in mind. So it shouldn't be a surprise to
But
the
it's
providers.
happening over and over again. It happened last year. It's happening this year. It happened today. So what you oversee the AAAs. Is it that the AAAs are budgeting incorrectly? Is it that you're not over? Where are things going wrong?
We are overseeing them. We are meeting with the area agencies in the regions where there are concerns and trying to make sure that they are putting one of those 2 measures or both of those 2 measures in place, and have been asking for that for a bit of time already. So again, this is not a surprise. This is not a new thing that happened with the provider.
Okay, but it just happens, and it happened before, and it's still happening. And if we need, look, we fight. Last year we fought to add state support for it. I know we've seen decreased federal support. We added state support. It wasn't enough, but to have a mid-year or end of fiscal year deficit, did you know that we had $1 million deficit in the program?
We knew that there were concerns on the part of the provider, and we have worked with the area agency on aging to ensure that they pull that in with either a wait list or a reduction in service levels. Again, I don't think it was a mid-year surprise. I think that's something that some providers continued to provide the same service levels that they were providing during COVID. That's not our new norm. We can't continue to serve at those levels. So we're going to have to be able to adapt. And for some providers, that may have been, there was an infusion of funds that would have been the time to sort of scale back down again.
Okay, so with regard to your comments at the beginning that we are, when there is a change of scope, that planning takes place. I will just say that was not my experience. In my district, a AAA switched elderly nutrition providers, and that change took place on October 1st of last year. And to this date, I don't believe there's been a resumption in congregate meals in my district. It was suspended. There was no adequate handoff. There was no consultation meaningfully with the city locally. And so for 6 months, seniors in my district who were relying on that program have not gotten food. And I don't know how hopefully they're okay. But that was a failure by the AAA to work with the stakeholders in the towns. And so that section 2, which is really specifically about engaging in local stakeholders, including the chief elected official, is to make sure that what happened to my district doesn't happen to any of my colleagues' districts going forward. So happy to work on clarifying what that looks like. I think that that would make sense, but that was a major priority of the task force, was making sure that we don't, if somebody wants to switch a provider, they can, AAA has that ability, but we don't have this issue where that coordination does not happen, and you got seniors who are just going without.
Thank you.
Okay. Then with regard to I totally understand the there are a number of questions about language, but one question we had was just about making the SNAP program more available to seniors. A lot of seniors are SNAP eligible. I know that SNAP is administered. We should have had Commissioner Barton Reeves up for another hour. But she had an agency to run. I'm sure you do too. But it doesn't seem that we're doing a very good job of enrolling eligible seniors in the SNAP program. So I know they've got that program. You've got elderly, what's the other name?
Senior nutrition.
Senior nutrition, whatever we call it. How do we connect the two so that we are connecting people to the resources that they've earned and they're entitled to?
Yeah, I think it's a great question. And I think this sort of opens the door for that discussion. You heard Commissioner Barton Reeves say that they're open to that. And they thought it fit best with the senior nutrition program. So we will take the lead on that with them, try to understand what the possibilities are, what the administrative burden is. I think our original conversations seemed to point to the fact that it wasn't going to be a huge burden on the AAAs, but the AAA testimony that you're going to see says it could be. So what we want to do is be able to mitigate that and make sure that we can do it in a way that reaches the goals that you're talking about without creating a lot of undue burden on folks that are already stretched at capacity.
Okay. And then just, we'll work with OPM and our appropriations partners, but one of the real takeaways was that there's a consistent funding problem at the beginning of the federal fiscal year. So we're looking for one-time funds to be able to adjust the way the program works to smooth out the operation. And so that will take, whether it's ARPA funds or some other one-time source, staggering or recalibrating the way that you spend funds to carry forward funds to the next fiscal year, I think is one of the things that we heard from elderly nutrition providers and AAAs would be a positive benefit to the program. So I know you can't ask for a nickel that's beyond what the governor is recommending, but I would just ask that you work with us and our friends on the appropriations committee on the feasibility of that, unless there's some barrier that we're not aware of.
Yeah, we'd be happy. We'll defer to OPM on the budget discussions, but any policy information we can provide, anything we can provide about how our funding comes in from the federal government, we're obviously happy to work with the committee on that.
Great. Questions from members of the committee? Representative Cook, followed by Representative Hughes.
Thank you, Mr. Chairman. I think there's a theme about what we get reimbursed from the feds and what's actually distributed. We need to continue to work on that. So thank you for that. Commissioner Porter, thank you and your department for everything that you do on behalf of our more mature residents in the state of Connecticut. And so I just wanted to touch base on the task force and clarify a couple of questions and make a statement. So my senior center director was honored enough to be on that task force. And so he felt it was very good that in many ways it brought to light the differences in the regions and independently that the providers have very different needs, which is something that we've never funded that way. We've always funded it pretty even, but the needs are very different. As you know, like if you're leaving Torrington and you have to go all the way to the west side of the state, that could be an hour to an hour and a half drive, significantly different than if you're in the city of Hartford and you can hit, 3 or 4 people in 5 minutes as opposed to 3 or 4 people in an hour in certain parts of the state, mine, Representative Johnson's and the like. So as each provider has a long-term understanding of how to best serve their region, but they are managed and operated very differently with the different missions, making an ununified voice in theory for what their challenges are. The advocacy becomes very muddy for those directors, and then they feel like they're pitting one group against the other, but in the end, they're actually fighting for the exact same cause. So the question lies, do you believe out of that task force, and then it's reported into this proposed piece of legislation, that the streamlining of the reporting process was addressed? The funds that need to be in the hands of providers faster. I know that you would address that briefly, but is there something that we need to clarify? I heard you say give a little bit of flex and maybe not legislate it, but figure out how we do that in a different manner. I respect that, but with all due respect, you're not going to be here and I'm not going to be here in some years. And so certain things you definitely want to make sure that they are followed a certain way. And then the third, for clarification is, I know that you had just said that you do support funding increases, but it's not necessarily put in there. Is there a way to maximize that? And I think that we were just addressing what we maximize from the feds and then, sending that back down. So if you could tip those three, I would greatly appreciate it. Thank you.
Sure. Thank you very much. And thank you for your continued advocacy. So the streamlining, I do think we have done what we can to streamline. We have, as you've heard for many years, we have what's called the Form 5, which is our assessment and intake form. We have what's in it now is what is required from the feds. There are only required elements in it. There was an additional section, a service indicators section that we actually put in there in cooperation with this committee to collect some malnutrition data, some nutritional risk data, and be able to really help us figure out what to do when we did have to put in wait lists or look at service levels. So what we've done is we've taken that out of the Form 5s. And then we're working with the AAAs and the elderly nutrition providers to kind of figure out how do we come up with local plans to address that? Because as you said, things are different depending on the region that they're in. So that's the piece about streamlining. The funding, the threshold we had, we did lower that as part of the discussion in the task force. And so while I may not be here, it is now reflected in our contracts that they can request additional funding with 50% of their on-hand funds expended. So we think that will make a difference. The area agencies think that will make a difference. And so then they can turn around and pay the elderly nutrition providers. We also had some issues internally. We, as many agencies, were hit with the retirements, and in our two of our biggest hit areas were in our state unit on aging and our fiscal department. We're back to full staff on our state unit on aging, and we are full staff in our fiscal unit with the person starting in 2 weeks. So we're in really good shape and getting people on board. So our average payment now is 30 days, not the 45 days that's in contract, but we've gotten down to 30 days, and we'll continue to try to refine that. And then the last question was about the increase in funding. So again, those decisions, if it's not in the governor's budget, I can't say that I support additional funding here. That's happens beyond the scope of my control. So I think that we have funding right now. We have additional funding that was added to the elderly nutrition program and ARPA dollars that were a bridge. And those are in the governor's recommended budget. And I think those are big new investments in this program and really demonstrate the commitment of the governor and his administration in making sure that this program not only maintains but grows.
And thank you for that. And just one brief follow-up. So you had said, so when we did add those questions and then we did utilize data that we were actually collecting but was going nowhere, by the request of the different groups that were on the ground, and now you're saying that we're not collecting that data anymore?
We've taken it out of the Form 5. Some of the same people that were advocating to put it in have said it's challenging there. So let's find another way. And so we are going to work with the AAAs and the elderly nutrition providers to make sure that we're able to collect the data we need to make the right decisions.
All right, perfect. I greatly appreciate it. And just a huge shout out to all those that are on the ground doing the great work that they need to do, and appreciate what you all are trying to do collectively. And thank you for working with them. Thank you, Madam Chair.
Thank you, Representative Cook. Representative Hughes.
Thank you, Madam Chair. Thank you, Commissioner Porter. Having filled out those Form 5s, I know exactly exactly what you're talking about. I'm just curious, as we look at elderly nutrition and the SNAP benefits and all that, has your office engaged with the Office of Food Advocate that we passed last year in?
I do not believe so, but that's something we can certainly do. Take your recommendation on that and.
Yeah,
and
because
connect.
that was a major reason, was like, we needed an office to map across the state, what are some sustainable food sources, where are congregate meals, where, so that people and really the area agencies on aging should be able to refer to that and start to piece together. Like you said, people are eligible. They're not necessarily earned benefits, but I would like to affirm the governor's acknowledgement that food costs have risen. And for all of our seniors that are on fixed income, can be catastrophic. And with the decrease in some of those, pandemic era, meal sources, we have a crisis, and we knew it was coming. That's why we put the Office of Food Advocate in our budget last year. And we need to, be really strategic for all the corners of the state about how we get people, especially in food deserts, to good nutrition meals.
Yeah, thank you for the recommendation. We will definitely connect and thank you for, acknowledging the governor's commitment there. And it's not just a recognition of the increase in food costs, but how important it is to make sure that we're addressing isolation and making sure that our delivery drivers have a check-in with older adults, making sure that our congregate sites get up and running, which is why Senator Lesser's comments are very concerning, and we will follow up directly with figuring out what's happening there. So thank you for that.
Yeah, absolutely. These food delivery and congregate sites are a critical part of decreasing isolation, which is a mental health issue, especially among our seniors. So thank you.
Great, thank you. Not seeing any other hands. Thank you so much for being here.
Thank you.
Next, we'll hear from Darcy Lowell, followed by Sarah Egan. Darcy, you just need to push the button and then the microphone will turn red. There you go.
There we go. Okay, very good. Okay. Good afternoon, Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services Committee. My name is Dr. Darcy Lowell. I am a developmental and behavioral pediatrician trained at Yale and founder of the Child First Model. Thank you so much for the opportunity to testify today in support of House Bill 5454, an act concerning mental health services for young children and their caregivers. The Connecticut evidence-based Child First Model fits perfectly in the description of services referenced in this bill. I'm here today to advocate for short-term funding for Child First for FY25 in order to stop the loss of almost 40% of Child First mental health services for 400 to 500 children and families at this point in time. This is urgent. Child First is a 2-generation intervention which specifically focuses on marginalized families and their children who are suffering from trauma, adversity, abuse, and neglect. These families live with multiple stressors, including poverty, depression, substance misuse, homelessness, violence, and racism. 99% of caregivers and 82% of their children have experienced trauma. 30% of Child First families identify as Black or multiracial, and 43% identify as Latinx. 50 to 60% have past or current DCF involvement. Child First uses a team approach with a licensed mental health clinician and a care coordinator who provide both mental health services and comprehensive care coordination to address the multiple stressors in the life of the family. Families served by Child First have various strong, consistent outcomes over more than 20 years, with decreased child mental health and language problems, decreased maternal depression and PTSD, decreased DCF involvement, and increased use of community services and supports. The key to addressing the mental health crisis in this country is to provide services at the earliest possible time, when the child's brain is growing so very rapidly, and to provide the level of intensity that matches the family's needs and priorities. This prevents much more serious mental health, learning, and health disabilities later on. With the end of the ARPA fund, the Connecticut Child First system is being dismantled, as rigorously trained Child First staff have left because of lack of funding for their positions. Child First is highly cost effective. For every dollar spent on child parent psychotherapy, there is a return on investment of over $13. This helps to avoid intensive and costly mental health services like hospitalization and residential treatment at about $288,000 per year. Fewer families will be involved with DCF and foster care with a lifetime cost of over $210,000. Compare the cost of Child First, a little over $9,000 for both child and parent mental health services and care coordination for the whole family. Child First needs both immediate short-term funding and the development of a collaborative strategy, not only for Child First, but also for a continuum of other early childhood mental health services. That is what the strategic plan should include. This enables children and families to receive the right intensity of services at the right time and in the right place to meet their unique needs. Thank you so much for your attention to this such an important matter. I'll take any questions.
Thank you, Dr. Lowell. And on Tuesday, we heard from a number of providers about the insane waiting lists.
good.
And so we've had a few conversations. Thank you. And
Good.
I know that the program you established does tremendous work here in the state. And so it's very disheartening to know that it is being reduced.
Yes.
Yes, Representative Johnson.
Thank you, Madam Chair, and thank you so much for your work and testimony today. I just wanted to ask you how perhaps your work is integrated with the special education system and how maybe it would if in early childhood in that and in those areas, a birth to 3, if we were to fully provide in those areas, maybe even be able to reduce the overall cost of the special education if the children are addressed early in their
Yes.
in the growth.
Yes, I actually do believe that it does decrease the cost of special education, and Child First providers work very closely with Birth to 3 and with the education system and with the early care and education system itself, which is such an important opportunity for young children. What we see because of the changes that we are seeing in their language development, really marked improvement in language, decrease in emotional and behavioral problems. Many children who would need special education do not have to go into the special education system, and that is certainly a cost savings. Also, we work very closely with Birth to 3. In some cases, we're able to get children into the Birth to 3 system when otherwise they're rejecting those providers. They're telling those providers they don't want them in their homes. And yet, when we can work with the families and help them understand how this is so important to their children, they have changed their minds and are able to engage. It's all about the kind of trust that's built between the family and the Child First providers, and the way they approach them, which is really, what can I do? How can I partner with you? How can I help you? Not telling them what to do, but really encouraging their priorities and making that such a good and helpful partnership. So yes, I think that we definitely could save money there, and that's one of the, I think, critical points.
Thank you so much for that. Thank you, Madam Chair.
Thank you, Representative Johnson. Seeing no other hands, thank you so much for your testimony
Thank
today.
you so much.
Next, we'll hear from Sarah Egan, followed by Howard Savronsky.
Good afternoon. I'm Sarah Egan. I run the state's Office of the Child Advocate, and so happy to be sandwiched between Dr. Lowell and Howard Safransky, my very good colleagues, on such an important issue, because probably the highest need age group and the largest group of children that are underserved in this state from a behavioral health and developmental standpoint are young children. right? And from a mental health standpoint. And it's so unfortunate, as Representative Gilchrist pointed out, that Child First is a Connecticut homegrown innovation that other states around the country have moved to replicate and find sustainable funding for through a combination of state and federal funding. And in Connecticut, the program is collapsing. It's collapsing without having sustainable funding. And some of those numbers are, and our office intersects with these families and these children all the time. The largest cohort of children that come to the attention of DCF are young children under the age of 5. We need services. We need to have a continuum of services that can work with young children and their caregivers. It is the least expensive time to intervene. It is the most effective time to intervene. And it only gets harder and more expensive once children and their families' needs go unmet. From a cost perspective, as Dr. Lowell was saying, $9,000 for Child First. I was at a press conference this morning about DCF Star Homes. That's a $750,000 contract for 6 beds for children whose needs have gone unmet into adolescence. And that's a low cost, right? We're talking about enhancing that level of care. So those are some of the cost differentials we're talking about. And I think there's a real opportunity, and the bill speaks to that, because what it's calling for is creating not just immediate funding to address the near collapse of Child First, which right now has hundreds of families on the waiting list, hundreds. And these are the highest need children and families we serve. You know, young children who have experienced family violence, young children who have experienced abuse and neglect. So we can't have waiting lists, because what else are we providing? And without an identified funding stream now, what happens is that the teams that are out there working with the providers, they're going to leave for other jobs. So that 300 or 250 or however many it is on the waiting list right now, that's going to be double if there isn't a funding solution this budget session, because people need to work and you can't hang on with a program that doesn't have a sustainable funding stream. So, I mean, Child First is a Connecticut innovation. It's not the only service we're going to have to need and build for this population. So the opportunity here is problem solution. The solution is having a multi-agency coordinated plan that ensures there is a continuum of services, from the home visiting that OEC is working to bring to scale, really important initiative, nowhere near where we need to get to yet, to the clinical interventions for our highest need families with children under the age of 6, looking at and maximizing the available federal funding streams, TANF, Medicaid, Title IV-E. So we're getting the bang for our buck, right, with those dollars. And then looking and ensuring that we have, and I don't know that the bill speaks to this, but it could, the broadest eligibility criteria, right? A 1-year-old may not have a DSM diagnosis, right? But they may have a developmental need. They may have needed as an early intervention service. The parent may have a diagnosis. So states have taken different approaches, some very broad, in determining eligibility for this type of service on a developmental scale. One state, Oregon, made it so that if you had been involved with DCF and had been abused or neglected, that a history of abuse, neglect in a young child was an eligibility criteria. That's what we need, right? So you don't have to wait for a diagnosis in order to bring in this type of intervention. North Carolina went to an EPSDT case rate for Child First that I can tell you is a lot less than what a lot of other services at the deeper end that we pay for. So I think it's an opportunity to look at what is the service array we want to have for children 0 to 6 and their families, establishing broad eligibility criteria to maximize the opportunity for intervention, and establishing a cross-agency plan to ensure braiding and maximization of federal dollars to support a sustainable continuum of care for children, young children, and their caregivers. So we really appreciate your raising this bill. So important. And again, there's no better time to intervene with our young children and our families. Thank you.
Thank you so much. I do not have a question. Were you on, Representative? I just walked in the room.
No, but I do have a question,
Okay.
but you could go first.
No. I will, while I collect myself, 'cause I just walked in, I will gladly turn it over to you, Representative Hughes.
Thank you, Mr. Chair. Thank you so much, Sarah, for your advocacy. I'm just curious, do you have like a ratio? You mentioned some, costs ratio versus downstream cost, which is exponentially. So what I'd like to drill down on is if you're aware of any kind of dollar savings invested in this early group that we could, hang our hat on and really champion that investment as a sustainable part of Connecticut's budget.
So there's actually, Representative Hughes, I really appreciate the question because there's a lot documented
Yeah.
on the cost savings. And I know that Dr. Lowell's testimony references that. But something I could forward to you and to the whole committee is when North Carolina created when I said EPSDT case rate, what I meant by that was under Medicaid, and I testified about this on Tuesday, children have a broad entitlement under Medicaid's early periodic screening, diagnosis, and treatment mandate to any service that they are screened for that they need, et cetera, right? So one of the points I forgot to make today, that was in my notes, is that Connecticut has a legal obligation to its Medicaid covered children to ensure that children who need a service like Child First access it, right? We're not in compliance with that requirement. So that being said, what North Carolina did is they created an EPSDT case rate for Child First that establishes the eligibility, what the services are. And as part of their documented case rate, they walk through painstakingly all the cost benefit analysis.
Oh,
And so I think that's a good thing to share. I'll make sure it's up to date and that has the best information, and I'll share it with the whole committee and, for your review.
that would be helpful rather than our anecdotal evidence, which we know is out there as well. But in terms of a sustainable funding investment, if you will, and that broad eligibility for the screening, and then we can figure out what services they need. But we do hear you. We heard you on Tuesday that the system is collapsing and the private providers are leaving. And so we're trying to mandate that they get assessed, but without the providers, that doesn't really help, does it? So
That's right.
thank you for your testimony. Thank you, Mr. Chair.
Thank you, Representative. Other questions? Representative Johnson.
Thank you so much, Mr. Chair, and thank you so much for your work and your testimony today. I wondered, you mentioned the interagency working, and I wondered if you had some language recommendations for the interagency changes, agreements that they could make so that we'd have a more comprehensive way to make referrals and make sure that the EPSDT, for example, is followed throughout all the agencies, particularly when you have somebody on Medicaid. So I was just wondering if you had language like that and we could share it with the committee at some point.
Absolutely.
Thank you.
So the bill, Representative Johnson, calls for an interagency plan and funding stream, which I think is, I'm going to take another look at the language because I don't recall that it spoke to establishing broad eligibility criteria, which I think is very important to do, right? The narrower we go, the more missed opportunity that we have. But I'll take a look at that. And if we have anything, I can propose it. But the multi-agency aspect of it is imperative, right? Because we need to look at this at a system level, right? And one of the reasons Child First is not collapsing by design, it's collapsing by default, right? Because it doesn't belong to anybody within our system design, right? And so every agency has its good priorities that it's working on. But we need to be looking at our whole system from up here, behavioral health from birth to 21. I mean, and then on, but birth to 21, right? So, and the funding streams are different. So not everyone is going to be Medicaid covered. So there's going to have to be other funding streams besides Medicaid, though a high percentage of children eligible for Child First will likely be Medicaid covered. But I appreciate the question. I understood the point you're making.
I thank you for that and look forward to seeing how you would create those agreements between the agencies. Thank you, Mr. Chair.
Thank you, Representative. Any other questions from members of the committee? If not, thank you for your testimonies. Next, I'm going to lean on my clerk here for the moment. Oh, great. Howard Safransky, hello.
Good afternoon. Senator Lesser, Senator Seminara, members of the Human Services Committee. I want to thank you for the opportunity of submitting testimony today in support of House Bill 5454. My name is Howard Sobronsky, and I'm the Chief Behavioral Health Officer at Connecticut Children's. Connecticut Children's is a nationally recognized 205-bed non-for-profit children's hospital driving innovation in pediatrics. We're the only health system in Connecticut dedicated exclusively to the care of children. We're also the state's largest provider of emergency services for children in our emergency room. And we have a firsthand look at the impact this child mental health crisis has had on our kids and families. The states must support more innovative policies that lead to a comprehensive and integrated behavioral health system. And that support requires significant investment. HB 5454 directs relevant state agencies to collaborate in drafting a strategic plan to maximize state and federal funds for mental health services for children 6 years and younger, their caregivers, and pregnant persons. As pediatric providers, we recognize that mental health care is an integral part of a child's overall health. As important is the role of caregivers. Positive health outcomes demand a proactive approach to educate, support, and engage caregivers who are key influencers of child's health and mental health. Connecticut Children is the state's largest pediatric care provider, specifically in neonatal care and medical care for children. With mental health providers embedded in all of our ambulatory medical clinics, we are keenly aware of the behavioral health risks facing many of our children and families. The growing recognition of the risks associated with early childhood trauma, coupled with the children's behavioral health crisis, underscores the need for early screening and intervention that will help children avoid the need for higher levels of care, as illustrated today by the 31 children in our emergency room, 22 of them awaiting higher levels of care. We applaud the state legislature for its significant investment in children's behavioral health made in recent legislative sessions. However, our children's behavioral health system continues to be overburdened and under-resourced. This moment requires bold leadership in support of our kids' futures. Connecticut Children's remains eager to partner and serve as a resource to our legislators as you continue to think through legislation and investments related to mental health support for families and kids. We applaud this effort, which will encourage greater collaboration among children serving agencies to find bold and innovative ways of supporting our young children and caregivers. Thank you very much.
Thank you, Howard, for your testimony. It's good to see you. I'm sorry we don't have some of our colleagues who are particularly involved in the TCB task force, who I know are looking to work with your organization and others to make sure that we're finding the funds and making that investment that you're outlining. Representative Johnson.
Thank you, Mr. Chair. Thank you so much for your work and your testimony. And because you're CEO in Children's Hospital, I just wondered if you could tell us a little bit about the patient mix with respect to Medicaid versus private insurance.
Thank you for that question. I'm the Chief Behavioral Health Officer, not the CEO.
I was going to say we missed that news, but
right. But thank you for the promotion. I think the mix generally, I don't have the exact numbers before me, but we're seeing mostly probably like 60-40% overall in the hospital, Medicaid to commercial insurance. The mix of kids in our ED it's a wide spectrum of children, both public who are receiving public mental health services, many receiving private mental health services, many receiving no mental health services, many insured, some not insured. But what's most interesting are the kids that have been showing up for the last 3 years who previously would never have experienced the mental health crisis. But given the various influences in our community through the pandemic, through what's going on in schools, more and more kids who previously would not have been seen in this emergency setting are appearing in crisis. And let me just say one more thing, that the issue really has to do with the throughput of our system, that kids are spending more times in our emergency room because they're waiting longer for inpatient beds. They can't get into inpatient beds because kids on the inpatient unit are being delayed discharge because there are insufficient services in the community to meet with their needs upon discharge. So it's not a question of more beds. It's a question of looking at, as Sarah pointed out, the whole system of care that exists to serve kids and families in this state.
And thank you for that. And just a quick follow-up on the patient mix aspect. In terms of processing the claims, do you find a difference between the Medicaid processing and the private processing of claims? If you know this, I don't know.
I don't, frankly, I don't deal directly with the billing and the processing. We're sort of blind to insurance in terms of treating kids equally, whether they have commercial or not.
Oh, that wasn't the point. The point
Right.
was just with respect to patient mix, how does that influence, your capacity and your overall capacity? So if you have access to that information, I think it would be helpful for the committee to take a peek at. So just a thought in terms of, I know patient mix is a real problem in terms of, although, especially after we just got our Medicaid funding study where the increases have not been going on. They have been indexed and they should be, I believe. So for those reasons, I just wondered if there had been, a take, how do you deal with patient mix, I guess is the final
Okay.
question.
In 10 words or less, right?
Absolutely.
Let me just say this. I think it's widely recognized that Medicaid rates don't come close to covering actual costs. So the more Medicaid patients we have, the greater risk of a deficit occurring. And the more we have to, along with all the other agencies, try to make up that difference through other sources. And I think that's really the challenge that we're facing in the Medicaid conversation. And the other thing I would say is that we do know that treating children costs more than treating adults. And we can't lose the fact that rates need to reflect the different costs associated with the populations that we're treating.
Now you made me ask one more quick question. Why do children cost more than adults?
Why is children live in a network of care. So when you're treating a child, you're treating their family. You must get involved in interacting with school systems, with sometimes criminal justice systems, with other healthcare providers. So your need to properly address the needs of children and families goes way beyond what you often need to do in treating with a single adult. And I don't think we often recognize that burden, not a burden, but that necessity to provide quality care to children and their families.
Thank you so much for that. Thank you, Mr. Chair.
Thank you, Representative Senator Seminar.
Thank you, Mr. Chair. I'm just really wanted to make a comment and thank you very much for raising the issue that there are children who are being detained in hospitals because we do not have services on the outside for them. There are people who are in I was appalled the other night during testimony where one young woman said that she was in the hospital for 4 years, 2 separate hospitals, but for 4 years because they couldn't find appropriate placement for her on the outside, once being discharged. She didn't need that level of care anymore, but there was no other level of care on the outside that was appropriate for her. So there she stood. And I think very often people forget that, or people feel that now that COVID is over, that's not the case. So I'm so very happy to hear, or I'm not happy to hear that we're in that situation, but I appreciate you raising that awareness to everybody yet again. Thank you
for
so
that,
much.
Senator.
Any other comments, questions, members of the committee? Seeing none. Thank you very much for your testimony.
Okay, thank you.
Next, we'll hear from Mary Painter, followed by Tracy Wodach, followed by Representative Acker. Good afternoon.
Good afternoon. Hello, Senator Lesser, Representative Gilchrist, and all of you distinguished members of the Human Services Committee. I'm Marie Painter, State Long-Term Care Ombudsman, and I'd like to testify regarding HB 4557. I support this bill as I've witnessed firsthand the challenges that both residents and family members have had in their ability to navigate the complexities of securing a long-term care bed. The existing system is outdated, and most facilities are not currently keeping an appropriate wait list. The provisions will allow skilled nursing facilities to modernize and improve the process of managing admissions as well as wait lists and inquiries. By moving to an electronic waitlist system, we'll ensure greater transparency, efficiency, and accessibility, making it easier for applicants and their representatives to understand their position as well as the status of their application. This modernization is crucial in an era where technology plays such a fundamental role in how information is managed and communicated to others. Under the current system, accessing or reviewing waitlist records is cumbersome, time-consuming, and often not conducive to a timely process or easily accessible to get the information. With an electronic methodology, investigators or ombudsmen will likely have expedited access to accurate and updated records as needed to ensure a rapid response and ensuring that any issues can be addressed promptly. In addition to modernizing transparency, I'd also like to applaud the specific provisions that make the mandate develop and implement policies and procedures related to this wait list. These provisions address how they're going to have a substantially complete applications and the steps for safeguarding the privacy and ensuring the integrity of the wait list, which is incredibly important to me. Specifically requiring that they articulate how they're going to be able to do that. These measures not only protect the privacy and dignity of applicants, but also enhance the efficiency related to the overall process. Also, the provision that individuals on the wait list have a clear criteria for managing these lists will help addressing the long-standing issues of clarity and communication that have plagued the system and made it challenging for individuals to understand where they are on the list and when they can anticipate being accepted. For this, I thank you and I support this bill.
Thank you very much for your testimony and for your work on the task force that led to the bill and the bill itself. And I think this is the only bill we're considering today, maybe all year, that everybody seems to like. So good job.
There was good collaboration from advocates as well as the industry on this. And I think we worked really hard to come to a place where we can move something forward that I think will benefit everyone.
Cool. Any questions or comments from members of the committee? If not, good work on this. Thank you for everything that went into it.
Thank you.
Actually, I no, you're good. But I did make a mistake earlier. This will not be the last mistake of the day. But actually, we're going to hear not from Tracy next, but from Anderson Curtis, followed by Representative Ackert, and then we'll go to Tracy.
Good afternoon to the chairs of the Human Services Committee and the rest of the committee. I asked the clerk to hand out a photo that I took. So that the word fatal is like a couple blocks from my house on the side of a building. And the other picture is two people sleeping in a doorway that I took from a bus. And I see these things because I was once homeless myself. Senator Lesser, Representative Gilchrist, Ranking Members Seminara and Case, and other members of the Human Services Committee. My name is Anderson Curtis. I'm the Senior Policy Organizer of the American Civil Liberties Union of Connecticut. I'm testifying in support of House Bill 5458, an act concerning homelessness. I am a non-traditional, I have experienced homelessness, member of the Connecticut Coalition in Homelessness. The ACLU of Connecticut and the Coalition in Homelessness believe in a society where all people, including those who have been convicted or accused of a crime, have equal opportunity to contribute to their communities and build successful and fulfilling lives. Connecticut is stronger and safer when all people have a fair chance of accessing housing. People who are formerly incarcerated are nearly 10 times more likely to be homeless than any other members of the public. I myself was discharged into homelessness after serving my last period of incarceration in 2007. Rates of homelessness are especially high among people of color and women with criminal records. Across the country, almost 50,000 people a year enter homelessness shelters directly from incarceration. The reasons for these appalling high rates of homelessness among people with criminal records are complex and many, fueled by systematic racism, but discrimination by landlords, inadequate reentry services, and underfunded transition services upon a person's end of sentence are contributing factors. Connecticut needs to invest in housing programs and services specifically for people leaving incarceration. The state also needs to remove barriers that make it impossible for a person to rejoin their family at home at the end of their sentence. I support House Bill 5458, which will require the commissioners of social services, housing, and mental health and addiction services to report on the metrics related to health, housing, and economic stability in the Connecticut Housing Engagement and Support Services, and identify Medicaid waiver programs or state plan amendments to address social determinants of health. I support this bill as a step towards ending homelessness in Connecticut, and I encourage the committee to do the same.
Thank you for your testimony. Thank you for sharing your story. Glad you're back on your feet now, but that you haven't forgotten what you went through, and you're working to make sure that other people don't go through that. One of the things that we've heard is that the federal government for the first time is we're not the housing committee, that we're not the main committee that deals with homelessness, but it definitely touches on what we do, and it's tied to what we do. And in fact, the federal Medicaid program now allows us to access, in some cases, it's allowing states to provide up to 6 months of housing assistance through the Medicaid program. We're not using that yet, but you would encourage us to look at that?
Definitely, and,
Okay.
and especially the chess program. I actually responded to an ad when I lived in New Haven, and I moved in with a man. He had a voucher for the chess program in Hamden. I was working for Community Partners in Action at the time, and I went to the Walgreens and I bought myself a T-shirt because I had moved to Hamden and said Hamden. I bought him one. I came back to the apartment and I gave it to him, and he looked like he wanted to cry. He said, "Nobody's given me anything in almost 10 years." And, and that was when I began to realize what I was seeing, I stayed there for about 3 or 4 months until I could get my own place. But again, I did have some experience with that program. He informed me about the program. And so part of what I'm doing today is sharing not only my life experience, my advocacy, about things that are very important to all of us. And, safer and fairer for Connecticut is best for everybody. Thank you for your time.
On Tuesday, we're going to be holding a joint hearing with our friends over Appropriations Committee on the justice involved waiver.
Okay.
You coming back for that? That's about making sure that we have housing and Medicaid supports for people coming out of correctional settings, and we're going to make a difference on that. But we got to hear from people. So I hope you're back here on Tuesday.
I will be there. I never turn on an invitation. Thank you.
Sounds. I'm sure our Senator Austin and Representative Walker are going to be thankful that I bring more people to they're here. Yes, Representative Gilchrist.
Just a comment, Senator. Still good to see you, and just wanted to say it's always a pleasure to see you in the building, and I continue to learn from you. So thank you for being here.
Thank you.
Representative.
Thank you, Anderson. I concur with my colleagues. I see that in this bill, it asks for a strategic plan for the outcomes by October 1st, 2024. Are you hoping to contribute some suggestions to that strategic plan?
Definitely. I'm willing to work with and bring, what's fair, reasonable, and equitable for everyone. It's not just about people with incarceration, even though we know we are disproportionately, kind of rejected when we come home. But, I wear a shirt that says people, not prison. So I believe everybody needs a fair shot.
So that is requiring the DSS and DEMIS commissioners, and I would love for your input to be, passed along to them in terms of developing that strategic plan, because people with the lived experience have the best solutions.
Thank you. I would definitely be willing to contribute.
All right. Thank you. Thank you, Mr. Chair.
Thank you, Representative. Any other questions, comments from members of the committee? Seeing none, thank you for being here.
All right. Thank you.
Representative Ackert. followed by Tracy Wodak, followed by. I'm not sure, but we'll get there.
Good afternoon,
Good
Senator
afternoon.
Lesser, Senator Gaston, Senator Seminara, Representative Gilchrist, Representative Dathan, Representative Case, and other esteemed members of the Human Services Committee. My name is Tim Acker, and I represent the 8th District, which includes Bolton, Columbia, Coventry, Lebanon, and Tolland. Thank you for scheduling a public hearing on the following bill, raise House Bill 5427, an act concerning non-emergency medical transportation. I am here with Kimberly O'Halloran, a constituent and owner of Halo Transportation, a new women-owned business in Bolton, Connecticut. We are here in support of the F endorsement, which would provide accountability and transparency in a needed field, I believe. And I think one of the areas that was brought up, it's great to have the conversation that you've had already on some of this, and the delay. One of the piece before I let Kimberly weigh in is the piece that may be a little delay and maybe a time that you need to get everybody caught up and get that F endorsement that the commissioner did mention. But I think it's a piece that is important. I would now like to turn it over, Mr. Chair and Madam Chair, to Kimberly, the owner of one of the businesses, to talk about it and also bring in some of the concerns that she has of the operation of what's going on right now with the transportation of this. Thank you, Mr. Chair, Madam Chair.
Good afternoon, all. I'm Kimberly O'Halloran with Halo Transportation, co-owner. Our business just opened June 27th of 2023. And my partner, Suzanne, and I have 3 livery vehicles out on the road. And I appreciate what I heard from Representative Cook over there about the safety of the endorsement. I can tell you I've been in the industry for 7 years now, and I've worked with one of the largest transportation companies, and I learned a tremendous amount of information. I too am contracted with MTM, so I fully understand the credentialing that takes place. And I can tell you that it's a very, very expensive operation, and it is a critical need of transportation. So what I had to endure as an owner is I had to apply for the livery permit through the Department of Transportation, which took some time getting approved. And then I reached out to MTM and got a letter of support stating that there was a need for transportation. But before I could be a driver, I had to apply for an F endorsement. The F endorsement entails application, fingerprinting, DOT physical, sex offender registry, which we heard about. And what else? As a company, we have to carry $1.5 million of car insurance, which costs for 3 cars a month, $5,000, starting off, and only investing in your own pocket, $30,000. It was depleted rather quickly. We also have to carry general liability, workman's comp. We had to be approved through the Department of Social Services to receive third-party payment and get a NPI number. So it's very heart-wrenching to hear that Lyft and Uber is accepted as a provider when we, state of Connecticut residents, are paying a tremendous amount of money with a bleeding heart for a critical need. And I am not only an owner, but I get up every morning and go out and transport people to the methadone clinics. Okay, there's 4 tiers to methadone clinics. We as providers go out. If those tiers are not updated in the system, we are chasing no fares. Therefore, your dialysis people are sitting 3, 4, 5, 8, however many hours, because the system of MTM is broken. It's been broken with Veo. They don't update the information in their system. Therefore, we as the provider are penalized and we do not get reimbursed for going and picking up no fares. What I'm learning from my riders is everything that's been addressed today so far on this table, from hunger, from, needing DCF help, from needing just tremendous amount of things. I had a girl in my back seat tell me that she has in her folder listed, she does not want rides from Lyft. My ride was taken after I confirmed the ride and it was given to a Lyft driver. Her folder was marked. She didn't go for her treatment. Okay. So there are a lot of issues. Transportation, Northeast region, they just currently had a CT hackathon. The hackathon entails no transportation out there in the Northeast region. They're in the process. They've submitted proposals for funding for us to get out there and start being providers. Lyft is great in a pinch, but when you're doing this on a reoccurring daily basis and they don't have the credentials that cost what we providers had to put out, that's discouraging. So, I mean, I can go on for days. What I heard today and the gentleman with his testimony, I could give you a testimony. But I mean, I can, however I can help. I'm here to help. I want to be a part of the solution.
Thank you for telling your story and for offering to be part of the solution. Representative Acker, did you have something you wanted to add?
Yeah, I just wanted to follow up on that. I think one of the things that we all care about is transportation for those that need it. But also the viability of the providers that go out. In this case here, I've learned more about transportation of non-medical, and we've heard this, that so often people are using our ambulances for medical for transportation when they don't really need them. But also in the case where they're assigned a job and either the client's not there or there's been someone picked them up instead. And so there's got to be some way that, information has got to be valuable for these providers and obviously the bigger question is those that are waiting for that ride, that are looking for, and that's something that Kimberly had mentioned to me is, they go on and get a pool of jobs. And if a third of them are no-shows, the other ones that they've actually could have served in that case aren't being served. So just an area that I think we needed. I don't know if it's a we thing here as a legislature, but got to look at where we can be best supportive. So I thank you for allowing the time and look forward to any question.
Thank you. Representative Gilchrist.
Thank you, Senator. Thank you both for being here. I've had a lot of folks reach out on both sides, livery providers, and then also healthcare entities and folks needing the services. And there is currently an RFP out for non-emergency medical transportation. And so, we'll see, right, like who the next vendor is. But my concerns, based on what I've heard, I think I would hate for someone to get hurt, but my fear is that, we have a contract, right? So at the end of the day, it is our responsibility as the state to make sure folks get to their medical appointments safely.
Good point.
And based on what I've been learning and hearing, I'm nervous about that. And I think rightfully so. What you were explaining, could you please talk me through again, who requires you to get that your employees aren't on the sex offender registry? I mean, I like all of those steps taken. So who is requiring that?
That's part of the process with the DMV, but it's also a part of the process with MTM. So that's why I'm a little confused as to why Uber and Lyft would be able to operate without an F endorsement. It's not just a regular driver's license. You need to have an F endorsement or you have to have a V endorsement to transport children. That's the way it goes.
So currently there is a difference between what we are requiring of the independent contractors and the livery providers.
Correct.
Okay. Thank
And
you.
the livery drivers are paying, the livery companies are paying a lot of money.
Yes.
And the drivers are being taken and we're going to be out of business.
And to your, and where I'm like, also there's a more of a safety protocol.
Correct. Yes.
which
These
when we are
people, I mean, I'm a
for
bleeding.
vulnerable people and children, I'd like there
Yeah.
to be, yeah.
Yeah. And you mentioned the sex offender in the healthcare, but we should also have that information in our order when we're transporting these people. If we're taking them to methadone clinics, what's to say? I mean, I have a plastic shield in all my cars in between my driver and my passenger. But what's to say one of my drivers don't get killed because they were a sex offender and we're women owned? I mean, and I'm not being prejudiced over that. No, you're right. And during the pandemic, I worked for one of the largest transportation companies, and all I kept hearing on the news was healthcare workers and this worker and that worker, and I didn't hear anything about transportation. And we didn't miss a day of work, and many people risked their lives going out there.
Thank you.
You're
Thank
welcome.
you very much.
Thank you, Representative. Representative Cook.
Thank you, Mr. Chairman. Representative Ackert and Kim, thank you both for being here. And I know you were sitting in when I was asking some questions earlier. And so one of my questions for you would be, as you talk about your licensing and the whole certification to be able to drive and pick up, what do you have to learn, and what is the training for folks to get in and out of your car? People with wheelchairs, people with walkers, disability, a variety of things. Do you have training, or is there any training requirements for that?
So with MTM, they do send you a link, and our drivers have to watch a 3-hour video on how to transport people. So we're building our library. As I mentioned, we just started July 1st. So we're building our library in order to continuously keep our drivers educated on what to expect in certain situations. We only currently have 3 sedans. We would love nothing more to have a wheelchair van, but we have the 3 sedans. So we don't really pay attention too closely to the wheelchair. It's more of situations that occur in sedans. But back to your question, MTM does give you that link. You are required to follow through, and you get a certificate at the end saying that you completed. And then when you renew your contract, all those trainings have to be done as well.
And so forgive me for not knowing this, but I don't do the transportation. So if I'm sitting there and I'm in front of this computer screen and I'm watching this video, who's to say that I walk away from and this is not to throw you under the bus. I'm trying to understand what we're requiring and where we need to go. I'm not trying to make it more burdensome for the people that are following the rules, but I'm really trying to separate out the people that are following the rules and the people that are getting away with no rules. So if you could maybe walk us through that for a second.
So yes, I would agree with you, Michelle, as far as the training. The link is given to the potential driver, and we send that to them. Now they tell us we've completed and they get that certificate. However, being that you are transporting vulnerable people, a majority of them in an underserved population, I believe that the training should be in a more controlled atmosphere. So that way, you know for sure that your driver sat and watched that boring 3-hour video. I mean, and not that it's boring, but you also know, the repercussion. For me as an owner, for me as a provider, for me as a driver, for me as a person who cares about the people, I can honestly say that I watched the video. However, maybe my potential driver that I just hired, I don't know. I'm taking his word that, you get that certificate.
So thank you for answering that. And the reason why I asked that question is so when you take your real estate license test, it is on a computer. If you walk away from your computer, you fail the test because there's somebody literally sitting there watching you watch that screen. So not that there is an importance versus one way or the other when we talk about what profession or not, but they're not transporting people. They're not putting people in potentially in harm's way. But yet we're kicking you out of a real estate license test if you're walking away from your screen. And we're not following up with that in this regard. And so when we talk about how we better this system, how we make it patient friendly, consumer friendly, as opposed to willy-nilly friendly, for the people that are doing it in a way that really kind of skirts our requirements, I think we do have a moral and ethical responsibility to alter that. Now, I do apologize if it makes things just a tad bit harder for you in the big scheme of things, but I also think that that might be a conversation for your insurance companies if you turn around and said, we did all of these trainings and here's what we're certified in, as opposed to, I don't have any certification. So
When you're transporting elderly, I mean, or children, or anybody for that matter, I also feel that we should be CPR certified. Just saying.
on a side note, we don't require our bus drivers to do that either.
Yeah.
So, but thank you. And thank you for being here, and shout out for a woman-owned business. Greatly appreciate that too. Thank you, Mr. Chairman.
Thank you, Representative. Any other, Senator Seminar?
Oh, I just wanted to provide a comment. I wanted to thank you very much for providing services to the Northwest Corner. That's where I represent. I am very, very, very well aware of the transportation desert that exists up there, and very much appreciate for you to extend your services to the people there.
Thank you. And what I can add to that is that we did present a model that has been working for Nutmeg Senior Rides, and our team came in second place in hopes that once we get the transportation moving in the Northeast Corner, we'll have involvement in there too.
Yeah, and thank you for all you do in this committee. Really appreciate it. It's been about a decade since I've been here and I kind of miss it. So, but thank you for what you do.
You can't stay too long or we'll put you back on it. Thank you, Representative. Good to see you. Next up, we have Tracy Wodach. Hello, Tracy.
Good afternoon. Yep. Good afternoon, Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services Committee. My name is Tracy Wodach, President and CEO of the Connecticut Association for Healthcare at Home. I'm also an RN with 40 years experience. The Connecticut Association for Healthcare at Home is the united voice for our licensed home health and hospice agencies, as well as several non-medical homemaker companion agencies. Together, our members provide services that foster cost-effective home care for Connecticut's Medicaid population in the setting they prefer most, their own homes. I'm here today to support, with amendments, SB 365, an act concerning safety in the healthcare workforce. As recent tragic events have highlighted, there is a critical need for the state to partner with our members by investing in initiatives in a broader effort to strengthen the safety of our workers. We must remind you that our nurses and all home care visit staff are not working in institutions in which security can be managed and controlled. Our members are entering private homes and neighborhoods without having control over who else besides the patient or client may be present, or even control over the safety of the physical location. The association is pleased to see the funding support outlined in this bill. Specifically, we support Section 2 requiring the home health care agencies and hospice agencies, among others, who receive reimbursement under the Medical Assistance Program to adopt and implement health and safety training curriculum for home care workers using the NEOSH and OSHA endorsed standards. However, in searching for such endorsed standards, the only home care worker specific resource I could find was a NEOSH flyer or handout, Fast Facts for Home Health Care Workers. I left a link in my written testimony. This was published in 2012. This document is a comprehensive guidance document, but I'm not sure it would be considered endorsed standards. I can say that our home health and hospice provider members already offer training that includes best practices aligning with these tips. We recommend using this resource as guidance for training versus deeming it endorsed, but it's also allowed providers to broaden their curriculum as necessary to incorporate, but also we ask that you allow us to broaden our curriculum as necessary to incorporate best practice resources to home care safety and workplace violence prevention, as we do now. The association strongly supports the inclusion of Section 3, which requires the Medicaid agency to increase fee payable to home health care agencies and hospice agencies providing escorts for safety purposes for staff conducting home visits. We also ask for funding to cover options beyond escorts, such as personal safety devices or other technological safety mechanisms, similar to what Commissioner Barton Reeves mentioned in her testimony. We also ask that you go beyond the home health and hospice providers and include other home-based providers. That has also been discussed today. Our homemaker companion agencies need to also be safe and trained. After nearly 2 decades of flat funding in Medicaid, our members are not able to invest the necessary resources to do this on their own. As such, we are appreciative of this section and strongly urge that the required funding be included in the budget adjustments this year so that these agencies have the ability to comply with this proposed requirement. We look forward to continuing our support of this bill and provided that the full funding required to implement this is included in the adopted budget. Thank you very much.
Thank you, Tracy, for your testimony, and I thank you again for your work with the chairs of this committee and with others on improving safety after the tragic event in Wyndham. I will obviously keep those lines of communication open as we head towards through this committee's deadline and then over to the appropriations process. Representative.
Thank you.
Thank you. Thank you, Tracy. Thank you for really participating in all the working groups to really come out with some good recommendations. Do you, in anticipation of the Appropriations Committee review, do you have any estimates, especially for that personal safety device that you're recommending that we provide funding for? Is that at all something that your group could estimate?
Well, I think one of the things as we go through the other bills that we'll be hearing, the work group to look at other safety options would give us a much better idea. We've been, ever since the death of tragic death of Joyce Grayson, several of our agencies have been trialing various risk assessment tools. We've done that before, but now with so much more intensity, trying to determine the most efficient and best ways to establish risk of the clients that we need to see and put in necessary safety precautions, whether it be escorts or safety devices, GPS trackers, et cetera. None of them come with an easy one-size-fits-all process. We have to look at each client individually, what the risks are, what the potentials. An escort may be good for one, a safety device for other neighborhood situations or crime locations. So it's hard for us to put a dollar amount on that at this point. I do know that Public Health Committee put forward in, I think, 369, the some funding for DPH for grant programming for that. I think was just $1 million, which I do not believe would be enough to cover what our agency needs are. But I do not have a dollar amount on that, Rep. Hughes, and I'm sorry. It's just still such a moving target for us.
Sure, thank you, and that's helpful. Are you implementing a risk screening now for your home health folks?
Yeah. Yes, almost all of our agencies have some level of risk assessment. The screening includes questions, many of the questions that are in Senate Bill 369 and also in Senate Bill 1, but really looking at a history of violence, substance abuse, domestic abuse, restraining orders, parole versus probation, sex offender registry, all those pieces, but that information is not easy to come by. It's as good as the person that's giving us the information. So it makes a high liability on our home health providers to have to try to get that information without some type of transparent database or way of us accessing that information other than interviewing a referral source or the client and their family. We can only put safety precautions in place if we're aware of situations. And it's, I think we really need to work through that process.
and all of that is actual lived experience trying to implement this. So is there a cost associated? I guess that's what I'm getting at now, that we can, build on with that risk screening assessment?
Well, I wish I had one for you, and I need to work more with many of our providers. We have several providers piloting it. I can tell you that they've changed the tool, they've changed the questions multiple times. They're also looking at who is asking the questions, how to streamline it. It's many steps, and one of the biggest concerns we have is that it's slowing down our acceptance process or our raise eyebrows and have to deny a case. So I need to work on getting costs for you, and I don't know how to approach that with the number of agencies that we have and the I would say probably about 5 to 10% of the population that we see would need escorts. But I would not be able to put a dollar amount on that at this point.
No, but what I'm getting at, and maybe we can propose that with my colleagues, is to at least Medicaid cover the administrative costs of the additional time and screening that steps that you're going through, and that's not currently being covered by Medicaid.
Yeah, I guess we're supportive of needing that information, Rep. Hughes, but we are not supportive of the process of the home health care agency having to dig and delve and do everything they can to get that information. We're more supportive of having a transparent, collaborative process with our other healthcare providers and our state agencies, such as the Department of Corrections, the Psych Review Board, et cetera. We cannot hold up many of our admissions, especially when you're looking at hospice. Those patients need to be seen immediately. We can't wait to screen through all those questions and try to still get out and see our patients before their terminal process sets in. So I would really look at more upstream, how we can work collaboratively with our healthcare partners and our state agencies to have that information available. I know Senator Lesser had made some recommendations during some of our meetings for having certain questions on our referral process versus having us have to subjectively try to get those answers.
That's helpful. And thanks for that specificity in terms of moving forward. That's all. Thank you, Mr. Chair.
Thank you.
Thank you, Representative Hughes. Other questions or comments from members of the committee? Seeing none, thank you very much.
Thank you.
Next, we have Catherine Zoll, followed by Cassandra Esposito.
Thank you very much. Good afternoon, Senator Lesser and Representative Gilchrist and the entire committee. My name is Kathy Zoll. I'm the Executive Director of the New London Homeless Hospitality Center and a resident of New London. And I appreciate the opportunity to testify before you today and provide general comments on HB 5458, an act concerning homelessness. We have participated in the CHESS program since its inception and are currently supporting a total of 44 CHESS participants, 21 of whom have secured permanent housing. Multiple studies have confirmed that it is possible to achieve better health outcomes and reduce healthcare spending by helping people address health-related social needs, especially access to stable housing. CHESS is a critical effort to access Medicaid funding to speed progress toward this goal. The potential is great, and many lessons have been learned from our experience to date. As the proposed bill lays out so well, however, fully realizing CHESS potential will require CHESS to evolve. A few areas stand out as particularly important from our experience. First, new rent vouchers for CHESS participants are very welcome, but relying on vouchers alone will not allow us to bring CHESS to the scale required. Creatively combining CHESS services with existing DOH and DEMIS housing resources, such as rapid rehousing, diversion, and supportive housing, would allow us to reach more participants. There are also possibilities for creative partnerships with DSS programs such as residential care homes and Connecticut Housing Finance Agency funded affordable housing projects. As the bill suggests, however, this will require even deeper collaboration between agencies. Next, the pool of housing-focused service providers participating in CHESS needs to be expanded. While DSS staff have been remarkably responsive and helpful, service providers need even greater assistance to allow them to transition from contract-based funding to the very different world of Medicaid fee-for-service. Medicaid is also dauntingly complex. Some of this may be unavoidable, but simplifying administrative requirements could improve participant access to services by increasing the number of housing services providers interested in participating in CHESS. And finally, the use of value-based payments within CHESS represents an important effort to link payments to outcomes, but benchmarks for earning payments need to be updated, and the process for paying value-based payments needs to be more reliable. We are grateful to all who have worked so hard to see how Medicaid funding can help improve health outcomes. The challenge in this new effort has been great, but with a continued commitment to collaboration, process improvement, and innovation, we believe CHESS can become a key tool in improving health outcomes by providing access to housing. We look forward to be part of that effort in any way we can. Thank you for this opportunity to testify.
I thank you for your testimony and for your thoughtful suggestions. We are going to take a look at that and appreciate it. Representative Gilchrist.
Thank you, Senator. Thank you, Kathy, for being here and for participating on the Social Determinants of Health Working Group last summer and fall. And please know that it was actually much of your feedback on CHESS that helped inform this legislation. So I look forward to our continued work together. Thank you.
Thank you, Representative. Other comments or questions from members of the committee? Seeing none, thank you for being here this afternoon. Okay, Cassandra Esposito, followed by Callie Moquette.
Okay, thank you. Good afternoon, Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Case, and esteemed members of the Human Services Committee. My name is Cassandra Esposito, and I am president of the Connecticut Nurses Association. The Connecticut Nurses Association is the state constituent member of the American Nurses Association, and we work to represent nurses in Connecticut across all specialty areas in all practice settings. Thank you for hearing our testimony today. We are in full support of SB 365, an act concerning safety in the healthcare workforce. In a 2019 study by the American Nurses Association, 1 in 4 nurses reported being physically assaulted while at work. As an APRN and former ER nurse, I have been a victim of workplace violence. I've witnessed the acts of violence and what the impact of violence has on our healthcare workforce. SB 365 presents a crucial opportunity to address these concerns and prioritize the safety and well-being of our home healthcare workforce. As nurses, we share a unique bond that connects us to each other. When tragedy strikes one of our own, it reverberates throughout our entire profession. Joyce Grayson was a home care nurse who was killed while providing home care services to her patient in a home. Although many of us did not know Joyce personally, we all know Joyce. She was a nurse, and nurses understand the fear and vulnerability that comes with being a nurse. All nurses deeply felt this tragedy, and it should never happen again. We are thankful the General Assembly has taken this call to action seriously, with multiple bills coming out this session focusing on improving safety in the healthcare workplace. SB 365 emphasizes the importance of training for healthcare providers. This training aims to give nurses the necessary knowledge and skills to assess their safety in situations and provide them with the tools to know what to do should they face an unsafe situation. Providing training helps create a culture of safety and allows nurses and healthcare workers to realize that safety is their top priority. By providing essential funding for escorts, this bill further ensures the safety of the nurse and healthcare workers, as they would be able to access escort services when they need, allowing them to continue to provide care. There is no standardization of best practices. By implementing the Hospital Joint Commission standards, The entire healthcare system is focused on prioritizing safety and preventing workplace violence. This comprehensive approach allows best practices to be shared across the healthcare continuum. As healthcare systems develop plans, they can start to connect the dots between these different areas. This includes hospitals, long-term care facilities, and home care settings. It creates a streamline of an approach to care. I urge you to support this bill for Joyce and for all nurses in Connecticut who have experienced violence in the workplace. I urge you to support this bill to help build a culture that prioritizes safety and ensures access to care while delivering care. I'm happy to answer any questions or follow up and support the committee as this bill moves forward. Thank you.
Thank you, Cassandra. I just want to say that I think we're all very appreciative of the way in which that you and the Connecticut Nurses Association has really stood up after Joyce Grayson's murder to ensure that this never happens again. And your thoughtful engagement over a number of meetings has been very helpful for Senate Bill 1, but also for this bill. And I'm hoping that by working together, we're going to be able to make a difference. We couldn't do it without you. Other questions, members of the committee? Seeing none, thank you very much.
Thank you so much.
Next, we have Callie Moquette, followed by James Williams.
Good afternoon, Senator Lesser, Representative Gilchrist, and esteemed members of the Human Services Committee. Thank you for accepting this testimony in support of SB 395, an act concerning Medicaid budgeting methods and the reporting of medical debt. While my oral testimony will primarily speak to SB 395, our written testimony includes support of SB 313, an act concerning continuous Medicaid eligibility for children under the age of 6. My name is Callie Moquette, and I am submitting this testimony on behalf of Health Equity Solutions, a nonprofit organization with a statewide focus on advancing health equity through anti-racist policies and practices, where I serve as a senior manager of policy. Our vision is for every Connecticut resident to attain optimal health, regardless of race, ethnicity, or socioeconomic status. Regarding SB 395, medical debt is an escalating concern, which poses a significant threat to the financial stability and well-being of individuals, particularly those from continuously marginalized communities. It disproportionately affects Black and Latino individuals at rates exceeding the population average, compounding existing disparities in wealth and access to healthcare. As such, HES strongly supports Section 1 and Section 2 of SB 395, which seeks to prohibit the reporting of medical debt to credit rating agencies. Minnesota, New York, and Colorado have already enacted this patient protection to prohibit hospitals and debt collectors from reporting medical debt to credit reporting agencies. Additionally, HES recommends the incorporation of additional measures to screen patients for hospital financial assistance and direct them to the Office of the Healthcare Advocate to address any outstanding medical bills and allowing patients to purchase their medical debt at the rate collection agencies would purchase it. Unlike planned debts, such as mortgages, medical debt often results from unforeseen or emergency medical needs. It's a burden carried by those seeking care in dire circumstances. 72% of people attribute their medical debt to bills from one-time or short-term medical expenses associated with acute care, such as a single hospital stay or treatment for an accident at an hospital. The unpredictability of hospital costs compounds the problem. Even when prices are publicly available, patients often face unexpected out-of-pocket expenses. No one should be subjected to long-term financial insecurity imposed by the reporting of medical debt to credit rating agencies amid already challenging circumstances following a hospital stay or an accident treatment. Patients and their families can be barred from accessing the credit they need by the reporting of medical debt on their credit reports. Even though prior Consumer Protection Financial Bureau research shows that medical debt reported on credit reports is far less reliable and predictive of people's ability to pay their bills going forward. This practice not only threatens the integrity of the credit reporting system, but also perpetuates systemic inequities, limiting access to credit and exacerbating financial hardships for communities of color and individuals with low income. Reporting medical debt to credit rating agencies exacerbates the financial burden faced by individuals already grappling with dire medical and economic circumstances. Once medical debt is handed over to collectors, individuals face a myriad of additional challenges, including diminishing access to credit, an increased likelihood of bankruptcy, and the prospect of confronting costly and protracted collection litigation. The compounding effects of facing higher probabilities of grappling with medical debt to continue to push Black and Latino and other communities of color into financial instability and prevent them from accessing wealth-building opportunities, thereby widening the racial wealth gap. When a single medical expense jeopardizes a person's ability to rent, purchase a home, get a job, or receive credit, it calls for urgent systemic change. HES respectfully urges this community to pass this equity-focused proposal, specifically Section 1 and 2. I direct you to our written testimony, which includes further research and specific recommendations for changes to the language in SB 395. Thank you for the opportunity to submit this testimony in favor of SB 395 and SB 313.
Thank you so much for your testimony. And I don't know if you saw the testimony we received on this from the Connecticut Hospital Association, but it sounds like they're going to do it. They're going to stop going after people's credit as long as we, with some changes. So I think that's potentially a very positive development. So any questions or comments from members of the committee? Seeing none, thank you for your work
Thank
and
you.
your organization's work.
Thank you.
Next up, we have James Williams, followed by Lucy Nolan.
Good afternoon, committee.
Good afternoon.
Good afternoon. Yeah, how you doing? My name is James Williams. I'm a member of the Republican Town Committee of West Haven. I'm here today to show my support for House Bill 5458 to maximize aid to homeless individuals. I want to note that the governor and the legislation body has done a very good job in fighting homelessness. The problem is because of the lack of overseeing the agencies that aid homeless people in Connecticut, and because of the tax and money incentives to helping out homeless people, it has become a business in which a lot of homeless shelters would do the bare minimum to help out a person in crisis and try to get the most funds to and try to get the most funds for their homeless shelter, even though their homeless shelter is in deplorable conditions. Connecticut has to have a place where homeless people can go and be treated with dignity, where they could clean up, get the medical and mental health homeless individuals need, especially for women, because women need access to feminine products because that time of the month is going to come whether they're homeless or not. There also need to be more programs to help individuals before they hit rock bottom and become homeless. This bill, with the right ideas behind it, can do justice for individuals in need. Thank you.
Thank you for your testimony. Are there comments or questions from members of the committee? Seeing none, thank you very much. Next, we have Lucy Nolan, followed by Jessica Elizondo.
Good afternoon, Senator Lesser, Representative Gilchrist, Senator Seminara, and Representative Hughes, and other members who are watching. My name is Lucy Nolan. I am the Policy Director at End Hunger Connecticut, and we are a statewide anti-hunger advocacy and outreach organization. And for 20 plus years, we've been doing outreach and one-on-one assistance to SNAP participants to access their benefits. Today, I'm speaking on SB 364, an act concerning supplemental nutrition assistance. The bill would require DSS to participate in two of the options that the USDA provides states to ease access to SNAP. These provisions, if implemented, could significantly improve the current system and make a real difference in the lives of SNAP participants. The Supplemental Nutrition Assistance Program, or SNAP, is not just a program, but the nation's first defense against hunger. It is a lifeline for almost 400,000 people in Connecticut and 230,000 households. The benefits are dispersed using alphabetical order of people's last names on the first, second, and third day of the month. However, the current system often leads to congestion, including long wait times, frustrating experiences at DSS. We've had people who've just given up because they've been hung up on so many times, or missed calls, whatever. So Section 1 of the bill requires that DSS distribute the benefit at 4 intervals during the month. Staggering the benefits would mean less traffic at DSS during the specific time at the beginning of the month, with recertifications being staggered, and give DSS some breathing room. There's no doubt that given the issues that DSS is currently having, that this could cause some trauma or some problems in the in putting it out there, but as some states, what they do is they stagger as new people come in. And I think that that might be something we should look at. Other reasons why this is a good idea is our grocery stores will not have an influx of customers in the first 4 days of the month. There'll be less of a rush, there'll be more stocked food, access to healthier foods because it's there, and ability for the stores to predict staffing. So it's not only a convenience, but it's practical as well. Section 2 of the legislation provides the Restaurant Meals Program, or the RMP, an option that allows those who are disabled, over 60, homeless, or a spouse of any of those three, to be able to purchase meals at participating restaurants and with SNAP benefits. Currently, hot foods are not allowed to be bought with SNAP. So I just want to say that 40% of Connecticut SNAP participants are in families with members who are disabled or elderly. So I just quickly to sum up, I just want to say that there are 9 states that do it. California started it in the early 2000s. They now made it a statewide, and also Massachusetts only has 12 restaurants. So, but they do allow food trucks. And here's the issue, and I know I'm going over my time, but I just want to say that there's a question about letting chain stores in, but we have to remember when we're working with people with limited incomes, $141 a month for elderly, $149 a month for homeless is the average. And if they don't have a place to go and sit and go to the bathroom, clean up, all those things, and they're cheaper at those larger stores. And so while I appreciate, and I think it's great to say that healthier meals has to be included, I think we have to really not cut out what many of us might think is not healthy food, because it is what people can afford and use.
Thank you. So that's helpful on a number of fronts. Just with regard to the first part, the staggered benefits, what we heard from DSS last year in particular was, because we asked the same question, it was, can we fold this? We don't, the actual transition could be pretty dire if somebody has to go 3 weeks without food when we're transitioning from the first of the month, or the third day of the month to this new plan. And so we asked if we could only do this, phase it in for new enrollees. And DSS said not really, that would be a big administrative burden, and it would be easier to just move everybody at once rather than have to do it multiple times. And I don't know if you've had a chance to talk to them, but that was our question, and we were originally trying to do that, and we had that pushback. That
I haven't talked to them, but I know that that's how Ohio does it.
Okay.
And there are other states that do it. And I will tell you, I was looking at the disbursement of benefits in all the states, and Connecticut is one of the very few that does it like within just those 3 days. Most states have that. They'll do birth dates from 1 to 0. And so there'll be 15 days that, or, whatever, how, sorry, 10 days that it works out throughout that, or they'll do it through, different alphabets. So there are other ways to do it. And I understand that it could be an administrative burden, but I think ultimately it'll help.
we agree, which is why we we voted on it last year. We're hoping to do it, and so hopefully we can do it. But that question about how to handle that handover in a way that doesn't, I mean, I think it may, the fear we have if we move people who are currently receiving it in those 3 days is that you could have, a significant hardship that for 1 month. Is that something? How much should we?
I think that's fair. I think that is a very legitimate concern. When you're talking about people who are getting SNAP benefits, they don't have extra pennies to they really need it when they need it. And that's why there is such a rush on the first, second, third, and fourth day of the month, because people got their benefits and they immediately go to the store, right? And so it is something to be concerned about.
So with regard to the Restaurant Meals Program, we've had a bunch. I hear what you're saying. The pushback that we've gotten has been a fewfold. One, nutrition. Another is making sure that people aren't the term is wasting. I don't know if that's the right term, but that they're not running out of benefits early by, because restaurant meals are more expensive than other meals. And some restaurant meals maybe, there's an affordability issue. And then the third is just cultural appropriateness and sensitivity. So I know that, I was looking at the Massachusetts website, and those restaurants seem, I don't know, to me, like places I would want to go. They sound really interesting places. We were joking about maybe doing a field trip up there to taste some of the food. But I don't know if there's been literature, if you've looked at what works and how we should be thinking about it, because we want to think about this, have this conversation and think about it, but don't want to create a program that we later regret.
Well, I think one of the beauties of Massachusetts is using the food trucks, right? Because that's culturally appropriate food for many people. But the question is, right, then if you are talking about homeless people and that they do need a place to sit in and be warm, right? So I just don't want to make it so people are unable to go into those kinds of places. And also, Massachusetts has a very small, they're only in a couple, as I understand it, a couple cities. And so I would appreciate that it would be statewide for Connecticut, because in many areas, rural areas too, those are the places. There are the small breaks on it being too expensive, no gratuities, no sales tax. The restaurants have to offer a lower price, and there's 3 different ways that it can do it. One is if it's an advertised special for everybody, that can be considered a lower price. So there are things like that. But I think just to be able to have the chance to get a hot meal, because the other thing is, right, where people can't cook, they don't have the materials to cook with. And this way is somebody, they can get something hot and warm and fill their belly when they need it.
Great. Well, nice that you like the idea, and we'll have to work with you
Yeah,
to figure out how to get it right.
idea.
Okay,
As do many advocates that I checked in with across the country who have it.
that's great. Okay. Any questions from members of the committee? Representative Hughes.
Thank you. Thank you, Mr. Chair. Thank you, Lucy, so much. I really appreciate you bringing to this body that it's not just the nutritional aspect, but there's so many more ways in which food and meals, connect with our essential needs as human beings, both socialization, but also, our biological functions. Like, really, we need to take that all into consideration and not just look at how we deposit, certain nutritional, value into people, but really look at that continuum of meals. And hot meals are so important and such a treat for people. If there's any way we can include that, in participating restaurants or food preparers. I know that many of my, as a social worker, many of my isolated elders crave that. They just crave that, even if they do have the capacity to heat something up in their microwave. It's just not the same as actually having that conversation with somebody in a restaurant. Maybe the only people they talk to in person all week. And I think we have to keep in mind the value of that beyond the nutrition. Thank you.
Thank you. I appreciate that. Food and socialization they're intertwined in so many ways. And I just very quickly want to add that I would appreciate, and I'm sure advocates in the homelessness community and other elderly and also a disabled community would like to be part of any planning that DSS does on this. So if you could stick that in the bill, that would be great.
I think we'd be open to that. I think DSS would also.
I sounded
welcome
like
that
it
too.
today, yes.
They have a lot of asks that we've been making of them, so maybe assistance would help them. So thank you.
Thank you.
Other questions from members of the committee? Seeing none, you're good to go. Thank you. Next, Jessica Elizondo, followed by Kara Capone.
Good afternoon, Representative Gilchrist, Senator Lesser, and distinguished members of
Jessica, you look familiar. Have you been around here?
Yes,
I-
I'm an intern with Representative Gilchrist.
I know, I was just, go right ahead.
My name is Jessica Elizondo. I'm a resident of Danbury, Connecticut, and a BSW student at Western Connecticut State University. I first want to thank you for the opportunity to testify today in support of Senate Bill 395, an act concerning Medicaid budgeting methods and the reporting of medical debt. According to a KFF analysis, approximately 1 in 12 adults in the United States have medical debt, with Black and disabled individuals being more likely, as well as low and moderate income families being more likely. I just think Americans should not be in medical debt to begin with. The WHO states that access to medical care is a human right, and individuals shouldn't fear racking up medical debt whenever a doctor sees them. I'd like to share a little bit about my own family experience with medical debt. While being on Connecticut, paying a premium of $750 a month, which only covered 70% and had a $6,000 deductible, my family incurred over $20,000 in medical debt. We have since paid a collection agency monthly for over 4 years. Part of this debt was a time that doctors believed that I might have had a stroke. So I went to an emergency clinic and they thought that I might have had a stroke. They sent me to the ER to do MRI testing, CT testing, things like that. Luckily it wasn't a stroke, thank God. But because of this diagnostic testing, that was really important and critical to make that diagnosis, we had to go into debt. And as a result of this, now every time something happens, I'm, worried, should I go to an ER? Should I go to an emergency clinic? Or, in fear of racking up more medical debt. My mother recently, unfortunately, got divorced, and such our household income has significantly declined, and we're now below 200% of the federal poverty level. As such, we have to kind of change how we budget our money, and we called the collection agency to ask if we could defer payments up until we, kind of got on our feet, and we were told that we couldn't, or else our credit would be impacted. And I'm sure I'm not the only family in Connecticut that has similar issues with this. Families in Connecticut shouldn't have to worry about their credit being impacted based on medical debt. Individuals cannot control when they fall ill and should not have to question whether they should go to the hospital or kind of tough it out in a way. Everyone should have sustainable access to healthcare without fearing medical debt. I pushed the Human Services Committee to vote in favor of Senate Bill 395 to ensure that Connecticut residents receive the care they deserve without fearing medical debt ruining their credit. Senate Bill 395 would ensure that low-income families are further not held back by medical debt. Thank you for giving me the opportunity to testify.
Thank you, Jessica. You were great.
Thank you.
And thanks for having the courage to talk about your story. I'm glad you're doing better. And I will say, the last time we looked at this, it looked like the community that you live in had a particular issue. There were some providers that were being really, one in particular that I'm thinking of, I'm not going to call them out. They were being very aggressive at going after medical debt, and it was resulting in foreclosures and lots of other problems. So I you mentioned it earlier, but I was really gratified to see that the Connecticut Hospital Association says they're not going to do this anymore in response to this legislation, and that's a big deal. So thank you for having for telling your story, and I have a hunch that your legislator is going to say something in a second. Representative Gilchrist.
Thank you, Senator. Thank you, Jessica, for being a valuable asset to the team here at the legislature, before sharing your experience and for testifying today. Well done. Thank you.
Any other questions? If not, thank you. Okay, we're going back to Kara Capone. After Kara, we're going to hear from Catherine Whitney.
Thank you. Good afternoon, Senator Lesser, Representative Gilchrist, and other distinguished members of the Human Services Committee. My name is Kara Capone, and I'm the CEO of Community Housing Advocates, an affiliate organization of both Mercy Housing and Shelter and My Sister's Place, providing housing and homeless services in Hartford and Middlesex counties for over 4,000 men, women, and children annually. I appreciate the opportunity to testify before you today and provide general comment on HB 5458, an act concerning homelessness. The Connecticut Housing Engagement and Support Services, otherwise is known as CHESS initiative, began as a way of improving housing stability and health outcomes for a targeted set of Medicaid recipients who have complex health conditions, have experienced homelessness, and would most likely benefit from targeted housing stabilization services. In reality, it was very similar to what permanent supportive housing providers are doing, including care plan development, as well as pre-tenancy and tenancy sustaining support services. As many permanent supportive housing providers know, housing is healthcare. So pairing CHESS with permanent supportive housing providers seemed like a natural fit. To date, neither Mercy Housing nor My Sister's Place are currently CHESS providers. When originally approached as potential participants, there were some major barriers for organizations to participate. And so the first one is higher reimbursement rates were needed. Reimbursement rates were too low for us to fully participate and not lose money in the process. Both organizations need to fundraise to fill gaps with existing programs. We simply could not afford to take a financial risk. Availability of bridge funding. Since this is a fee-for-service program with payment after service completion and most PSH providers are grant-based, some types of bridge funding would be necessary to jumpstart and staff the program. We're already so short-staffed, it would not be possible to add to already existing overburdened caseloads. Giving a better idea of the estimated numbers of clients to be served, since this is a client choice program, which is a really good thing, it was very difficult to determine the number of clients seeking services from us, and therefore difficult to determine the level of staff to be hired. And then also just a better idea of acuity level of the clients that were intended to be served. So in my experience, the hardest to serve clients are not the clients who consistently show up for their appointments. This is why homeless services have traditionally been grant-based. Under CHESS, if a client doesn't show for an appointment, then the organization cannot bill Medicaid. Therefore, there is a tendency to serve those who are less acute and more likely to be service compliant. And I think this is off the mark. Providers through this pay structure tend to serve the less acute rather than the most acute, who really are the target of this program. So I have submitted my testimony. There's a couple things that I just want to highlight as part of some amendments that I would like to see in support of this bill, which is just updating the definition of social determinants of health to include housing. It was missing from the definition as written. Also, it looks like there was only 3 months allocated to get this done. I don't think that's enough time to actually do a thorough study of what has to happen. An independent consultant. And it's not because I don't think these departments can do the work, they absolutely can, but it's simply a best practice to have somebody come in with an objective viewpoint to really give an overview of what can happen, what needs to be happens, and work plans going forward to ensure it happens. CHESS has the potential to enhance current homeless response system, which is why I'm really interested in making sure that we're able to provide a study that's going to be able to bring more resources into the homeless service system. So I want to thank you all for your time today, and I'd be happy to take any questions if there are any.
Thank you for your testimony and for your thoughtful suggestions. We're going to consider them carefully as we look at this legislation, look to move it forward. And thank you for the work that you do in the communities that I represent. Are there questions or comments from members of the committee? Seeing none, thank you.
Thank you.
Next up, we have Catherine Whitney, followed by Brian Lynch. Again.
Good afternoon, Senator Lessers, Representative Gilchrist, and distinguished members of the Human Services Committee. My name is Catherine Whitney, and I'm a program manager at the Connecticut Coalition to End Homelessness and a resident of Willimantic. I appreciate the opportunity to testify before you today and provide general comment on HB 5458, an act concerning homelessness. I'm not a direct homeless services provider, but I am here as part of the statewide effort to solve homelessness and to support the organizations who serve people experiencing homelessness every day. While we support HB 5458 for the effort to improve the experience for clients and providers participating in the Connecticut Housing Engagement and Support Services, otherwise known as CHESS, there are key amendments that we would like to see, which we believe would make CHESS more effective along the lines of what you heard from my esteemed colleague, Kara. Ensure that the Departments of Social Services and Mental Health and Addiction Services allocate enough time to generate a comprehensive report with actionable results. Ensure that the report includes input from program participants and participating agencies, as well as from agencies who choose not to participate, about the benefits and drawbacks of the CHESS program. make changes to the existing program that might include but should not be limited to a higher reimbursement rate, more upfront funding for providers to cover costs before reimbursement, funding for strategic partnerships with healthcare providers to facilitate onboarding for homeless services staff, and to completely identify all applicable Medicaid waiver programs, and to update the definition of the social determinants of health to include housing, as Kara mentioned. Thank you to the committee for the opportunity to testify, and with your support, we can strengthen and stabilize our state's homeless response system and help make sure Connecticut's residents are healthy and stably housed.
Thank you for your testimony. Representative Hughes, did you have a question? Or?
I just want to make sure you submitted your amendments, right? The recommended which
yes, I have. So I will. Yes.
Thank you.
Thank you. Okay. No other questions. Thank you for your testimony this afternoon. Next up, Brian Lynch, who we have never heard from before, followed by Nicole Foster. No, Brian. Wow, that's a. We'll miss him. Nicole Foster, followed by Bill Scalzi. For those of you who are not Human Services Committee regulars, Dr. Lynch frequently testifies in front of this committee.
Good afternoon, Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services Committee. My name is Nicole Foster. I'm from West Hartford, Connecticut, and I'm here today to provide testimony in support of House Bill 365, an act concerning safety in healthcare workforce. I'm here because I'd like to share my own experience working in home care. My experience working in the medical field as a nurse for 12 years did not quite prepare me as I expected to work in home care. During my tenure as a home care nurse, I experienced firsthand the risks associated with providing care for clients in their homes. I worked for a large home care agency in Connecticut, caring for medically fragile children who required 24/7 care by highly trained nurses. During my time with them, I never received training on personal safety or recognition of hazardous conditions that may lead to potential violence. On a number of occasions, I was put in high-risk situations with no procedure to report my concerns. Without a protocol for reporting events or near misses of violence, many organizations are not tracking the number of incidents. I believe our estimates of risk are much lower than the reality. I did not feel supported when reporting my concerns, nor did I feel that they had a plan to support my safety. The physical and psychological impacts of violence in the workplace do not end when the shift is over. I ultimately made the decision to leave home care because I did not feel safe. I was not willing to risk my well-being or to leave my 3 children without me. Section 2 of this act outlines a detailed plan to establish and maintain training programs for home care workers, including safety training and recognizing hazards. This is just the first step in developing a high-quality long-term plan to support those who care for some of our most vulnerable in our society. I'm here to ask that you please support House Bill 365. Home care workers in Connecticut deserve safe work environments and the support of the state of Connecticut.
Thank you for your testimony.
Thank you.
Good time. Yep, go ahead. Thank you for your testimony. Are there comments or questions from members of the committee? Seeing none, thank you. Next, we have Bill Scalzi, followed by Allison Dvorak.
Hello, everyone. My name is Bill Scalzi. I want to thank the chairs, Lesner and Gilchrist, and the ranking members, Seminara and Case, and the members of the committee for allowing me to speak today. I'm talking to you today about HB 5427. My company is M7, NAMT Transportation Company. We strongly support the minimum driver licensure requirements required under this proposal. By way of introduction, M7 was established in 1987. We're a family-owned business providing non-emergency medical transportation throughout the state of Connecticut. We contract with hospitals, rehab centers, nursing homes, assisted living facilities, et cetera, and also provide service for individuals who just need a ride. Both wheelchair and ambulatory. Half our fleet of 170 cars are all wheelchair accessible, 24/7, 365. There's been a lot of discussion on this today, so I've rearranged a couple of things I want to say, but hearing what I did, I want to point out a couple of things. Anybody who is going to drive for our company has to have an F endorsement or the application for an F endorsement, and I'll explain that in just a little bit. They also have to go through OIG screening to make sure they're not barred from any state or federal contracts. We do a DMV driving history report. We do an online criminal investigation. It's a 7-year national background check, which, as you probably well know, the F endorsement that they're required to have will ultimately do a fingerprint-based check, but we like to know who we're dealing with as much as we possibly can up front. We do a national sex offender registry. That's also required by the F endorsement. And we do drug testing, and that's not required by any of those facilities here in Connecticut. And we review their medical history through their cards. I know they have to present those for the F endorsement, but we check them out before we even get that far. We're licensed and approved by, I'm sorry, not licensed, we're approved by NEMTAC, which is a national accreditation for service standards and safety standards for the NEMT industry. We're the only company in Connecticut to have that certification. There's also been some discussion on cost, so I thought I'd include a report from Florida that came out a few years back, the Florida Transportation Disadvantage Program. And it's, in essence, it says that NEMT services are vital to the health and quality of life for all patients in need of transportation, including Medicaid members. Reliably transporting people to their medical appointments results in a healthier people and a lower healthcare costs. In fact, every dollar spent on quality NEMT services results in a healthcare savings of $11.08, which is just an incredible savings. And they found that not only a quality transportation service is necessary, but they offer a lot of other things like renovations for their home to let them stay home if they have to widen doors for wheelchairs and things like that, a broken air conditioner, and they provide transportation for these people just to go to a bingo game or visit relatives or go out to a restaurant. So they're talking about, somebody else mentioned the SDOH. That's what these folks are all about, or this program's all about, is healthier people, and all this contributes to it. I wanted to start with that, but I want to get on to the F endorsement now. Currently, there's nothing in the statute that specifically addresses the requirements for driving accepting NEMT trips on behalf of contractors or subcontractors with the Department of Social Services. Yet DSS requires every taxi or every driver to be fully compliant with Connecticut General Statutes 14-44, commonly referred to as the F endorsement. And why wouldn't they require that? Everyone else does. Every contract we have with a state or federal agency mandates compliance with CGS 14-44, no matter who we're transporting. DCF requires an F endorsement. School contracts don't require an F endorsement. They require a V endorsement, which is about 2 steps higher. So an F endorsement is required for all passenger transportation in school buses, student transportation vehicles, taxi cabs, motor vehicles and livery service, and motor or bus services. Determining the criminal history, medical background, and drug or alcohol use of the driver is clearly the first and most basic test in providing quality and responsive transportation services. In that regard, TNC drivers under CGS 13B-119A have no requirement to undergo any State Department check at all. In fact, a TNC company can put a driver on the road and send them out to perform NEMT trips.
Sir, I know you're passionate about this issue, but your time has expired. Can you please summarize?
Okay, sorry. I'm going to get right to the bottom line, I guess. The Department of Social Services mandates that a driver, when applying for a license, they give a 90-day, DMV gives them a 90-day grace period, so they can apply and still drive within the 90 days. DSS does not allow that. They want to see the F endorsement. So my statement is this: if everybody is so concerned about having that F endorsement, all right, then why would you ever not want to have the F endorsement? It's put there for a reason. And as previously stated, is required for all passenger transportation for those aforementioned service levels. But remember this, any random TNC passenger making their own decision about the level of safety they're comfortable with, they can make that decision on their own. The Medicaid passenger is forced to accept whatever level of service and safety shows up at their door. This is not intended to be a discussion of TNC versus taxi delivery, rather a request for a uniform compliance standard across the board for all Medicaid passengers. It's nonsensical that a driver who meets all of the TNC standards is still not acceptable in the more strictly regulated taxi industry. Thank you for your attention.
Thank you for your testimony and for your work in helping bring this issue to the committee's attention. One of the questions I think that we're sort of wrestling with, I totally understand what you're asking us to do to set that that floor, but it seems that there's some other potential things that we might consider as well, or separately, or not. One of the issues is when your drivers are applying for that certification, they have to stop driving for a period of time. Is that correct?
Well, no, they can't drive until, as soon as they mail in their application, they're allowed to drive for as long as 90 days because it's going to take up to that long for them to receive their F endorsement. So it's difficult to bring somebody on board in your company when you train them and you say, okay, now you've got to go home for 8 to 10 weeks and wait for you to get your license. So that's why in 2018, DMV put that grace period in there for drivers to alleviate that. DSS is saying we don't care if they're in their 90-day grace period. You have to wait until they get the full endorsement, and which is nonsensical to me, because if you have a TNC driver who's not required to have any of that, then why wouldn't you at a minimum accept the DMV standards of having them be licensed to drive as soon as they submit their application?
So that, again, I guess that's my question is, for the folks who are in that grace period, can we, I understand that you'd like to raise the standard on all drivers, but as another way, sort of another menu of options that we could consider, you would like us to talk to our friends at DSS and persuade them to grant the same grace period that DMV allows.
I absolutely would. As a fallback, absolutely. That would be a minimum. And if that's what you're offering, I appreciate it.
Offering. I don't know if it was an offer. It was more of a question. I will
stated.
Consult with all of the members of this committee and figure out where we are, and our friends at DSS. I am told I have to go. So I appreciate your question, and thank you very much. And I will turn it over to another chair.
Thank you very much. Appreciate your testimony. Okay, so next we will hear from Allison Dvorak.
Yes. Hello.
Hi, Allison.
Hi, how
Go
are
ahead.
you? And I will be as brief as possible. My name is Allison Dvorak, and I am the Executive Director at Senior Resources, which is the Agency on Aging for Eastern Connecticut. We cover 56 towns of Eastern Connecticut. I'm also a partner with Aging CT, so I'm here representing all of the agencies on aging across Connecticut. And I'm speaking particularly to the act implementing the task force recommendations for the elderly nutrition program. I was actually a member of that task force and appreciate all of the work that went into that. I've also appreciate all the work that you have all been doing today. I've been listening to the entire meeting and just such tremendous discussion and ideas that are coming out of this as well. I am a registered dietitian, which is a nutrition professional. I've been in this profession for 30 years, primarily working with older adults. And through my role with the Agency on Aging, previous to being the executive director, I had the wonderful opportunity to be in the homes of thousands of home delivered meal participants throughout our region, and really working closely with those participants and also with all of the senior nutrition program providers, which do such a tremendous job with this program. So I'm a strong proponent and fan of the senior nutrition program, the Meals on Wheels and the congregate meals, and all of the wonderful work that this program does. The senior nutrition program provides a well-balanced, healthy meal for individuals that are 60 and over. And as Commissioner Porter went over some of the logistics of that and how we handle that in the state, it's been a program that's been in effect in our state for 50 years, which is the length of time of the senior nutrition program. And all of that time has also involved the agencies on aging. So we've been doing this for a while. It is a federal program and it is funded through the Older Americans Act. So that was part of the challenges of our discussion from the task force level as to how does it relate to the state. The state absolutely supplements and supports the activity of this program within the state. But we covered so many things in the task force, and many of them, as Commissioner Porter alluded to, are already have been implemented because of the task force, as far as the change in timeliness of when we can request fundings through the State Union on Aging, and also things that will hopefully streamline our process as far as the revision of the Form 5 or other entities. One thing I really, out of all of the items that were discussed in the task force, I just really wanted to highlight the importance of Section 5, which really goes through the flow of funding for this program. So the funding is the funding. We have the Older Americans Act and we have the state supported components of it, but to be able to get that funding to the nutrition providers that are, boots on the ground, making these meals, delivering these meals to the seniors, that's the most crucial part, because a lot of these programs are not, we're a nonprofit as agencies on aging, and the nutrition providers are also nonprofits, and they just cannot bear the burden of that, of flowing those funds. So some recommendations that were made, especially in Section 5, was to be able to have the state potentially buffer the federal funding when, as we are right now, the federal budget isn't really in place. And so that October, November, December timeframe has always been a challenge to be able to find that funding. So that is a request that I think is really well within the realm of the legislation to encourage that the state supporting the funding there. It's not necessarily more funding, it's just allowing the funding to come from what the state would have provided, or for the state to create a way of covering that until the federal dollars come in. And I think in the Section 5 area, it indicates it being a one-time only cost. And this is really something that will probably happen every year. So we're looking at that as being a methodology to cover the flow of funding to keep things moving along. So that's, I really feel like if nothing else came out of this task force, that would have been a key component, because that struggle has been the struggle for all of the nutrition program providers for many, many years. And if we can make impact there, I think this would be tremendous. But I will also comment on
if you could just wrap up.
Okay.
Allison, thanks.
Yep. That I wanted to comment on the SNAP component as well, just because as agencies on aging, we do screen people for the supplemental nutrition assistance program, as well as all of the other things, the heating, the transportation, all their needs, and thank the legislation for the funding that helps provide service navigators at the agencies on aging, because that is exactly what they do, exactly what we do with Aging Answers, help people with whatever their complexity of issues are, and making sure that they get the right supports and services that fit their needs. So I'll hold up and I'll see if there's any questions.
Okay, thank you so much. And thank you for serving on the task force.
I have a question.
It was a pleasure.
Has a question.
Thank you. And again, thank you for all your work on the task force. We love to see good policy recommendations from the trenches moved into legislation. So your number one recommendation for Section 5 is that the state front loads the buffer funding while it waits for the federal funding lag. Is that accurate?
Yes. That's something that it's a strategy that isn't in place now that could be, that just helps us be able to keep up with the payment to providers so that they can buy food and, do the services that they need to make the meals.
Okay, so so right now, are providers not getting paid if they are still providing those meals?
Correct. There have been times that occurred in that lag time. We have made, there were several reasons why there were lags at different times, but that lag, and many of those have been resolved, but the lag of federal funding coming into the state is something that is a challenge, and it's a little bit out of our hands.
Sure. Okay. I think I understand now. So I so appreciate you working, cross agencies and cross sectors to create a seamless experience for our folks that are eligible and in such need of these services. I appreciate it.
Great. Thank you.
Thank you. Thank you, Allison, and thanks for your work with seniors.
Thank you.
Now, up next, we have Crystal Myers. Go ahead, Crystal. Just unmute.
Can you hear me?
Yes.
Okay. Good afternoon, Senator Lesser, Representative Gilchrist, and members of the Human Services Committee. My name is Crystal Myers, and I'm a registered nurse. I live in Windsor, and I'm testifying today to ask for your support regarding Senate Bill 365, an act concerning safety in the healthcare workforce. The Bureau of Labor Statistics projects home health and personal care aide jobs will grow 34% by 2029. In 2021, there were already 38,000 home health and personal care aides working in Connecticut. Home care workers are frequently female, non-white, and among the lowest paid workers in healthcare. A study found that 61.3% of home care workers experienced a form of abuse. Workplace violence is associated with increased burnout, stress, sleep problems, and mental health problems. Based on the OLR report on healthcare worker safety from the end of last year, some of the current laws regarding home care worker safety only apply to home care agencies of 50 or greater employees. I personally feel these laws should be all-encompassing. A worker's safety should not depend on how many employees their current employer has. To prevent a lack of communication between care transfers, I recommend a standardized referral sheet for home care to be developed by the Department of Public Health and be utilized for each home care referral. This referral sheet would include if a patient has a history of violence and like a violent risk assessment tool showing their risk level. Based on the history or high risk of violence, home care workers should have an escort to the client's home. Based on current law, this includes another staff member. If another staff member is not available based on trauma-informed care, private security personnel should be utilized to ensure a home care worker is not attending the visit alone. I highly agree with the training recommendations from the CDC, which include acquiring content specific to home healthcare workers regarding like hazards in the home, assessing the work environment, recognizing signs of imminent violence and verbal abuse, aggressive body language or posturing, employing verbal de-escalation techniques, and especially utilizing escape and egress techniques. In home care, it's not always the client who becomes violent, but it may be a family member or another member of the community. This training recommendation is consistent with training used in psychiatric and emergency departments in the state, which are also high risk for violence areas. As a behavioral health nurse, I've attended these trainings, and of course they're helpful. My one concern is there's no requirement for repeat training. I do think if you don't use it, you lose it, and this should not just be a one-time requirement. Healthcare professionals are leaving the profession due to burnout and poor working conditions. Without workplace violence, addressing workplace violence in home care, the number of caregivers willing to do the work will decrease. As the demand for home care increases over the next few years and the number of caregivers decreases, wait time for services will increase. The delay in care may mean hospitals are unable to discharge patients, or patients will go home without the services they need. As nurses, we want to provide our patients or clients with the best care possible, but in order to do that, we need to have safe working conditions. As a nurse who has experienced workplace violence, I urge you to help mitigate the risk to my colleagues in home care by supporting Senate Bill 365. Thank you for your time, and I welcome any questions.
Thank you, Crystal. Really appreciate you coming out to testify for this and also to share a scenario in what could happen out there. And I can feel that you have experienced some stuff that you probably were not feeling safe in. So thank you for what you do. Representative Hughes has a question.
Thank you so much for your firsthand experience on behalf of all the workers out there in the field. I think you bring some really important points, especially around upkeep of that training. I was a professional assault response trainer for the state of Connecticut in the group home industry, and I know exactly how we had to kind of keep up that certification training every 2 years so that we didn't lose it, as you said. So I do think that there is an appropriate cost associated with that training and an appropriate, increase in wages to reflect the level of training and specialty risk that you take on. So I think that's something we need to look at as well. So thank you.
Thank you.
Thank you very much. Next is number 39, Chris Pankratz. Also on Zoom.
Thank you. Good afternoon, distinguished members of the Human Services Committee. Thank you for your time and the opportunity to speak today. My name is Chris Pankratz, and I'm a resident of South Windsor. I'm Chief Executive Officer and co-owner of Masters in Home Care, and have been active in the home healthcare industry here in Connecticut for over 20 years. Masters is a licensed and certified home healthcare agency, and we specialize in providing skilled medical services in the home for the growing older adult population since 2014. I'm testifying today in support of SB 365, an act concerning safety in the healthcare workforce, and in strong support of the necessary funding to provide additional safety measures for our workforce in home healthcare. As our population continues to grow and the demand for home-based care services increases, it is incumbent that we continue to collaborate on effective solutions to improve the safety of healthcare workers delivering care in the home. The long-term viability and sustainability of any of these safety initiatives is dependent on adequate funding to be successful. Safety training and the use of escorts are critical to improving upon the safety initiatives many of the skilled home healthcare agencies like mine already have in place. As an employer, we place great emphasis on the safety and welfare of our employees, but our resources are limited to the reimbursement we receive for providing services in the home. Thank you for recognizing that providing escort services for staff in potentially high-risk situations comes at a financial cost, and for requiring the Medicaid agency to provide funding to arrange safety escorts for our staff as needed. I hope to also see the future inclusion of funding to invest in training efforts, as we've heard, additional personal safety devices to offer as alternative to escorts and a way to communicate, and greater transparency of safety-specific referral information to home health providers. Your efforts to raise this bill is a crucial step in providing the necessary resources for programs and initiatives to show the healthcare workforce that you take their safety seriously. I respectfully request that the committee consider including the funding for these initiatives in the budget adjustments this year, and thank you for recognizing that funding is key to the longevity and success of any solution. And thank you for all the work you do for the state of Connecticut and for the opportunity to present this testimony.
Thank you very much, Chris. I have a question for you. A person, couple of people ago mentioned that if you don't use the training, you lose it. So I was wondering if it would be, if the initial training came in the form of in-person training or, in-service areas, and then follow-up training were delivered by video, would that be more convenient for you, and I mean, I'm assuming that it would probably be more cost-effective in our,
Absolutely. And as an example, last October, we brought in an outside social worker to do a mandatory in-service for all our clinical staff on de-escalation. And we also videoed that so that we could also present that to all new staff being onboarded after the fact. But yeah, anything you can do to make delivery of the content more easily and readily available, and that certainly reduces the cost factor as well.
Thank you. Thank you for coming out today. Any questions? Nope.
Thank you.
Okay, next up we have John Brady. Hi, John.
Good afternoon, Senator Comey. Representative Comey. Representative Hughes and members of the committee that might be on Zoom. Thank you, first of all, for your service to the state. My name is John Brady. I'm a registered nurse and I'm the vice president of AFT Connecticut. Among our 30,000 plus members are approximately 8,000 healthcare members in hospitals, visiting nurse agencies, clinics, and schools, including our own Senator Martha Marks. AFT Connecticut supports passage of SB 365, an act concerning safety in the healthcare workforce. According to the U.S. Bureau of Labor Statistics data, healthcare and social service workers are 5 times more likely to experience workplace violence than all other workers. And there's general acceptance that the amount of workplace violence is underreported. The loss of Joyce Grayson has been felt by all of Connecticut's residents. Last year, the Connecticut General Assembly took historic steps in passing safe staffing legislation. This year, we must pass safety legislation. SB 365, along with SB 1, will go a long way in protecting healthcare workers and patients, and I thank the General Assembly for making this a priority. SB 1 will deal with many of the dangers in the home healthcare field. SB 365 addresses some of those issues, but it also addresses workplace violence in facilities such as hospitals and nursing homes. It will require facilities to adopt and implement the workplace violence standards of the Joint Commission. The Joint Commission defines workplace violence. This definition is important because current Connecticut law does not define workplace violence, meaning that sometimes the only incidences reported and reviewed are those that involve emergency treatment. This is unfortunate because a near miss that is investigated and dealt with could prevent a future injury. SB 365 will require facilities to provide evidence of a program and education of staff. It will require reporting of incidences and will carry Medicaid incentives for compliance. In home care agencies, SB 365 also provides funding for escorts to the staff conducting a home visit if needed. Improving safety is reason enough for these pieces of legislation, but another reason is the shortage of healthcare professionals willing to work in the current conditions. Improving safety will improve recruitment and retention. So we urge passage of SB 365, and I thank you so much in advance for your support.
Thank you, John. Are you aware of, I think it's nice that you have a sort of a broad breadth of organizations and businesses and things like that, staff that you work with. Are there consistencies across, say, home health care providers as to the types of intake questions they ask, those types of things? Do you have that information?
I don't. We don't represent nurses and healthcare aides in a lot of different agencies. Most of us are concentrated in the one that Senator Marks is associated with. So I'm not as keen on what happens in the other ones.
Okay, thank you. Representative Hughes?
I thank you so much for AFT's advocacy and input on workplace safety. Do you have a standard training that you would recommend in terms of safety training as a minimum across the sectors? Can you talk about that a little bit?
Well, thank you, Representative. I think it could be different when we talk about home care and in facility. Because it's different situations. There are different situations because of the number of staff around you, because in the home, you do need to think about like exits and stuff like that, but there are some similarities. There are a couple of programs out there. One of the programs that I participated in when I was working in the emergency was MOAB, it was called, Management of Aggressive Behavior. And it was a hands-on training, and there's other ones too. I'm not endorsing one program before I get in trouble for that. But it's a hands-on training both on how to de-escalate first identify a situation, identify a situation that's escalating and how to de-escalate that. I mean, there are things even on how to stand and how to hold your hands and that kind of thing. And then if the situation escalates, how to handle that and protect yourself and protect the patients and the other people around you. And it was hands-on. It was like an all-day program. And then a couple of years later, you would get recertified, and it was a much shorter period of time because you've been through it all. I actually had to use it sometimes. I mean, they actually showed you the correct way to defend yourself. And I had incidences where I needed to use it, and that practicing and the muscle memory came back. It was pretty remarkable.
Yeah, I appreciate that because I became a trainer in the precursor to Moab because I experienced workplace violence a lot from my constituency that were, at times highly aggressive. What we found in getting trained and recertified, like you say, which is a shorter amount of time, is that the incidence of violence went way down because the clients could sense they were safer because we were much better trained and we were much less likely to use excessive force and to de-escalate and to do preventative measures to prevent violence in the first place. We could intervene much more effectively, much earlier, and the amount of aggressive incidents went way down. And so we can see that across the sector, but it does require that hands-on training. Can't really be done through a video because you really got to practice. And then once you have that confidence, you exude a different sort of security in how you enter a situation and how you can, how you disarm, if you will, a situation that could escalate. So I think that's a really important part to consider as we consider investing in our care workforce, that investing in the right training for the right setting is essential, is basic. So
Thank you for that. And sometimes it's provided to some people, like in a hospital, maybe the emergency room and the psychiatric department, but then not necessarily given to the floors, who end up having sometimes just as much problems.
right, a cross-sector investment in that training would be really helpful. Thank you. Thank you.
Thank you, Representative. Other questions from members of the committee? Good to see you. Have you had a chance, I don't know if you know this, to submit written testimony?
I did submit.
Okay, I haven't seen it, but I will.
I'll
collect
follow
that.
up
I
on
will
it, make sure
figure
it's
that.
in.
Yeah, I'm sure we have it, and I just haven't seen it. Thank you. Any other questions? If not, thank you.
Thank you.
Next up, we have John Flanders.
Good afternoon, Senator Lesser, Representative Gilchrist, Senator Simonara, and Representative Case, members of the committee. My name is John Flanders. I am the president of Special Education Equity for Kids of Connecticut. SEEK is an organization of attorneys, advocates, and parents working for systematic change for the benefit of children with disabilities in our state. I am here to very, very, very enthusiastically support the passage of Senate Bill 397. This is a wonderful idea. Let's be clear, special education is expensive. Special education is a process that is very difficult for communities to budget for, because a kid can show up with needs 3 months after you've finished your budget and suddenly your numbers are in trouble. We find that when kids go into the situation, the educators who want to help are caught between their desire to help and the limitations of their budget. Anything that we can do to put more eggs in the basket is a good idea. IDEA, the federal law, allows schools to seek reimbursement from Medicaid or commercial insurance for cost of related services, as long as they have the parents' permission. There's a lot of money being left on the table. I noted in the commissioner's testimony that fully a quarter of the towns don't participate in this, which is nuts. And I further noted that of the $60 million that was requested, about $15 million of that is going back to the communities. We have an opportunity to make sure that those communities have more resources to provide more appropriate services for children. And we have a way of doing it that will include federal dollars to help subsidize what we're doing. We think that Connecticut, well, we're told that Connecticut is one of the worst states in getting this, and we very, very much appreciate the committee and the leadership's efforts to fix that and to make us a better place. That is it. I can't believe in doing this for 10 years. This is the first time I beat the buzzer.
I didn't see hear any criticism of the bill.
I think you people should celebrate the fact that you have got you've got a committee that can keep me quiet.
Well, thank you, John, for your enthusiastic enthusiasm for our legislation. Just wanted to ask, you know, we did hear some concerns from the department about the fiscal note, but we're already incurring the special ed expenses and also the health expenses in the bill. We're not adding any new nothing is. This bill doesn't cover anything that we're not already paying for. It's just like getting reimbursement.
That's absolutely right. When you say we, if you mean the taxpayers of Connecticut, that's
We the
exactly,
taxpayers of Connecticut.
that's who. Now, for a lot of this currently, the people who are taking that money are your state or your municipal tax collector rather than the Department of Revenue Services. But the money coming out of my wallet and your wallet shouldn't be affected by that. It should in fact go down because of the federal contribution to Medicaid.
Is there a way though to sort of, because obviously one of the big questions is the impact on the general fund. There are a few different areas where that could be impacted. Are there ways that you can think of to mitigate that, or potentially? I mean, so one of the questions that we have is right now the state is pocketing 1 out of every 2 Medicaid dollars that comes into the state that's supposed to be reimbursing towns, and instead that's being diverted to the state's general fund. I know that the concern from the administration is that will impact the general fund, but I think the theory here is if towns do more billing, and you said in your testimony that 1 in 4 aren't even bothering with Medicaid because they're not getting enough reimbursement, that will lead to more money coming to the state, period, and also including the general fund. Is that
I can't see that it wouldn't. I mean, we don't encourage towns to seek this resource, and in fact, by the fact that you've got to jump through all the hoops, and the hoops are pretty substantial in order to get this, we are discouraging. Most of the towns who do this do it through a vendor. So not only is all the work being done, but a vendor is getting it. So for that dollar, that $1 out of $2 that may be coming back, the town is not getting all of that dollar. Some of it is going to a corporation that's doing the work for them. So absolutely, if we can increase the number of times where this question is asked, and parents, you know, certainly have no reason to not do it, because it doesn't affect the requirement that their children's education be free to them. You know, it only pays off if it's no impact on the parents. But if more places are doing it, if more schools are doing it, then absolutely it's going to come. And during the course of researching this, I had a long talk with Fran Rabinowitz, who's the head of the Superintendents Association, and she had been the director or the superintendent in Bridgeport for a long time. And what she said was, I don't know, but I know that everybody told me I was leaving a lot of money on the table. And I think particularly in our urban districts, where there are a lot of kids who are on Husky, that money could be flowing in. And so it's one of the other beauties of this is the money is going where the money is needed mostly. And I'm not going to pick out any other town. I was going to mention a couple of other towns which are likely to have fewer kids on Husky. They're not going to be doing it as much, but certainly our urban communities and our rural communities in the Northeast and Northwest are going to. I can't see that they don't benefit from it.
So I spoke to one of my local superintendents at a more affluent suburban district. And what he said was, it's not worth the time. It's you know, he has a company that in theory does. He's not one of the towns that doesn't do any reimbursement. In theory, they've got a consultant that's supposed to be collecting it. But one of the barriers seems to be that you need to get parental permission before you can do this, and so he doesn't know who's on Medicaid on Husky in the school and who isn't. So because of that, it's too cumbersome and the reimbursement rate is too low, so he doesn't bother. So this bill anticipates coming up with other workarounds, applying for federal waiver to do that. Is that the kind of thing that you're hearing is a particular issue?
Yeah, absolutely. As you are my senator, I know the districts that you're talking about, and I know the communities that you're talking about, and I get the same feedback. And I go to a lot of PPT meetings for my profession, and I cannot recall ever having the district ask my client if they were eligible. I think there's a really easy way to do this without being embarrassing or anything like that. You hand them the form at the beginning or the end of the meeting and say, if you qualify, then sign this and it will help us get resources for your kid. I mean, it's not, you don't have to go into a meeting and say, is your child on Husky? And so absolutely. And the workaround in the bill of allowing for, rather than an affirmative ask to do this, to affirmatively opt out seems like a good solution. And we think, although we've been looking at it, we think it fits within the federal regulation. The federal regulations require parent permission, but they don't define that. They think lack of objection equals permission.
Right. And then there's the whole thing that we discovered that in 2014, when this was authorized, it was limited. States were only allowed to bill for services provided, I think, with regard to a IEP and a 504.
Right, that's correct.
And since then, the federal government has lifted that requirement. And so a whole gamut of health services that schools provide at a school nurse's office are now eligible for reimbursement. But this bill seeks to open the door to that. Last year we did it just with regard to school-based health centers, but we didn't do it for school nurses. Can you just talk about that provision and why you think that's important?
I think it's great. I mean, school-based health centers are independent organizations. They are associated with the school in the fact that the school allows them to operate within the school. So they are all, they are all Medicare providers. They're all Husky providers. But there's a lot of stuff that goes on for kids in school, and particularly these days when emotional issues and we have COVID and all sorts of wonderful things going on. The nurses are working hard, and my life is working for the kids who have disabilities, but money is very fungible, and any dollars that are going into the district make it that much easier for the schools to provide for the services that our kids need. So I think it's a great idea, and I absolutely I applaud that entirely. I left it out of my testimony because I'm a special ed guy.
Okay. Any questions, members of the committee? Seeing none.
Thank you very much, Rita.
Thank you. Great. Next we have Rafael Rosario, followed by Phil Brewer.
Good afternoon. I will be brief because it's beautiful outside. Honorable members of the Human Service Committee, my name is Rafael Rosario, and I serve as the senior manager.
This committee when you tell us that.
Sorry, that's why I'm gonna be brief. I'll be real quick. So I'm the senior manager for communications and development at the Connecticut Coalition to End Homelessness. So I come before you to express our strong support for Raise Bill 5458, an act concerning homelessness, which is set to take effect on July 1st. This bill represents a critical step forward in addressing the complex challenges faced by those experiencing homelessness in Connecticut, particularly for those with complex health conditions who have been navigating the precarious path between health and housing instability. As outlined in this legislation, the Connecticut Housing Engagement and Supportive Services CHESS program aligns perfectly with our mission to improve housing stability and health outcomes for some of our most vulnerable citizens. My journey intersects deeply with the work of CCEH and the intentions of this bill. I started my career in Connecticut dedicating myself to supporting men and sometimes women in navigating the daunting transition from incarceration back into society. This work I've witnessed firsthand the many barriers that prevent individuals from securing stable housing, barriers that are often compounded for those with complex health needs or a history of homelessness. Raise Bill 5458 offers a beacon of hope. By developing a strategic plan to enhance the CHESS program, this legislation seeks to streamline the multi-agency administrative procedures that often delay or deny essential benefits to those who are at risk of experiencing homelessness. Furthermore, this bill's focus on targeting social determinants of health, including housing, nutritional, and health management supports, is commendable and necessary. As someone who's seen the impact of homelessness up close, I cannot stress enough the transformative potential of this legislation. Housing is not merely a place to live, it's the foundation upon which individuals can build healthier, more stable lives. This strategic enhancement proposed in this bill will not just reduce housing instability statewide, but will offer tangible, life-changing support to those who need it the most. In conclusion, I urge the committee to support the Raise Bill number 5458. Its implementation will mark significant advancement in our collective efforts to end homelessness in Connecticut. It will provide the necessary framework and resources to ensure that individuals with complex health conditions and experiences of homelessness can access the support they need to achieve health and housing stability. Thank you for considering my testimony on this vital issue, and I hope you guys get to go outside soon.
Thank you so much for your testimony, and Representative Hughes.
Thank you, Mr. Chair. Thank you, Ray, for your testimony. Can you just say briefly what the impact you think of HB 5458 will be on the mental and behavioral health of people at risk of homelessness when there is some stability and streamlining access to services?
Yeah, no, that's a great question. I think there's a lot of intersectionality between mental health issues that some folks are sometimes going through. You know, my time was spent at a halfway house here in Connecticut. I spent over a decade, and sometimes folks are coming home with dual diagnosis, with substance abuse issues, as well as some PTS issues. And sometimes those things are sometimes undiagnosed or untreated. So obviously this bill covers a lot of mental health issues, but I think in particular, folks coming home from incarceration are deeply impacted and targeted in this bill.
Thank you. Thank you, Mr. Chair.
Appreciate you.
Thank you, Representative. You can keep asking him questions, keep him from enjoying the beautiful day outside if you want. Thank you.
Thank you for your time. No, thank you guys.
Next up, we have Phil Brewer, followed by Sherry Dayton. No Phil. But Sherry is online.
Hi, good afternoon. My name is Sherry Dayton. I have done a lot of different hats in the healthcare field. I have been a home healthcare aide. I have been a PCT in the emergency room. I've been an RN who's worked in home care. I've been an RN who's worked in the emergency room, up on the floors in telemetry. So over 3 decades, I have been in the medical field. So I can tell you in each one of those positions, I experienced workplace violence. So I am very grateful that you guys are taking this on this year. And I'm really appreciative for myself and my coworkers that you guys are trying to improve this, because it is getting worse. Every year, it's significantly getting worse. And like I said, I've been in this profession for 3 decades, and I've seen more injuries now than I did when I first started. I'm also the union president for Bacchus Federation of Nurses, which is out of Bacchus Hospital. They have about 450 nurses there, and I am the divisional vice president for AFT Connecticut Healthcare. And I stand in support of SB 365 and act concerning safety in the healthcare workforce. On March 1st, 2024, the Joint Commission Journal on Quality and Public Patient Safety published an article titled "Hospital Staff Experiencing Workplace Aggression Every 40 Hours." So once a week, if you work a 40-hour position, you are experiencing some type of a workplace aggression. This is very concerning statistics because workplace violence has been seen as a factor that decreases retention and we are already struggling with staffing issues. It is a vicious cycle because number of patients assigned to staff has significantly greater during a shift where an aggressive event occurs. So when I first started this profession, I was usually 4 to 1 as a nurse. I had 4 patients to 1 nurse in the emergency room. And there are plenty of times now that we are going 6 to 8 patients a shift, which causes longer wait times and frustrations for our patients and their families, which heightens the tension and causes them to lash out because they're scared and it's sometimes the worst day of their life, right? So please pay attention to those statistics that are very important. The standard clearly defines workplace violence. Currently, the law doesn't clearly define workplace violence, but the standard clearly defines workplace violence as verbal, nonverbal, written, or physical aggression, threatening, intimidating, harassing, or humiliating words or actions, bullying, sabotaging, sexual harassment, physical assaults, or behaviors that is concerning to staff. I say all of those because there's not very many nurses who haven't experienced probably every single one of those at one point in their career. When I was a visiting nurse, I had a patient, and again, as a visiting nurse, you're walking into that house by yourself, just you. And I had a patient who was continually pushing boundaries about sexual innuendos. One day I walked in there and he had pornography on the television. I asked him to turn it off. He was always trying to like touch my hand or touch my shoulder. And eventually I said to my boss, I don't want to go there anymore. I'm afraid. I don't want to go there. And they were like, oh, you just need to set clear boundaries. As an advocate for workers in the union, probably most people who have seen me or talked to me before know that I'm very clear on setting boundaries and advocating not just for my profession, but for patients. And so I don't think the issue with this patient was that I didn't set clear boundaries. I think the issue was that I didn't get support. And I think it's important that we make these organizations give these workers support. And so I appreciate what you guys are doing. Workplace violence, I'm sorry, excuse me. The bill also calls for an annual work site annulus and process for continuing monitoring training. I do wish the bill went a tad further with the training. Every healthcare worker must have some de-escalating and self-defense training. Studies have shown that nurses encounter more threats and aggressions, even more so than law enforcement officers. You can look up those statistics, they're there. On October 28th, 2024, there was a horrific day when Joyce Grayson, a visiting nurse, went to visit a patient and was murdered. This bill will increase Medicare payments to home health care agencies that provide escorts for safety to staff conducting home visits. If Joyce had had an escort, there's a way better chance that she would have returned home to her family that day after work. I also wish this bill added that organizations would have to screen clients before visits to assess their danger level and notify them.
Your time has expired. Can you just please summarize?
Okay. Last sentence. The healthcare providers of the history of violence is not always great communication from discharge from the hospitals to the visiting healthcare workers going in. So I feel like we should have some more clarity on that needing to be done. And once again, I stand in support of SB 365. Thank you.
Sherry, thank you so much for your testimony. I am sorry that you had to go through that. Nobody should have to endure violence or harassment in the workplace. And I'm just grateful for you for sharing thoughtful commentary about what we can add to this bill to make sure that that doesn't happen to other people. Are there questions or comments from members of the bill? Members of the committee, Representative Hughes.
Thank you, Mr. Chair. You did say that you recommended the training, basic training, go a tad further. Did you submit written testimony about that?
I did submit written testimony.
Okay, great. We'll take a look at that. Thanks.
Thank you, Representative. Seeing no other questions, thank you so much for your testimony.
Thank you.
Next, we have Annette Exantis, followed by Nancy Issa. No Annette? Okay. Nancy? After Nancy, we'll have Stephen Tomczyk. Nancy, you gotta unmute yourself. Nancy, still got to unmute yourself. Well, Nancy is finding that mute button. We'll go to Stephen Tomczyk. We'll come back to you, Nancy.
Well, thank you. Dear Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services Committee, thank you for the opportunity to submit testimony in support of SB 395, an act concerning Medicaid budgeting methods and the reporting of medical debt. I am Stephen Monroe Tomczyk, a resident of Wallingford and a faculty member at Southern Connecticut State University Department of Social Work, representing the Social Welfare Action Alliance Connecticut chapter, a progressive group of social workers, allies, and community activists who work in partnership with those communities most negatively impacted by current societal inequities to educate, discuss, and organize around correcting these injustices. Medical debt is certainly prominent among such injustices that disproportionately burden those already economically disadvantaged and deprived. This is a chronic problem in our healthcare system, impacting people all over the country. Governor Lamont knows this, which is why his administration is working to pay off some Connecticut residents' medical debt. Healthcare costs have been a rising issue and have placed many in medical debt. There are 40% of U.S. adults that are currently in debt because of medical or dental bills. In Connecticut, roughly 280,000 people have medical debt. Medical debt on a credit report can lead to other problems, all the while someone is recuperating from medical care. Additionally, 72% of people attribute their medical bills to stays from acute care, such as a single hospital stay or treatment from an accident. When medical debt ends up on a credit report, there are numerous negative impacts. Importantly, while national credit reporting agencies have already voluntarily agreed not to report medical debts under $500, many Connecticut residents currently get medical bills higher than $500. States like New York and Colorado have enacted this patient protection. The more states that do this, the more likely that national action will be taken. Passing this bill, therefore, will not only help Connecticut residents, but people all across the country. The costs of not taking action are considerable and cause many long-term adverse health consequences. The inability to access health care results in poor health outcomes for those not able to pay debts. These include delaying needed care, being less likely to receive preventative care, and unequal treatment in healthcare. Furthermore, reports have found that people without health insurance and individuals with lower income, Latino and Black adults, women, and people with disabilities are among the most likely to have medical debt. Finally, as a representative of an organization that wants to get at root causes of social problems, I would be remiss if I didn't discuss the importance of preventative strategies and call your attention to a bill that has been considered by the Public Health Committee, HB 5320, an act concerning hospital financial assistance policies, which would help prevent medical debt. And so while I understand this bill is not being heard by this committee, I urge you all to consider supporting it, as it would help prevent these issues. And as an even more long-term strategy, I would urge this body to explore establishing a single payer system, which would go even further to preventing these problems and truly make healthcare in our state a human right and not a commodity based on ability to pay. In closing, thank you for the opportunity to testify in support of this important legislation. Please support SB 395 and pass it out of this committee. Medical debt is a symptom of our costly, fragmented, and unjust healthcare system. One major medical expense should not threaten a person's ability to rent, purchase a home, get a job, or receive credit. Thank you for the opportunity to testify today.
Thank you so much for your suggestion. Some of the members were speaking about the possibility of amending this bill to just tack on a single payer system as an amendment. I'm not sure if we're going to do that today or not. Probably not. But thank you for your suggestion. I do, in all seriousness, though, I want to echo what I'd said earlier, which is I think it was remarkable to see the Connecticut Hospital Association testify in support of the of this bill and indicate that they're working with their members and they will cease reporting this debt, which is an enormously positive step, and they should receive credit for that. Thank you for your testimony. Are there other questions from members of the committee? Seeing none, thank you for being here this afternoon.
Thank you.
Nancy, any luck?
Yes, thank you for bearing with difficulties. Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Case, and members of the Committee on Human Services and distinguished guests. My name is Nancy Issa, and I am the Director of Nutrition for the Community Renewal Team, CRT, the designated community action agency for both Hartford and Middlesex counties. We are also a member of the Connecticut Association of Nutrition and Aging Services Providers, CANASPs, and I am here to offer my testimony in support of Raised Bill number 396. On behalf of CRT, I wanted to express our gratitude for the opportunity to participate in the task force. It was a pleasure to collaborate and work together to discover solutions that will enable us to continue to meet the needs of seniors in our community. We have already felt the impact of the task force with an improvement in receiving timely payment delivery. In the past, we would go months without payment, and sometimes we were forced to float the program, which severely drained our resources. You all clearly appreciate and understand the importance of community-based services, including Meals on Wheels, and the positive impact that those services have on keeping seniors healthy and independent in their own homes. It is worth noting that in 1973, CRT established the first elderly nutrition program in Connecticut, serving meals at 8 centers located throughout Hartford. From our perspective at CRT, we are continuing to see unprecedented demand for these nutrition services from seniors throughout Central Connecticut. Last year, our elderly nutrition program served 432,000 meals to seniors despite a decrease in funds. However, we are currently facing a critical challenge. The number of seniors in our community has been steadily increasing while our resources have been significantly reduced. During the pandemic, the need definitely increased for our programs. But today, that same need has not decreased. The numbers continue to grow along with inflation, putting the elderly population who are on a fixed income in a very vulnerable predicament. Nationally, the senior population is growing rapidly. Meals on Wheels America reports that the senior population is projected to increase 30% to 93 million citizens in the year 2030. As you can see, this need will certainly not go away. It will only continue to grow. The recent budget reductions that we faced and the phasing out of ARPA funds, along with increased needs, have forced us to put a mitigation plan into effect next month that will eliminate 84,000 meals for seniors in Hartford and Tallinn County. It is imperative that we secure additional funds to bridge the gap and continue providing these vital resources to support the seniors. Furthermore, it is crucial that we continue to acknowledge the importance of efficiency in payment and contract disbursement. Streamlined processing suggested by the task force are imperative to ensure that programs run smoothly and funds are dispersed and contracts are delivered on time. In conclusion, I urge you to consider the dire situation facing Connecticut's fragile senior population and the pressing need for additional funds to sustain these vital services. The passage of Bill 396 will not only ensure the continuation of these programs, but it will also reaffirm our commitment to the well-being of the seniors of our state. Together, we can make a difference in the lives of those who have contributed so much to our community. So on behalf of the seniors that we serve, I thank you for your support of this bill.
Thank you for your testimony. I'm going to ask a question not specifically about the bill, but related to it, which is the announcement today that you're going to be engaging in a deficit mitigation plan that's going to halve the number of meals served in the greater Hartford region to seniors. What's the reason for a mid-year deficit? Was there a mid-year loss of funding?
So it's my understanding that at the beginning of our fiscal year, which is October, we obviously contract with the AAA in our region, and they've always had a way in the past, and please forgive me, I've only been in my role for 1 year, but they've always had a way in the past of being able to find more money. So at the beginning of the year, when we present our budget and we let them know how many people we can serve, and then they come back and tell us how many people they have funds that we can serve. They always tell us to hold off on those wait lists. They don't want us to put them in place because somehow they're always coming up with extra money, whether it be from another provider that didn't happen to meet their quota for the past year. They may have funds left over. I apologize, but I'm not certain of the whole entire funding stream. So that's the reason, Senator, for the mid-year mitigation plan.
But all of a sudden now we're in March 14th and we're actually, this is, timed for the day that we're doing a hearing on this program. And you announced that you have $1 million deficit, and all of a sudden seniors in the, all of Hartford County and the areas served by the North Central Area Agency on Aging are going to go from 2 meals a day down to 1.
Yeah.
I know we heard from ADS that this was not a surprise, but from the members of the committee, that seems like that just came out of nowhere. And now we're scrambling to respond to pretty acute needs for both congregate and home delivered meals in our districts. So the issue is that the Area Agency on Aging knew they approved your budget knowing they didn't have enough funding to provide it, but they were just hoping to find the funding in the interim through couch cushions?
Yes, Senator.
Well, that's strange. But I'm not saying I don't believe you. It's just a strange way of doing things. And it's, I can imagine enormously frustrating, not only for our seniors, but also all the towns that are relying on you and then through you, them for services to make sure that our seniors don't go hungry.
It's absolutely heartbreaking having to deliver this news to so many seniors. It's really soul crushing.
Representative Fortier.
Yes, I just wanted to follow up, and I don't want to put you on the spot because I understand that you're new in your position, but you mentioned something earlier in your testimony that the demand is increasing. I mean, do you think that partially explains this? That if, there were 6 different agencies doing this work, and normally 2 of them don't have the same demand, and so therefore they have extra funds, and CRT ends up getting those extra funds? Do you think it's because there's an increased need and therefore some of the other agencies used all their budget allowance?
Yes. I think you absolutely identified what the issue is. And I think from my perspective as the operator, the boots on the ground every day, if we could have a little bit more transparency from the AAAs on maybe where they stand, certain barometers at different points in the year, maybe once a quarter, then we would know a little bit earlier where we stand and how many people we can serve. But there are a bunch of factors that go into play because we're not the only provider that the AAA serves. So I understand they have to juggle funds, but I do think the work that the task force is going to do to shed some light on that will be very helpful to the seniors of Connecticut.
Thank you, Representative. Any other questions or comments from members of the committee? Seeing none, thank you for being here this afternoon. Next, we have Wayne Pesch, followed by Sarah Fox.
Good afternoon to the distinguished members of the Human Services Committee. My name is Wayne Pesch. I'm president of the Connecticut Food Association. I'm testifying today on behalf of the state's traditional grocery stores. CFA's membership includes a wide range of companies, including independent grocery stores, regional supermarket chains, food distributors, manufacturers, and local food companies. I'm here to testify on Senate Bill 364 concerning supplemental nutrition assistance. CFA supports staggering the distribution days of supplemental nutrition assistance program benefits, commonly known as SNAP. As of December 2023, Connecticut had 389,000 SNAP participants receiving almost $77 million in federal benefits. As my friend Lucy Nolan from Hunger Connecticut detailed earlier in her testimony, these funds are distributed on the first 3 days of every month based on the individual's recipient's last name alphabetically. However, on the first of the month, there are long lines, diminished selection, and other challenges for retailers and customers shopping in food stores. Expanding these issuance dates has a number of positive impacts. It would provide SNAP participants more consistent access to fresh produce and healthy food items, better access to bulk items for shopping, managing for folks who are managing limited benefit dollars, and shorter lines and reduced traffic at grocery retailers. Staggering these dates also brings Connecticut more in line with other states of similar population size, highlighting the need for this change. And it also allows for grocery stores to be more adequately stocked and staffed, and better meets the needs of shoppers without the spikes in demand seen today. The other consideration in this bill, allowing beneficiaries to purchase meals at participating restaurants, is a solution in search of a problem. Think about the economic impact this would have on SNAP participants. It is more economical for participants to shop in food stores and at farmers markets than in restaurants. Benefits go a lot further for families in terms of purchasing power. You can make 4 hamburgers and sides at home for the cost of 1 Five Guys meal. I've concerns on the negative impact of this proposal on the state's grocery stores. Does this lead to a loss of sales? Does it lead to a loss of jobs? Do we close a store in some of the state's poorest communities? Those are real concerns. And as you've heard from Commissioner Reeves earlier, a restaurant option has not been successful in other states, especially in terms of providing healthy, non-fast food choices to the beneficiaries. There are some proven programs in place that can be augmented to ensure healthy consumption and bang for your buck in terms of when you spend your SNAP dollars. There's the SNAP Ed program, which provides education and resources for these folks on healthier choices within their budget. There's the Double Up Bucks food program, where both retailers and farmers market double certain products purchases around produce and fruit. And there's the farmers market nutrition program. The grocers have also been taking steps to enhance the SNAP program. For example, we've got a very wide selection of locally grown produce that is larger than it's ever been. There are Connecticut hydroponic companies that we're purchasing from. We provide nutritional information in our stores. We display information in the aisles. We have dietitians in some of our stores. We even have a full month of food preparation and healthy living programs called Family Meals Month. And each retailer takes that and has their own specific spin on that. So we also partner with community organizations. Lucy was on the Connecticut Food Share, dozens and dozens of local partner organizations that we work with to make sure that people have information on where to get healthy food and how to get the most bang for their buck. So in closing, we think expanding distribution days has tangible benefits with the modernization of the program. However, allowing fast food options does not lead to healthier outcomes or better buying power for over 400,000 citizens in our state. I would be more than happy to answer any questions that you might have, and I thank you for your time today.
Yes, thank you for your testimony, Wayne. Appreciate it. I go to the grocery store. I'm a big patron of your clients. But not everyone, we heard actually Lucy's, you referenced Lucy's testimony. She made the case that not, the homeless folks, for example, who are eligible to participate under the restaurant meals program may not have a kitchen to cook grocery store purchased food. So, do you see a value for a limited program that targets folks who may not have the opportunity to?
Frankly, Senator, I would prefer to see these two bills separated and debated in a manner as such. I don't really see the linkage. There's a program that exists today that is going to need to work through DSS to expand these days, and then the debate about adding in. I don't want to call it fast food restaurants. I don't want to disparage anybody. But I don't know that those two things are necessarily linked in my mind.
Okay, thank you. Questions or comments from members of the committee? Seeing none, thank you for your testimony today.
Thank you so
Um,
much.
Next, we have Sarah Fox, followed by Patrick Turek. Take your time. Okay. Sarah, could you press the button just again? Great.
Good afternoon, Senator Lesser, Representative Gilchrist, and members of the Human Services Committee. My name is Sarah Fox. I am the Chief Executive Officer of the Connecticut Coalition on Homelessness. I represent, and CCH represents providers from across the state of homeless services, and we also lead the Connecticut Can End Homelessness Initiative, which is a collective impact initiative representing the voices of people who are housed, unhoused, providers, partners, and from across the state. I have also experienced homelessness as a child. My mother lives in permanent supportive housing, and the importance of housing is something that's just been a huge part of my life. And so I come here before you today to just provide actually general comment on HB 5458. And I did submit written testimony. Over the course of the last year, we've had many conversations about CHESS. And when CHESS was introduced in 2021, we were really excited about this cross-agency initiative and the opportunities to address housing instability, homelessness, and health all together through a comprehensive state program. Today, I would say that that program has fallen short. And in my testimony, you can look through some of the comments that have been provided by providers across the state on some of the challenges of the program, as well as the opportunities. I would say having a study done is nice. Having resources quickly moved into the community is better. And so when we are facing severe funding challenges in our communities, and we're really also facing severe acuity of the people that we're serving, it's really critical to move and deploy resources swiftly. And so the thought of a study is challenging for both myself and providers, and especially on the timeline that was given earlier by the commissioner. So we appreciate the thoughtfulness. We do ask that if a study does take place, that it takes place within an appropriate amount of time, that it includes all of the necessary participating voices, and that it really looks deeply at some of the challenges about rolling out some of these programs, because providers will tell you that this is a critical program. It requires flexibility, but it also requires funding to be able to do the job. And the reimbursement rates that were rolled out with CHESS really do not align with a process that our providers could actually work with. And so you have people who are already chronically funded being asked to do a service for $0. And so that's a challenge. And I will say homeless service providers historically have always stood to this challenge, and we've done work without getting the reimbursements that were necessary, which has led in some part to this chronic underfunding. So with that, I asked for some thoughtfulness about this resource. I'm also really excited about Connecticut participating in the National Academy for State Health Policy and the work that we can do to really develop, implement, and align these resources. But today, if there's a way to expedite this funding coming out to providers in a way that works for all, I think, and really helps to meet some of the complex challenges we're facing in the homeless response system, that would be very beneficial.
Thank you, Sarah. And there's a lot to process, and appreciate your thoughtful testimony. We've heard the same thing that you've heard, that the CHESS program, while promising, has not lived up to that promise necessarily, and that there are ways that we can make it work better. We don't need to necessarily study something for the sake of studying it. If you have clear ideas about what we need to do this year that we could potentially work with our friends in the Housing Committee on appropriations to move forward, those suggestions could be helpful. Yeah, I will. If that's helpful. I think one of the challenges, though, I think we've experienced maybe as an appropriator is some of the siloing that we have, just in terms of appropriation subcommittees and how we can make sure that that different agencies are talking to one another. But if you have specific, to the extent that you have specific suggestions about what we could do immediately, I don't think that's necessarily off the table.
I mean, that interagency collaboration, which we're really fighting for with the Interagency Council, including providers at that table, which is the national best practice, so that all agencies and partners sit together and really have true conversations about how to have impact together and on our efforts to end homelessness. So that's one piece of it. But, you know, really looking at from the provider perspective, what the reimbursement rates are and what it means to actually run this program as a homeless response provider. I think it sort of the unintended consequence of CHESS was that it put a really large onus on our service providers that they were not accounting for. And so you have like really high caseloads and you have, and they don't, and also the rates of reimbursement were so low that it didn't actually provide for some of the, you know, for some of the finance and operation administrative costs that providers needed to do to sort of roll this out. And so it took away from the impact. So when I talk to providers, they're very stressed about this program because it offered such a huge amount of resources. And this is a loss of capacity in terms of our housing for the state. We know that increasing so we're in a really hard housing market. And so having a traditional model where you're seeking just vouchers can be really limiting. So how do we move towards greater flexibility in that? So is it flexible assistance? Is it, you know, are there other ways to think about this resources that can keep people housed and stable if they are, you know, if they're prioritized for this funding, if they have any other options, if they were to bring more resources into another family household? You know, are there other ways to think through this programmatically to make sure that people can access stable housing?
Thank you. Specifically with regard to your first suggestion about raising the Medicaid reimbursement rates, do you have a specific proposal that you would ask for?
I do not, but I can come back to you quickly on that.
Could you do that extraordinarily quickly?
I mean, I can,
24 hours?
I'm not going to make it any promise. I will say yes. Yes, I will.
Okay.
I will.
That would be, I'm not saying that anything happens in the next few days in this building, but it just might. So if you could do that,
Okay.
that would be helpful.
And I wasn't trying to.
Thank you. Okay, great. Thank you. Any other questions? Representative Hughes.
Thank you. Thank you so much, Sarah, for this comprehensive testimony. Currently, is care management covered in the Medicaid reimbursement rate? You talked about acuity of a lot of your folks that you're seeing. They're basically have complex needs in the CHESS. I'm specifically talking about in the CHESS program.
So you mean like case management?
Yes.
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 So components of it are, but is not adequately funded.
And assessment?
And so on the program level, I will also get you more information.
Okay.
Because I have the provider feedback. I'm not an expert in the administration of the program.
Okay. Yeah, that would be helpful because I think, you know, we're blunt in sort of trying to throw some resources without actually understanding the implementation costs and the rollout costs. And you raised some really good points about the timeliness. It sounds like we're trying to update to the crisis that we're having, especially in the tight housing market. And, you know, we're throwing some other resources towards mental health, which is escalated. And yet this is like so foundational to addressing some acute mental health needs. So.
Well, I couldn't agree with you more. And I think one of our recommendations is that housing be considered within this a key social determinant of health, which it very much is.
Thank you. We look forward to your specific solution-based input.
Thank you.
Thank you, Representative. Any other questions? Okay, we're going to let Sarah go and work on her math, but thank you very much. Next up, we have Patrick Turek, followed by Peaches Quinn.
Good afternoon, distinguished members of the Human Service Committee. Good afternoon, distinguished members of the Human Services Committee. My name is Patrick Turek, and I serve as Hartford Healthcare's Senior System Director for Public Safety, Security, and Emergency Management, where it's my role and passion to partner with and empower 41,000 colleagues and leaders of our organization to be safer and more prepared for safety, security, and emergency events. I want to thank you for the opportunity to testify in support of Senate Bill 365, an act concerning safety in the healthcare workforce. Each day, Hartford Healthcare cares for thousands of patients in different environments, including hospitals, home care, doctors' offices, behavioral health, physical rehabilitation, among many others. Safety is an absolute core value of our organization. And in recent years, the escalating environment, threats, and physical violence in healthcare has grown to absolutely unacceptable levels. In response to these mounting concerns, we are providing new tools and resources to our colleagues in organization. I'd like to tell you briefly about those. First, our commitment to Hartford Healthcare's mutual care and mutual respect, a concept that's gained national attention within healthcare, where we believe there is a shared responsibility of safety amongst our care team, patients, and our patients' family members. We have an expectation of ourselves to deliver high quality care for our patients, but that treatment can only happen in an environment free from behaviors that may distract us from that. We focus on communicating clearly, understanding different points of view, reducing friction points, and in unlikely events, hopefully using active de-escalation skills. Second, Hartford Healthcare has convened an organizational-wide workplace safety initiative led by executive leaders and across multiple disciplines. Some of our core work includes updating policies and procedures, implementing standard work in event reporting and follow-up review, providing safety training in multiple formats for our colleagues, providing well-being resources after events occur, and implementing other best practices. Next, as a part of Hartford Healthcare's Public Safety and Security Department, which consists of leaders and nearly 300 public safety officers across our campuses with specific expertise in the work, they serve as guardians to our community colleagues and campuses. We continue to invest in our security program and are considering many other options. Finally, we're making specific advances in home care safety, and we're fortunate to have added additional layer of protection for our home care colleagues, including pre-visit safety assessments, home care specific training, purchasing and deploying mobile duress, panic, and other technologies, and even a risk assessment matrix to make sure that we adequately address any risks one of our colleagues going into the home. We are so encouraged by the ongoing conversations across our industry and then within the Connecticut General Assembly. While Hartford Healthcare supports the provisions of SB 365, we do want to raise some points for your consideration.
Can you do so briefly because your time has expired?
Yes, sir. If you could please align current language with Public Act 11-175 about workplace safety committees, policies and plans, and risk assessments. And then also finally, last point, if you could please consider referencing a singular or reducing the combination of accrediting bodies, federal agencies, or similar organizations that have methodologies that are similar, dissimilar, may change, where we fear focusing on those specific agencies may be problematic. Or adding or codifying those requirements directly into the legislation. We're proud of the work we've done. There's so much more work to do, and appreciate your support in this work and your consideration.
Thank you for your testimony. Are there questions or comments from members of the committee? Seeing none, thank you for being here with us this afternoon. Next, we have Peaches Quinn, followed by Jeff Shaw.
Hello, everyone. Can you hear me?
Yes, we can.
Okay. Can you see me?
No, we can't.
Oh, I wonder. Okay, I won't waste your time. I have to find out how to do that, how to turn. I'll talk to Chandra. Maybe she can tell me. Good
She's driving
afternoon.
down right now.
I'm sorry?
She's driving down right now to help you out.
Right to New Haven. That's good. Good afternoon, everybody. My name is Peaches Quinn, and I'm here to give a shout out to Raised Bill 5454, an act concerning mental health services for young children and their caregivers. As you probably know at this point, the Connecticut Coalition on Aging, and I am board president for that coalition, is celebrating a 50-year anniversary this year. 50 years of public education and advocacy in the legislature on issues of importance to older adults. My reason for wanting to do a shout out on 5454 is I want to bring to your attention the number of grandparents who are in households with kids who need mental health services. The grandparent needs mental health services and could greatly benefit. In just under, as a matter of fact, 50% of households in urban areas in Connecticut, there are young kids living below standard conditions. And in more than half of those, there is a grandparent who is living in or heavily dependent on for caregiving. 40% or more are over the age of 60. In fact, I was raised by a grandparent, I'm happy to say, a wonderful grandparent. She was 64 years old when she took me in, and I was 5. Some are great-grandparents, as a matter of fact. They may be caring for a third generation. Most do not have guardianship, and that's a point I wanted to make. There are many reasons why they choose not to become legal guardians, but they are steadfast and constant in their families. Almost a quarter live in poverty, and they and their young kids grandchildren have experienced one or more forms of trauma. And you often hear from Alice Forrester from the Clifford Beers Clinic, who has done a lot with those kids and the whole issue of trauma in urban areas. That trauma can take the form, and I'll wrap up, of addiction, which was happening in my family. It could be neglect, abuse. That was also happening in my family. A parent might be in jail. Eviction might have occurred. It goes on and on and on. But grandparents are not often thought about enough when it comes to the benefit and impact of these resources. So this is a bill that will give much needed help to all those grandparents out there who stay in the game day after day after day and make such a huge difference. Thank you all.
Thank you, Peaches. Thank you for testimony. Are there questions or comments from members of the committee? Seeing none, have a good afternoon.
You as well.
Next, we have Jeff Shaw, followed by Rosanna Ferraro.
Good afternoon, Senator Lesser, Representative Gilchrist, Senator Seminara, and members of the committee. My name is Jeff Shaw, Senior Public Policy Advisor at the Alliance. The Alliance is the statewide association of community nonprofits. The Alliance supports House Bill 5458 and that concerning homelessness, and I'd like to align my comments to improve the proposal with that of Sarah Fox and others that you heard from earlier today. While we support the bill for the effort to improve the experience for clients and nonprofit providers participating in CHESS, there are key amendments the committee should consider to ensure the effectiveness of the program. First, as you heard, more time is needed to generate the comprehensive report of utilization metrics, program improvement processes, consideration of additional Medicaid waivers with the timeline for state plan amendments. The October 1st, 2024 deadline is too soon. Additional time would allow enough time to initiate a survey, analyze results, and issue a report. Additionally, the comprehensive study would be best done by an objective party, consultant via RFP. Along with conducting a survey, analyzing the results, writing a report, the consultant could also include a multi-year strategic plan to find additional providers and grow the program. The CHESS evaluation process must ensure robust participation from people in the CHESS program, as well as those eligible but not yet participating. Similarly, nonprofit providers, both those who participated and those did not, should be surveyed. It will take time to identify both groups. Regarding providers, the low Medicaid reimbursement rate and the related and sometimes complicated billing process was a common reason cited by some nonprofit providers that chose not to participate. For example, nonprofit providers need bridge funding upfront to cover startup costs like upgrading financial systems, Medicaid billing training for finance staff, as well as hiring costs for caseworkers actually providing the newly billable Medicaid services. The ongoing workforce challenges makes hiring no easy task, but bridge funding could help. Further, because clients in CHESS self-select where to receive services, nonprofit providers are unable to anticipate demand. That uncertainty ties back directly to hiring decisions, which ties back to the upfront costs of deciding whether or not to participate as a CHESS provider. Bridge or upfront funding needs to be part of the CHESS program model to ensure nonprofit providers have the resources to set up and operate the program effectively and reach people in need. Thank you for the opportunity to testify today.
Thank you, Jeff. Good to see you. Questions, comments from members of the committee? Yes, Representative Hughes.
Thank you, Jeff. Do you have any estimate of what that bridge funding might look like for the nonprofit providers that are participating?
I'm gonna have to get that calculator and meet with Sarah outside. So I can get back to you, but yeah, I wouldn't want to give you a false number.
We've got arm garters and eye shades and the whole, Representative Cummings.
Hi, thank you for your testimony. Okay, will you be able to send it in? I don't see it.
Yes, I will as soon as I.
It's extensive.
Yes,
Okay,
absolutely.
thank you.
Yep, thank you.
Thank you, Representative Comey. Any other questions, comments from members of the committee? If not, thank you for being here this afternoon. Next up, we have Rosanna Ferraro, followed by Charles Bell. Hello.
I had to change my testimony a little bit in light of what the Connecticut Hospital Association said earlier. Hello, Senator Lesser, Representative Gilchrist, and the rest of the members of the committee. I'm Rosanna Garcia Ferraro. I am Program Lead for Health Justice Policy Advocacy at Universal Healthcare Foundation, and I'm here to support Senate Bill 395. We feel it aligns with our mission for health justice, as well as the recently voted out of committee HB 5320 out of public health around hospital financial assistance. I was really glad to hear that the Connecticut Hospital Association is interested in moving forward with this proposal. I just did have some questions in light of that development. So just to clarify, and I'm not asking for y'all to answer the question. I just wanted to bring them up. What recourse would patients have if their medical debt did show up on a credit report? This may be a question for Mr. Bell, who is following me, but is there anything we can do to remove medical debt that is already on credit reports? How can we make sure that folks know that it shouldn't be reported anymore if this does in fact pass? And while CHA represents the hospitals in this state, but there are other healthcare providers. I know most of the big bills come from the hospitals and the health systems, but it might be helpful to future-proof this policy because we really don't know where healthcare may go. And just how can we just check in on this commitment that CHA made and just make sure that it's moving forward as intended? I just want to also briefly mention SB 313, which is about continuous Husky eligibility for children ages 6 and under. Just that we absolutely support this. We see it as common sense policy that reduces administrative burden on DSS and it ensures health coverage for young children. That is all I wanted to mention today. Thank you. I realize I'm number 53 of 57, so I'll stop there.
We've been told it's nice outside, but we don't really know that for sure.
It is
No
nice
evidence.
outside.
Okay, it is?
It is.
All right, well, we will move quickly. Other questions from members of the committee? Representative Hughes.
Thank you so much, and thank you, Rosanna. Did you see DSS Commissioner's testimony about the cost of raising bill continuous Medicaid eligibility for children under 6, SB 313?
I did not. I did not get a chance to review it before speaking on it here today. I do think, I'm certain that it's probably it costs some money, but I also think that the health of our young children is sort of priceless. So
they came to a figure, estimated figure of 57 million. And I was wondering if Universal Healthcare Foundation could come up with their own estimate of what that continuous Medicaid eligibility might look like for continuous enrollment.
So I am clearly putting on the visor and the calculator as well, but I can actually get back to you all on that. And I'll include it in written testimony on 313 because my gut tells me that's high, but I am not.
Our guts tell
100
us that's high too, but again, can you send that to the clerk so that they can get that out to
Absolutely.
us?
I'll make
That'd
sure
be
it gets
great.
to Chandra.
And-
Absolutely.
And also, I just appreciate your questions, because one of the questions that I realize that I have in the back of my mind is, doesn't hospitals sell medical debt to debt collectors? And if they don't, would they continue to do that, or, where would that profit go to?
I think that's an excellent question. I think from my understanding, and Mr. Bell, who's right after me, might know the answer, have a better answer for how this has been implemented in New York and Colorado.
Okay.
But I will say that I think the idea is that it would never be sent to collections in the first place, and it wouldn't be sold. So my understanding is that most debt is sold for pennies on the dollar.
Right.
So I'm not sure that maybe there isn't, maybe there's just not a lot of profit there, and it just doesn't make sense to continue to do that. I really am not sure.
Yeah, that's okay. I just wanted to put it on the record that that's a outstanding question.
Yes,
Thank you.
I agree.
All right. Thank you, Mr. Chair.
Thank you all.
Yeah, no, I do want to, I think that is clearly in the bill, actually, is that there's no prohibition on selling or on hiring a debt collector, but there would be a provision that a collection agency not report it to a credit rating agency. So you can certainly, there's nothing in the bill that would prohibit hiring a collector. Whether or not you could sell it or assign it, I don't think there's that's a good question. And there is a section on line 2334 that says any portion of a medical debt that is reported to a credit rating agency shall be void. So I think that would invalid. I read that. I'm not a lawyer. There are lawyers in the room who will, I'm sure, opine, but void, I would think, is void. That's my layman understanding, but I don't know. So thank you, Representative Hughes. Thank you, Rosanna.
Absolutely. Thank you so much for your
Next,
time.
we have Charles Bell, followed by Matt Barrett. Someone, 500 years from now will look for their legislative intent. And we just had a conversation about that. Hello.
Hello, good afternoon, Chairman Lesser, Representative Gilchrist, Senator Seminara, members of the committee. My name is Charles Bell. I'm a financial policy advocate at Consumer Reports based in Yonkers, New York. We really wanted to thank you for introducing and considering SB 395 to ban the reporting of medical debt to credit bureaus. We worked on a similar bill in the state of New York that was passed last year and signed by Governor Hochul. We think this is an incredibly important protection for consumers. Credit reports were developed for credit granting purposes to assess the creditworthiness of customers for financial products such as credit cards, car loans, mortgages, and consumer loans. And over the years, they've experienced some mission creep into other areas of the economy. But one of the most concerning is into the area of medical services and medical debt. Medical debt has a special character because nobody voluntarily seeks to incur large amounts of medical debt. And healthcare is essential, vital for people, and sometimes it's a matter of life and death. Some of us, over the course of our lifetimes, will run up really large medical bills that are hard to pay off. But what the National Financial Regulator, the Consumer Financial Protection Bureau, has found is that medical debt is not a great predictor of a consumer's ability to pay off their other financial obligations. And there are a couple reasons for that. One of them is that people are incentivized to pay off medical debt, and many people scrimp on other household necessities, including food, groceries, and medicine, to pay off that debt, and that's a burden the whole country is suffering under. We have 100 million people with about $195 billion in medical debt, so this is a full-blown crisis. But the other reason is there's a lot of inaccurate information that goes into credit reports. And because of the complex medical billing system we have, a lot of bills get sent to collections that were actually paid by insurance. And then it's extremely difficult for consumers to correct that information once it goes in there. So for all those reasons, we think that consumers should be protected from not having medical debts sent to the credit bureau. Hospitals and other providers that have debts, they still are free to collect that debt, but they should not be contracting with debt collectors who use it as a coercive tool to force consumers to pay up. And as we heard earlier from Jessica Elizondo's story, and I think there's tens of thousands of other stories like that, people who get ill or have an accident, who pay off their debts diligently, nevertheless have their credit harmed. It makes operating the economy much more expensive. You can jack up your insurance by as much as $1,800 in Connecticut if you have poor credit. Your auto insurance can be way more expensive. You could be denied an apartment or denied a job. And when we're trying to help people get back in recovery and back to jobs and school, it doesn't make sense to impose all this collateral damage on consumers. So this is what New York and Colorado have already decided. There's bills pending about 7 or 8 other states. We really strongly support this one and urge you to please approve it in this session.
Thank you, Mr. Bell, for driving up from Yonkers and for sharing your testimony with us. We've discussed what the Hospital Association has said they'll do in response and their support of this measure, which is certainly welcome. They did ask, and I think it's important to say that we remove the penalties associated with noncompliance. So that would be their pound of flesh. Do you think that that's reasonable? And do you think, are there any other questions that we should be asking of them about what that would look like moving forward?
Well, I'm sorry, are they asking that the penalty of voiding the debt be removed?
No. So the bill that we introduced said that we would reduce Medicaid payments if they don't do this. And they're saying, please don't do that to us.
Well,
which, I
yeah.
understand.
I think this is such an important protection for consumers. I think there should be penalties if you don't comply. So I think I do disagree with them on that point. However, voiding the debt is a very strong penalty, and it's a big disincentive not to report it. In New York, there were specific provisions that also directed the hospitals that when they contract with debt collectors, to instruct them not to report, so that it was more explicit in the contracts that they have. But I think your bill would work as well. It's pretty clear, and you have it clearly stated there. So yes, it's if debt is mistakenly reported, as half of consumers get so frustrated dealing with the credit bureaus, they just give up. They can't get stuff removed, and so it's unfair to customers when that happens.
Great. Representative Fortier.
I just had a question. I'm not sure our speaker could answer it, but maybe you can, Senator Lesser. What happens about debt that is currently on a credit report if this passes? Medical debt. I'm just wondering if there's anything, only because I haven't read it all. I'll admit, just because those people would continue to be penalized for that in not able to find a rent. And I understand that's not something really the hospital can do anything about. It would have to be directed to the credit reporting agencies.
Yeah.
I mean, that might be something for a future session, but I'm just asking.
It's a really good question, and you and I should have a conversation and pull a lawyer who can actually give us legal advice.
All right.
As things stand today, it would come off after 7 years, right? So from the point that it was reported. So that's a long time for people to wait. I think it would be reasonable if these bills continue to pass in the states to talk to the credit bureaus and ask them how they might remediate this situation for customers or for patients. And eventually the national CFPB is going to do a rulemaking that would apply to all 50 states, but I don't think you should wait for that because that might take 3 or 4 years to be completed.
Great. Representative Houston, do you have a question?
Just one from your reporting on other states. Is there any kind of measurable boost to the economy that we can refer to? I mean, I believe there will be, but that would be an important metric to sort of,
Yeah, I think
consider?
that's a great question. We don't have that, although something just came out today about the benefits of lowering credit card late fees that shows like a huge benefit to many businesses and consumers alike. So I think it stands to reason. I told a story in my testimony about a tow truck driver who unfortunately had to have his leg amputated because he had diabetes, and then it ruined his credit. He could no longer borrow to get the tow trucks. And his business collapsed and he was unable to continue to operate his towing business. So that's just one example in sort of the microeconomy. But if you think of that writ large, if we make it more affordable for people to recover from illness and injury and get back to work, it only stands to reason would have a big economic multiplier effect. But if we get any data, I'll definitely send it in your direction.
Thank you so much.
Thank you, Representative. Other questions? No questions. We are good. Thank you.
Thank you
so
so
much. Next, we have Matt Barrett, followed by Mag Morelli. We were trying to figure out if we could make them testify together, but we can't figure out how to do that. One is in person and the other is virtual.
Good afternoon, Senator Lesser and Representative Gilchrist and members of the Human Services Committee. My name is Matt Barrett. I'm the president and CEO of the Connecticut Association of Healthcare Facilities. And I'm pleased to have the opportunity to testify in support of Senate Bill 365, an act concerning safety in the healthcare workforce. And I would like to express my sorrow and regret about the circumstances that have led the Human Services Committee once more to put their focus and attention on issues related to healthcare workforce safety. I've submitted testimony, and so with your permission, I'll just move forward to summarize that we do support the provisions in Section 1 of the bill that apply to Connecticut nursing homes. However, we're recommending substitute language that connects these provisions to an existing and strong body of Connecticut law that has since 2011. That was enabling legislation, Public Act 11-175, that set forth workforce violence prevention standards that apply to nursing homes and a range of other providers. And those provisions were amended or expanded under Public Act 1591 to require providers to annually submit reports on workplace violence incidences occurring during the immediately preceding calendar year. And these provisions are now codified under Section 19A 490Q of the General Statutes. And I'm going into that level of detail because I did want to emphasize that our recommended substitute language, Senator Lesser, tracks verbatim the language from 19A 490Q and sort of links it to the provisions in Section 1 that are now assigned solely to the JCAHO or Joint Commission recommended standards. And so we think adopting specifically on line 8 after the word hospitals, we would recommend adding or issued by any government agency, including the Occupational Safety and Health Administration, OSHA, the Federal Centers for Medicare and Medicaid Services, CMS, the Department of Public Health, and the Department of Labor, and any hospital accrediting organization. Similarly, on line 13, a conforming amendment or substitute would also should be included. That includes that very same language. And I really thank you for your consideration this afternoon, and I'd be happy to answer any questions that you may have.
Perfectly timed. You've done this before. Any questions or comments from members of the committee? If not, we will take a close look at that suggestion, and thank you very much.
Thank you.
Next up, Mag Morelli, followed by Chris Herb.
Thank you, Senator Lesser, Representative Gilchrist, members of the committee. My name is Mag Morelli, and I'm the president of Leading Age Connecticut, a statewide membership association representing the not-for-profit provider organizations serving older adults across the continuum of aging services. On behalf of Leading Age Connecticut, I'm pleased to testify in support of 2 bills before you today. First, House Bill 5457, the bill related to the nursing home waiting list laws. We would like to thank the committee for raising this bill, which reflects an agreement reached by the Nursing Home Waiting List Working Group. The bill would update the administrative process currently required to maintain the nursing home waiting list. As background, Connecticut's waiting list law applies to nursing homes that participate in the Medicaid program and prohibits discrimination against nursing home applicants who are eligible for or who are receiving Medicaid. Connecticut's waiting list law has been in place for decades, and the requirements associated they're outdated. For instance, we're required to maintain the waiting list in a paper-bound book. We brought our concerns to you last year and you listened. You asked for a working group be established to consider necessary revisions, and that working group was established, and it included the long-term care ombudsman and the applicable state agencies. And the bill before you today is the result of that group's collaborative efforts. We urge your support of the bill, which would benefit both the nursing home and the potential residents who are seeking placement. And again, thank you for raising this bill. On Senate Bill 365, the Act Concerning Safety in the Workplace. Again, Leading Age Connecticut appreciates your efforts to address the issue of workplace violence and healthcare workforce safety statutes as proposed in this bill. We offer our assistance to the committee as you consider the elements of the bill, and we've submitted some suggestions regarding the proposal that's in our submitted testimony. Similar to the testimony you just heard, regarding the bill that was passed in 2011, an act concerning workplace violence prevention and response in healthcare settings. It requires certain healthcare employers to develop and implement workplace violence prevention and response plans, and several other requirements. We too, in our suggestions, request that you consider this bill and make the current bill consistent with that statute, particularly when it comes to the JCAHO standards or the Joint Commission standards that you're asking the nursing homes to comply with. It also should be noted that the current law, as well as this proposed law, does not address the non-medical home care and homemaker companion agencies that are registered with the Department of Consumer Protection. And then finally, we just want to thank the committee for proposing the reinstatement of a payment of a safety escort, and would recommend extending this reimbursement option to other providers who send home care staff into the home. We thank you for this opportunity to testify on the two bills, and we would be happy to answer any questions.
Thank you for testimony. Any questions? Yes, Representative Hughes.
You said that it doesn't refer to the non-medical home care staff in which bill are we talking about?
Right, in 365?
Yeah.
Right, it doesn't.
Okay. So we'd need to broaden the workforce safety definition as well as defining the workplace. Is that
right?
your
It includes the
testimony?
the home health care agencies that are licensed by the Department of Public Health, and some of those agencies have home health aides, but the majority of the homemaker companion agencies are registered over at the Department of Consumer Protection. And neither the current law that was passed in 2011 or this proposal would address that segment of the sector.
Okay, thank you for that clarification. I think that's important that they are included, since they're also the risk is
Right.
about the same, going into a patient's home.
Going into patients'
Actually,
homes.
probably going more often
Right.
to the homes.
Right, than the nurses. Thank you. Okay, thank you.
Thank you, Representative. Next, does look like anybody has any questions. Thank you, Mag. Get out of here. Thank you. Chris Herb.
Good afternoon. My name is Chris Herb. I'm the president of the Connecticut Energy Marketers Association. I'm here to testify on House Bill 5426. SEMA represents 600 energy marketers who sell bioheat fuel, propane, HVAC services to over half the homes in the state. First, about the program, we've always considered DSS a partner in this program, along with the community action agencies. But right now we're feeling unequal, underappreciated, and unheard. Our members increasingly feel disconnected from this process, thoughting that change would come to the program. And because of the work that we did with you last year specifically, that the Department of Social Services agreed to, word for word, we sat and looked at each other in the eye under your supervision, and we came up with a bill. That bill made a number of changes that were intended to ensure that there was adequate participation so that every person eligible for energy assistance is served. And thankfully, that is occurring today. but it's not occurring because they have a number of options to do business with. They're down to the bare bones minimum people who will participate in the program. The reason why I didn't start off saying we support the bill is because we've heard over and over again since last year from the deputy commissioner that they don't interpret the law the same way as we do. The black letter of the law is not a matter of interpretation. It specifically prescribes two things that they did not execute, which was basing the price of fuel on the day of the delivery and to create a regional pricing mechanism. While there were questions that were raised early on in the process about what's the difference between the law about county pricing and regional pricing, we explained what those were. They're clear in the statute, they're clear in the plan, yet they refused to continue to do it, saying that they interpreted that those were the same thing. Our members didn't even want me to testify today. They said, you know what? It doesn't matter if the law changes. DSS is going to do what it wants to do regardless. And I told them that we've been working with good people who have every intent on making sure that they follow through on what the law says. You are co-equal branches of government. The executive branch does not get to tell the legislative branch which laws they want to execute and which ones they don't. So I do appreciate this bill. I appreciate what you're attempting to do. Unfortunately, we've lost faith in the process, not because of you, but because of DSS's actions. We do want to see this bill move forward. We want to continue in this conversation. I want to make sure that if market conditions change in the future, that we continue to have adequate and vibrant participation, that every person is served and that we are equal partners with them. Thank you for your attention. If you have any questions, I'd be happy to answer them.
Thank you, Chris. I can understand your frustration and appreciate your testimony this afternoon. Other questions, members of the committee? Seeing none, thank you. And that concludes our public hearing of the list of people we have signed up to testify this afternoon. We will not entertain any other people. So that is the last public hearing for this year from the Human Services Committee. We anticipate being back on Tuesday for a joint hearing with appropriations. We also anticipate having a committee meeting that same day. So you will be here for a goodly portion of the day, I expect. So have a wonderful weekend. We will see you on Tuesday.